give generic advices like eat healthy. We can see that you can eat specific foods, they may be green for you. Exercise more. Some people may benefit from just 5,000 steps, some people may need 11,000 steps. Some people may benefit by a morning exercise, some people may benefit from afternoon exercise. Some people might just need 6 hours of sleep, some people may need 10 hours of sleep. So obviously, the individualization to scale, AI can micro map it, and we can actually predict physical CGM by actually using AI. And we did RCT, just like the direct trial showed around 50% remission using AI. We could improve that remission rate to, and we have a 3-year RCT now, and it's replicated in the Cleveland Clinic. We published that data in New England Journal last year, clearly showing that you can remit up to 75%. And we presented it at ADA a couple of years back. This was our paper in endocrine practice, and we showed that in multiple subsets, we were able to achieve remission. In fact, even hypertension remission in diabetes was possible. In fact, in the Journal of American College of Cardiology, there was editorial written on it, and I and Dr. Parmesh Sammanna were co-authors on that, and we could actually reverse a lot of that paper. In fact, we could even reverse PCOS, and we could do that. So clearly, precision diabetes is here to stay, and remission is a doable entity. We can actually use sensor readings, member logs, blood reports, machine learning, artificial intelligence, nutritional databases, and curate plans of nutrition, medication, and lifestyle by doctors, coaches, and mobile apps, and do that. But drugs can do the same. Drugs can very easily do the same. If you just get 10 to 15% of weight loss with a semaglutide or a tirzepatide, you can actually get diabetes remission. And that data is very clear cut with the dual agents and the triple agents, which that data which we saw at ADA just last week at New Orleans. Very clearly, we could see the retatrutide data is so compelling that it could even use that. Or if you see the CagriSema data, also it could show that very clearly. But remission is a fragile entity. Okay, direct at 5 years only was able to maintain remission almost 13% at year 5. So the lesson is induction of remission is achievable. Maintenance of remission is a therapeutic challenge. So we don't call relapse as a failure, but it remains that type 2 diabetes remains responsive to renewed weight intervention, pharmacotherapy, metabolic surgery, and repeated remission attempts. That's possible. Does remission improve hard outcomes? Why remission may matter beyond A1C? It does matter because remission will have lower medication burden, better blood pressure and lipids, reduced metabolic exposure, better quality of life, and possible reduction in renal and vascular risk. However, the prior glycemic exposure matters. And that is why the old dictum was hit hard, hit early. And we know that if complications ensue, then remission is difficult. But if you are able to hit hard, hit early and get a remission, it will lower risk. It may not erase the patient's metabolic history. Can pharmacotherapy induce drug-free remission? And the emerging strategy is to induce, consolidate, and withdraw. And I think if you see the data from tirzepatide, if you see the data from semaglutide, and if you see the latest data, phase 2, which was presented at ADA and in the Endocrine Society last week, where I was there in Chicago, I just came back day before yesterday, clearly it shows that these new agents, we are able to, through pharmacotherapy, get drug-free remission. So obviously with incretin therapy, we can make a difference and bridge this evidence gap. What about metabolic surgery? Well, I think they have the best data available. The surgeons have the best data long-term available for diabetes cure. The long-term randomized evidence from the ARMS type 2 diabetes trial showed surgery produced better glycemic control, lesser diabetes medications, higher remission rates, and benefits extending to at least a decade. But relapse can still occur there. It depends on the duration, it depends on the beta cell reserve, and so on and so forth. So obviously, we should offer everybody a remission strategy. It has to be a phenotype-based approach. And we clearly recognize that recent onset type 2 diabetes, overweight, obese, substantial residual beta cell function, willingness to pursue weight loss, and access long-term maintenance and embrace technology are candidates for remission. So we have to discuss 3 pathways. If you do intensive dietary weight management, incretin-based pharmacotherapy or surgery. In all of them, this drug-free remission is possible. It may be powerful and scalable, but surgery probably has the best durability. But they all have limitations of weight regain, continued treatment, and produce procedural, nutritional, or relapse risk, which is there. Remember, we should never stop cardioprotective therapy. Even during glycemic remission, decision about statins, RAS blockers, and other therapies should be continued based on the overall risk. So, is it a hype or a hope? That's what Sunil wanted me to tell. Hope is already realized because drug free remission is possible. Remission can be achieved in routine clinical settings, and earlier and greater sustained weight loss increases success. Hype is to reject. Anyone can reverse diabetes. That's a hype. A single diabetic, diet cures diabetes. That's a hype. Normal A1C or medication equals cure. That's a hype. And remission means complications no longer require surveillance. That's also hype. So we should clearly separate hope and hype. So type 2 diabetes can enter remission, particularly early in the course, but sustained remission needs a lot of effort on the underlying metabolic drivers. My last point, which I want to talk, is would there be a cure for type 1 diabetes? Because Sunil is very passionate about it, and three problems must be solved simultaneously if we are looking at a cure for type 1 diabetes, and that is more in the reality of realm of hype than hope. But let's see the truths. We need to restore beta cell mass. So we need donor islets. Whole pancreas transplantation is possible. It costs around 4 to 8 crore rupees. Okay, stem cell derived islets are a reality, and endogenous regeneration is also a reality. But most of this footprint is in the experimental space. The hot topic today is prevention of immune destruction, control recurrent autoimmunity, prevent allogenic rejection, and establish immune tolerance or immune invisibility. That is very much doable. And finally, preserve the function safely, which means we need adequate vascularization, oxygen and nutrient supply, long-term glucose responsiveness, no teratoma or off-target tissue sites, and no toxic chronic immunosuppressions. So obviously you cannot have a near physiological control without restoring beta cell biology. Now AID is able to do all that, and a multi-center bionic pancreas trials demonstrated a sustained glycemic control across children and adults, but you need that. Why is it not a cure? Because you need exogenous insulin. Infusion failure can rapidly cause ketosis. Devices, consumables, and engagement is necessary and expensive, and autoimmunity and beta cell loss remains unchanged. So one thing is very clear, that a functional substitute for a part of pancreatic physiology is possible, but it's not a biological cure. We have a drug which now has actually got a FDA approval even in stage 3. Though this slide was made for stage 2, the US FDA is approved for stage 3. It's called teplizumab. It has changed the natural history of type 1 diabetes. In high-risk individuals with stage 3 or stage 2 type 1 diabetes, a single 14-day course delayed progression to clinical stage 3 disease. And this initial trial showed that approximately 2-year mean delay in diagnosis, and follow-up demonstrated a preservation and stabilization of beta cell function in responders. So we have an immunological therapy approved by the US FDA and EMEA, and on a compassionate ground, I'm told the drug is also available in India, but it's very expensive again. What teplizumab does not do is, it does not eliminate all autoreactive immunity, does not permanently prevent type 1 diabetes, does not restore lost beta cell mass in long-standing disease, and does not produce routine insulin independence. But it's the first successful US FDA disease modifying delay. Not a cure again, but it's there for us to stay. And then there's a host list of immunotherapy portfolio, whether it is anti-CD3 therapy, anti-CD20 therapy, abacavir, low dose thymosin, cytokine directed therapies, regulatory T cell strategies. And some of these interventions can preserve C-peptide for a period, especially if they are given early. But there are a lot of limitations because of heterogeneity, toxicity, tolerance, and so on and so forth. The future is all about immune modulation with beta cell replacement or regeneration. That's where type 1 diabetes is moving very quickly. And therefore, we need to understand that donor islets and pancreatic transplantation cure is looking biologically possible. And insulin independence also looks biologically feasible. So whole pancreas or decreased donor islet transplantation can provide endogenous C-peptide, glucose responsive insulin secretion, protection from severe hypoglycemia, insulin independence in selected patients. Why this is not a cure for type 1 diabetes at a population scale? It's not scalable. Limited organ supply, procedural risk, progressive graft attrition, alloimmune rejection, recurrent autoimmunity, and lifelong immunosuppression. But in selected people, particularly with recurrent severe hypoglycemia, impaired hypoglycemic unawareness, unstable brittle diabetes despite of optimal technology, or concurrent kidney transplantation, we can look at this for type 1 diabetic population. We also have the Zimi cell, which is an allogenic stem cell derived, fully differentiated islet, for which also data is available, where beta cell replacement is becoming more and more credible. Again, why this is not a cure? Because of small cohort, short-term follow-up, portal vein infusion, chronic systemic immunosuppression. So beta cell supply may be a solvable, but immune protection remains a bottleneck here. Clearly, we can see that a striking single patient result was published, and a lot of patients walked up to me. In 2024, a chemically induced pluripotent stem cell derived islet was transplanted beneath the abdominal rectus sheath in one patient with type 1 diabetes. And it reported an outcome where insulin independence was beginning for 75 days after transplantation. Time in range was around 43%, going right up to 96%. A1C was below 5% and sustained function throughout a year. And a lot of patients got this printout, newspapers, social media came out to us, and it's there. There were limitations. It's a proof of concept. This was a patient who had undergone a liver transplantation, was receiving immunosuppression. Autologous manufacturing is complex and costly, and recurrent autoimmunity remains biologically relevant. So obviously this is a very extraordinary proof of feasibility, but does not have evidence of generalizability. So we do have such case reports which are there in public literature. Can gene editing remove immunosuppression? Because immunoinvasive allogenic islets are a pivotal frontier. And in 2025, we again had first in human report which describes a genetically modified donor islet transplanted in the forearm muscle without systemic immunosuppression. And in 12 weeks, we saw that there was no detectable immune response against the edited cells. Very stable C-peptide secretion and no serious treatment adverse events. But again, a single participant, and therefore it's the first in kind of a human signal that a transplanted beta cell can survive without systemic immunosuppression. But the therapeutic scale is unproven. So again, scalability becomes a challenge, but it's all feasible now. In human beings, we are able to do it. So what has changed by June 2026 as we talk? Well, what is established today is type 2 diabetes remission is a legitimate treatment goal, and that's possible. Stem cell derived islets can restore clinically meaningful insulin secretion. And immune engineering can produce short-term survival without systemic immunosuppression is in a human proof of concept stage. So these three things are established beyond reasonable doubt. But as I said, the second and third component still is investigational. The active areas of translational work are hypoimmune gene-edited cells, encapsulation and retrieval devices, alternative implantation sites, vascularized endocrine constructs, local immune modulation, biomaterials, antigen-specific immune tolerance. What is still not established is a durable multi-layer independence of insulin without immunosuppression, reliable protection from both autoimmunity or autoimmunity, large-scale manufacturing consistency, lifetime tumor or off-target safety is still not established, like a teratoma or a sarcoma. Affordability and equitable access is a challenge. So why beta cell replacement is alone insufficient? Because there is a hostile host problem also. Remember, whenever a transplanted cell will always encounter a hostile host, and we have a host myriad of challenges. Also, we need to have an unlimited beta cell source, and that's the big bugbear which is there. So when we look at an evidence ladder, where each strategy starts, in type 2 diabetes, weight loss intensive RCT 5-year data, durability is variable, treatment independence is possible in response, and the 2026 judgment is clinical remission is doable, direct data and various other data supports it. So that strategy clearly works. As far as metabolic surgery is concerned, RCT long-term data, highest in type 2 diabetes durability, Treatment independence is often but not always, it's a good hope. And we will get a lot of that coming up very quickly. What about GLP-1 and GIP therapy? Large RCTs requires continuous therapy. The treatment independence is not there because you still need to take the GLP drug. It is a transformative treatment. AID, large RCTs are available, device has to be used, so you can't be treatment independent, but it's a technology substitute. Teplizumab, RCT and follow-up data available now. Stage 3 approval by FDA is also available. It delays onset. So it's a disease modifying therapy. Again, can be scalable if affordable. Donor islet and pancreas transplant, established select use, but durability is variable. Treatment independence is possible, but limited functional cure. Stem cell islets and immunosuppression, small phase 1, phase 2 trials, short-term evidence may be in some patients possible, but major in proof of concept stage. Gene edited with immune invasive cells, single patient evidence, weeks and months, not yet treatment independence. It's an early hope. Regenerative or in vivo gene therapy, mainly preclinical, both durability and treatment independence unknown, and it's more of a hypothesis generation. So that's the fact sheet as far as the cure is concerned. So we need to tell our people living with diabetes that we should give them hope without overpromising. For type 2 diabetes, remission is possible early in the disease and requires sustained, substantial weight loss and continuous monitoring. This is the truth, and I don't think we'll be hyping if we say that. In type 1 diabetes, however, we can now delay disease in select high risk individuals or replace beta cell function experimentally. Its widely available cure without immunosuppression is not yet established, so please don't give that hype. As far as media and policymakers are concerned, proof of concept is not population level cure. A scalable cure must be durable, safe, manufacturable, and accessible. And as of now, the answer is disappointing no, but there is a lot of hope. And we should never discourage hope from people. So, cure from diabetes, which what Sunil told me to talk, is it a hype or a hope? Type 2 diabetes, hope is realized, but call it remission. As far as type 1 diabetes is concerned, hope is transformed into proof of concept, but just now there is no routine care. That's the best answer I can give him for the question he posed to me yesterday late night when he told me that I have to do this talk. I also told one more thing, that there was a term which I coined in this meeting a couple of years back called digital detox. And we are all being so digitally intoxicated that if we make a transformative change, we have to modify lifestyle. We have to eat less, eat slowly, eat on time, eat right. We need to do physical activity. We need to sleep well, sleep on time, and smile. But we definitely need to do digital detox. And my final slide is that in type 2 diabetes, beyond prevention or delaying progression, remission now has entered that space. We definitely have a remission window in the type 2 diabetic space, and we should not ignore that window. This is a clinical reality. This is a scalable reality, particularly with CGM available. I think this is very doable. Thank you so much for a patient hearing.
Thank you, sir. Thank you, sir. Very excellent presentation. And presently there is no cure, but we will use the word remission only, not relapse also. Is it clear?
Thank you.
We will not take questions already. We are having the shortage of time. 7 minutes is good.
Thank you, sir, for wonderful session. I now request Dr. Ajay Yadav, sir, and Nalini Humne, ma'am, to please proceed for felicitation of Dr. Shashank Joshi, sir, in a felicitation terminal.
For the next flight, I would like to invite our captains, Dr. Gajala Siddiqui madam from Raipur and Dr. Kiran Belsare sir from Nagpur, to kindly have the seats on the captain seats. And as a pilot, we would like to have Dr. Siddharth Das sir from Cuttack. He will be enlightening us on diabetic kidney disease, glomerulopathy to tubulointerstitial disease. Welcome you, sir.
Don't waste time on introducing me.
Yeah.
I'm an old man.
Sir is having a
Known
very
to the
strong
audience.
CV. No need to tell all those things. Sir, please, over to you.
Thank you, Sunil, for this opportunity. After the marvelous presentation by Sasank, I think my theme, which I'll be taking up, may be less relevant. Anyhow, my talk is in tandem with Dr. Rakesh Rao who talked in the morning. So diabetic kidney disease, glomerulopathy to tubulointerstitial disease. Diabetes mellitus and nephropathy. Diabetes is a pervasive cause of end-stage renal disease, all of us know, and a major contributor to CKD. Nephropathy affects 10 to 30% of type 2 diabetics in the Western studies. And as the disease increases, the duration of diabetes increases, the prevalence of nephropathy also increases. And if you look at the last red letters, large number of such patients will never show levels of proteinuria above the traditional definition of overt diabetic nephropathy, that is more than 500 milligram per gram during their life course. This is the catch point, that we have high nephropathy, but we do not have albuminuria in all the cases. Well, looking at the Indian scenario, early work done in 1975 to 78 under registered WHO, we found as the duration of diabetes increases from 0 to 6 years, we found that 10 to 7% of males and 5 to 7% of females had diabetes, and is increased to 6 to 13 years, is a whooping of 23% of males and 13.6% of females showed nephropathy. Another study done at AIIMS New Delhi well back in almost same time, between 1966 to 86, you can see that the prevalence of nephropathy was very high. The ICMR study revealed that 15 to 4% females and 13 to 9% of males and females had nephropathy. This was published by Professor M.M. Ahuja, the founder of RSSDI long ago. Now, following the same method, ICMR conducted a study in 9 centers in India, and where we found, I was a part of that study long back, and we found that as you increase the duration of diabetes increase, the prevalence of nephropathy increases. The pioneering epidemiological work done by the Indian Society of Nephrology, they call the CKD registry, they found if you take all causes of CKD, diabetes contributed to 31.2%. So you can see almost 1/3 of patients with CKD in India, as found by the Indian Society of Nephrology, were patients suffering from diabetes mellitus. Now, in the past, diabetic nephropathy was referred to as Klimelstiel-Wilson disease, all of us know. This Klimelstiel-Wilson disease was a form of diabetic nephropathy due to nodular glomerulosclerosis. It arises from chronic, poorly controlled diabetic state, leading to a high blood glucose levels. These damage cause microvasculature in the glomerulus, accumulation of essential matrix within the glomerular capillaries. So it was a glomerulopathy, so nodular glomerulosclerosis. Next came classification of staging of diabetes given by Carl Erickson, and his book he published in 1994. And in this he found 2 differences. Then it was called as IDDM and NIDDM. If you look at the IDDM population as analyzed by Erickson in 1994, if you look at predictive power, relationship to pathophysiology, relations to structural damage associated with other vascular disease, microalbuminuria had a very strong prediction for type 1 diabetes, developing nephropathy, and so also was clinical proteinuria in IDDM or type 1 diabetes. Now, when Carl Erickson analyzed the data on NIDDM, or non-insulin dependent diabetes, now we call it type 2 diabetes, it has hence become clear that the codes of complications and implications of microalbuminuria differ in several subsets between the 2 types of diabetics. We found that microalbuminuria was not sine qua non of early diabetic nephropathy in type 2 diabetes, or NIDDM as it was called. So proteinuria, diabetic kidney disease, the paradox. Observations from prevalence of DKD in USA across 3 time windows extend up to 2014 substantially confirm these findings. 1, prevalence of albuminuria decreased progressively over time from 20.8% in 88-94 to 15.90% in 2009 to 14. In contrast, the prevalence of reduced EGFR increased from 9.2% to 14.1%. This was the paradox. Microalbuminuria reduced, but EGFR decreased. All of us know about the different studies in type 1 diabetes and type 2 diabetes done. The effect of glycemic control on proteinuria in diabetic population groups, whether DCCT or the DCCT addict or EQPDS or advanced, you can see that with good glycemic control, as the HbA1c comes down, microalbuminuria reduces, the burden of microalbuminuria reduces, but nephropathy doesn't reduce. Thus, diabetic kidney disease, from pathogenesis to multimodal therapy, current evidences and future directions were published in 2025. DKD develops through a constellation of interconnected pathophysiological processes. They are hemodynamic alterations, inflammation, and fibrotic remodeling. So these two things, hemodynamic alterations and inflammation and fibrotic modeling, were found to be having more relevance than only glycemic control. Persistent hyperglycemia activates a network of interrelated inflammatory pathways that contribute to sustained renal injury. One of the principal mechanisms involved was hyperglycemia-induced oxidative stress and a consequent formation of advanced glycation end products. Now, AGE, which in turn activate two key inflammatory cascades, the toll-like receptors, the MYD88 receptors, and nuclear factor kappa B pathway, which are pro-inflammatory pathways. And similarly, thyroxine interacting protein NOD-like receptors, pyrin dominant receptor, leading to inflammasome complexes. And looking at the hemodynamic factors, glomerular hypertension, RAS activation, inflammatory and pro-fibrotic factors. Thus, diabetic kidney disease is just not a story of hyperglycemia and microalbuminuria. It is a pro-inflammatory process going on in the kidney involving beyond the glomeruli. Growth factors, increase the levels of growth factors such as transforming growth factor beta or TGF beta and connective tissue growth factor CTGV promote endothelial ECM accumulation, extracellular matrix accumulation and fibrosis. Hypoxemia, impaired blood flow and increased oxygen consumption by the damaged cells can lead to renal hypoxemia. Thus, looking at what happens in a diabetic nephron, if you look at one, there is increased sodium chloride filtration along with glucose. It is obligatory with glucose and sodium chloride infiltration occurs. Then stage 2, increased sodium chloride reabsorption from the descending loop of Henle with glucose reabsorption. And coming to the ascending loop of Henle, there is decreased distal delivery of sodium chloride, which lead to vasoconstriction of the efferent, whereas there is vasodilatation of the afferent arterioles inside the glomeruli. So if you look at the efferent vasodilatation, afferent vasodilatation with efferent vasoconstriction. So glomerular and tubular damage, these interconnected pathways lead to thickening of the glomerular basement membrane, mesangial expansion and damage to tubular cells. Extracellular matrix accumulation and fibrosis leads to, especially with TGF beta, drive the excessive deposition of extracellular matrix proteins leading to kidney fibrosis. Structural changes besides glomerulosclerosis, there is interstitial fibrosis and tubular atrophy. On the whole, the loss of function, the structural changes ultimately lead to progressive decline in kidney function, potentially progressing to end-stage renal disease. The paradigm shift. Historical trends showing improvements in glycemic control over time in large database with the widespread use of antagonists for renin-angiotensin AC inhibitors and RAS inhibitors. As most of the previous speakers have shown, it has caused great benefit in type 2 diabetics and type 1 diabetics. There is a decrease in the prevalence of glomerular lesions, but an allowed emergence of other types of renal lesions affecting the interstitium and the vasculature. As alluded before, the paradigm that proteinuria is a necessary step in the course of CKD associated with type 2 diabetes, causing renal dysfunction and prognosis, has been reframed. Microalbuminuria in type 2 diabetes patients found to be a marker of generalized vascular endothelial dysfunction, and in different studies I showed with good glycemic control, microalbuminuria went on decreasing, so also microalbuminuria. A study from All India Institute in Delhi have shown that 17.5% of newly diagnosed diabetics with microalbuminuria had hypertension. Before they developed renal pathology due to diabetic complications, they had microalbuminuria because of uncontrolled hypertension. If you look at this cartoon, the first one you can say is normalbuminuria, microalbuminuria, and proteinuria. If you look at the reduction of GFR occurs much earlier in non-proteinuric phenotype than in the proteinuric phenotype. So the IDF and the International Society of Nephrology evaluated 30,000 type 2 diabetic patients from 33 countries and found that prevalence of normo, micro and macroalbuminuria was 51, 39 and 10% only, with racial variations. In the absence of proteinuria, a reduced GFR is observed in about 1 diabetic patient out of 5. Even at the onset when you diagnose them as to be type 2 diabetic. Proteinuria cannot be considered as the sole marker, though it still continues to be a marker, sole marker of diabetic nephropathy. Proteinuria in diabetics has to be seen as an indicator of glomerular lesions in diabetic patients with CKD. Proteinuria is a distinct feature of glomerulonephritis, so glomerulitis. It does not talk about beyond the glomerulus. The contribution of non-proteinuric nephropathies to the global ASKD burden is still poorly focused. Type 2 diabetics, non-proteinuric DKD is more frequent now proteinuric diabetic. However, substantial research efforts are still needed. ASKD is a biomechanisms pathways other than proteinuria has to be established. The risk factors which have been identified, hypertension other than hyperglycemia, chronic hyperglycemia, hypertension, obesity, and hyperserum triglyceride levels. I think our friend from Dr. Mahalke gave a lot of emphasis on hypertriglyceridemia. It's very correctly so. If we look at this cartoon, hypertension leads to tubulointerstitial inflammation. Overweight and obesity leads to alteration in the adipokines and secondary pro-inflammatory changes. Hypertriglyceridemia stimulates the alteration in the adipokines and secondary changes and also enhances insulin resistance. Glomerular filtration at single nephron level is individual nephrons. Now, we did a study long back on certain markers of atherosclerosis, including insulin resistance patients with chronic renal failure. What we found? Comparison of various parameters within 3 groups, non-diabetic CKD, diabetic CKD healthy controls. We found that insulin resistance, beta cell dysfunction, dyslipidemia, C-reactive protein, uric acid, and carotid intima thickness significantly higher among CKD patients than controls. And in diabetic subset, greater degree of insulin resistance, beta cell dysfunction, diabetic CKD, and then non-diabetic CKD. So resorption of albumin escapes the glomerular filtrate by the cubital mechanism complex in renal tubular cells, sets of motion nephrotoxic pathway. It activates the reactive oxygen species, stimulates the nuclear factor kappa B control cytokine cascade, upregulates different cytokines. So the biomarkers of microalbuminuria, albuminuria is limited to the glomerulus. Then there are a huge lot of markers. I'll just enumerate them in the tabular form. Interstitium, it is alpha-1 antitrypsin, TGB beta, and NT-proBNP, which is routinely done by most of us. Proximal tubule is KM1, and loop of Henle, osteopontin, and collecting diacoptin. Besides evaluation of available status expressed of nuclear factor kappa B can reflect regarding activity of cytokine cascade in chronic renal disease in diabetics. We did a study, association of nuclear factor gene polymorphism with inflammatory markers in patient type 2 diabetes with or without renal involvement. And we looked at the GFR, we looked at the UACR, we looked at the UMCP and TNF alpha. And you can see diabetics with nephropathy had higher levels of all of this, UACR, UCMP and TNF alpha compared to the type 2 diabetics and healthy controls. And you look at the gene polymorphism, then in the diabetic nephropathy group, insertion was found in 70%, which was less than 30% in healthy controls and all less than 50% diabetic without nephropathy. So we have to look not only at the microalbuminuria, but also at the other markers of chronic kidney disease, as well as the genetic build of the individual. So paradigm shift in understanding diabetic kidney disease, accumulating data suggests the proportion of CKD patients without proteinuria is substantially large. In a survey made in the framework of Third National Health and Nutrition Examination Survey, as many as 37% of patients with eGFR below 30 ml per minute 1.73 had no albuminuria. Among patients with type 2 diabetes with GFR less than 60, including 30% were normoalbuminuric. So microalbuminuria is no more sine qua non of diabetic kidney disease. Paradigm shift in understanding. Glomerulitis are proteinuric diseases. The incidence of rate of end-stage renal disease due to glomerulonephritis plateaued in 1990s and since then has declined because of glycemic control, because of use of ACE inhibitors and RAS inhibitors. Markers of interstitial involvement leading to non-proteinuric DKD has to be evaluated at an early stage. More exhaustive genetic study in different population groups will guide the future management, which I showed is only a pilot study. Thank you very much for the patient hearing.
Thank you so much, sir, for a very complex topic in brief with lots of studies and all. I'll ask one question only, then wind up this session because we are lacking of time. Sir, as per your opinion, whether is it accurate to classify diabetic kidney disease as glomerulopathy or primarily tubular disease, given that it causes proximal tubular hypertrophy and hypoxia from the day one of hyperglycemia? So, what is your take on this?
The take home is glomerulopathy is definitely and part of the diabetic kidney disease spectrum. It's a spectrum now. But you cannot ignore tubular interstitial disease and the pro-inflammatory burden on the kidney in patients with diabetic with the type 1, type 2, which leads to chronic kidney disease. So you may not categorize, but definitely you have to take care of the entire spectrum, starting with the glomerulus till the collecting tubules and the interstitium more so.
Okay, thank you, sir.
Thank you.
Treatment of tubular interstitial disease. What is the treatment of tubular interstitial disease?
The tricky question, sir. But you know, pharmaceutical products are now available. They are the antagonist are available. You can use them. They are the aldosterone, mineralocorticoid receptor antagonist can be used. But the experience in India is not wide, and there is no published data to prove that.
So again, how to find out tubular diseases early, like glomerular?
Yeah, I gave you the markers. You can look at the osteopontin is a very good marker. Osteopontin is commercially also available. Osteopontin is a very good marker. Yeah.
We are ending this session if there's no more question. Okay.
Thank you very much.
Thank you, sir.
Thank you.
I would like to request Dr. Siddharth Das, sir, to kindly join at the felicitation terminal, and Dr. Gajala Siddiqui, madam, and Dr. Kiran Belsare, sir. For the next, we would like to go for our next oration ceremony. For that, I would like to invite Dr. Sarita Bajaj, madam, Dr. S.N. Deshmukh, sir, and Dr. Bansi Sabu, sir, from Ahmedabad. For this oration, I would like to invite Dr. B.M. Makkar, sir, from New Delhi. Welcome, sir.
लो प्रोसीजर लो हाँ चलिए हाँ सर वो बिठा के करना सर कम मैडम ये मैं रिक्वेस्ट डॉक्टर A.K. दास सर एंड बंसी भाई oration so we have this Sushruta oration sir please take your seat बैठा के ये पीछे लगाएगा
It's a pleasure to read the citation for Dr. B.M. Makkar for the yeoman service in the field of medicine and an exemplary delivery of oration on Caramello, a comprehensive approach for type 2 diabetes from Nagpur, DCRC and DCGI proudly accedes to your benevolent service to people living with diabetes, obesity, and acknowledges your distinguished academic accomplishments. Your impeccable virtues and the humility with which you carry your towering repute serve as a source of inspiration to all. In recognition of your outstanding contributions and enduring impact, it is our profound honor to present you with this prestigious award, HDA Sushruta Oration 2026. Congratulations.
Good morning, friends. At the outset, I must thank the team of Hello Diabetes and, of course, my dear friend and younger brother Sunil for this great honor. I'm truly humbled to receive this oration named after Sushruta, who's one of the, I think, ancient times scientist that lived in India. He was the front runner of Indian modern medicine, surgeon, and also author of Sushruta Samhita. The times when we hardly understood, the field of biology and medicine, there was great work done by him. So receiving a oration named after such a legendary figure is actually truly humbling, and it's a great honor. So as mentioned, I will be speaking on Caramello, which is a comprehensive approach to type 2 diabetes management. I don't have any financial disclosures here, and I will be speaking all the text here is in relation to type 2 diabetes. So Caramello NAM, I picked up from a conference that myself and Bansi attended in Warsaw last year, and this was the Cardiovascular, Renal, Metabolic, Liver, and Obesity Conference. And I like the terminology, and I picked up that name because it conveys a very comprehensive approach to diabetes management. Now, we all know diabetes is, primarily defined by a level of hyperglycemia, which leads to increased risk of diabetes-specific micro and macrovascular complications, as well as compromised quality of life. And we know that from the DCCT trial and UKPDS trial that with every increase in glycemia, there is increased risk of microvascular as well as macrovascular complications. And with every percentage point reduction in A1C, there is significant reduction in microvascular complications as well as macrovascular complications. Not only that, early achievement of good glycemic control is associated with sustained benefit in people who had early glycemic control, and even the macrovascular complications are reduced in a significant manner. This we learned both from UKPDS follow-up and also DCCT follow-up studies, which showed that 30 years down the line, there was 30% reduction in any of the predefined CVD outcomes and first occurrence of MACE also. So all these trials showed us very clearly that there is significant evidence to support glycemic control as a primary goal for therapy for patients with type 1 and type 2 diabetes. And decreasing glycemia is effective means of reducing long-term complications. Not only that, achieving good glycemic control early in the course of disease is of paramount importance and is associated with something called legacy effect. So hyperglycemia should be treated aggressively and should be primary goal. Now, we also know that type 2 diabetes is caused by two core defects. One is the insulin resistance, which is static throughout the course of disease, and insulin deficiency caused by progressive failure of beta cell. And we know this from UKPDS that there is a progressive decline in beta cell function throughout the course of disease. But the whole story changed when Ralph DiFronzo presented the concept of ominous octet at ADA 2008, and he proposed that there are multiple mechanisms contributing to the causation of hyperglycemia, and also stated clearly that effective treatment of type 2 diabetes requires multiple drugs used in combination to correct the underlying multiple pathophysiological defects. So the whole concept of ominous octet became very, very prevalent, and now the numbers have increased to 11, and it is called egregious 11. But the important thing is, with this understanding, what changed? There were a number of new molecules which got introduced in the armamentarium of diabetes management. But despite all these introductions, the number of people achieving A1C target of 7% or less kept on declining, and number of people going above 9% were increasing. So there were more than 40 therapeutic options introduced during this period, but despite all, there was decline in percentage of people achieving 7% or less. Only about 50% people achieved the goal, and there was increase in people with very poor glycemic control, leading to an increased burden of morbidity, mortality, as well as economic impact on the healthcare systems. This was also followed up by trials looking at the cardiovascular outcomes with the newer molecules, and showed that we have DPP-4 inhibitors, which are cardiovascular neutral, but there was cardiovascular benefit seen with the SGLT2 inhibitors, and the trials with SGLT2 inhibitors showed that in people with diabetes, there is a significant cardiovascular risk reduction and mortality benefit with SGLT2 inhibitors. In addition, there was reduction in the risk of heart failure hospitalizations, and similar data came from the GLP-1 trials, whether it was LEADER, SUSTAIN 6, HARMONY, or REWIND. And all these trials showed again that there was significant benefit in terms of cardiovascular risk reduction and mortality, and also the kidney outcomes. So we started treating, the treatment strategy changed from the glucocentric approach to the glucocardiocentric approach. The interesting thing was the cardiovascular outcome studies that were done with SGLT2 inhibitors showed there is significant renal outcome benefit also. And this led to development of the renal outcome trials. CREDENCE was the first trial and was prematurely closed because of the phenomenal benefit in terms of reducing renal outcomes. And this was followed up by the DAPA-CKD trial. Both the trials showing that there is significant reduction in the risk of renal outcomes and renal mortality, not only in people with type 1 diabetes, but also in people without type 2 diabetes. And this led to change in the approach from glucocardiocentric to CKM or cardio-renal metabolic approach. Now, with this, we started getting the details from newer molecules like semaglutide and tirzepatide. We got data from SUSTAIN, PIONEER, STEP, SURPASS, and so on. And we saw significantly better reduction in A1C, significant reduction in weight, significant improvement in the MASL, and cardiovascular risk reduction. And not only that, there was reduction in the cardiovascular mortality. Another important thing that changed was, before these trials, we only could achieve a weight reduction of about 10% with the pharmacotherapy. But with the newer molecules, the whole story changed, and we were looking at weight reduction going in the range of 15 to 30%. We were inching close to bariatric surgery results. So the approach further changed, and with the newer GLP-1 RAs, we moved to so-called CARMEL approach, or cardio-renal metabolic liver and obesity approach. Now, what is the evidence for this? As I showed you, despite number of molecules entering the armamentarium, the burden of diabetes kept on increasing. And if you look at the figures between 1990 and 2022, number of people living with diabetes increased by 4 times and the prevalence increased by 2 times. And if you look at the IDF estimates that have been coming over last 25 years, in 2013, it was estimated that we will have 333 million in 2025. And this figure was revised in 2006 to 380 million. And then in 2013, we got the prediction of 592 million people living with diabetes in 2035. But we have achieved this number in 2024. So every time IDF gave a recommendation or a estimate, it was surpassed much before. And what is driving this type 2 diabetes epidemic? The answer is obesity. So if you look at type 2 diabetes people, 90% of the people have some degree of overweight or obesity, and studies have clearly shown whenever there is a rise in BMI across population, it is paralleled by a rise in the prevalence of type 2 diabetes. This was shown from Australia by Paul Zimet and his team, and again from North America. If you look at the data between 1995 to 2015, over 20 years, this picture shows you increasing prevalence of diabetes. I will use a pointer here, I think. So if you look at these figures, this is showing increasing prevalence of obesity over 20 years period, and it is paralleled by increase in the prevalence of diabetes. So there is an established relationship between type 2 diabetes and obesity, and with every increase in BMI, every point increase in BMI, there is increased prevalence of increased risk of getting type 2 diabetes. Now we know there is a clear-cut link between obesity and insulin resistance. There are at least 3 distinct mechanisms which have been proposed. One is the increased production of adipocytokines like TNF, alpha, interleukin 6, and RBPP4, or ectopic deposition of fat, especially in pancreas, liver, muscle, and even kidney and heart. And third one is the most important, which is mitochondrial dysfunction, which is evident in number of studies by decreased mitochondrial mass or function. Now, mitochondrial dysfunction possibly is the most important underlying defect which links obesity to diabetes, both by increasing insulin resistance as well as by decreasing the beta cell function. So there is possibility that both obesity and type 2 diabetes share a common underlying defect, and the defects that lead to progression of weight gain also lead to progression of diabetes. So what happens is once there is sustained exposure of cells to excess of nutrients, then there is impaired inflammatory signaling, there is increased ER stress, there is increased production of free radicals, and ultimately leading to mitochondrial dysfunction and activation of AKT pathway, leading to a cascade of reactions, leading to development of insulin resistance and beta cell dysfunction. 2017, AAC came up with a position statement that we should redefine obesity as adiposity-based chronic disease. And this framework was given by Jeffrey Mechanic and his team. And now we know that in individuals who have primary diabetes risk, which are predisposed by genetics, epigenetics, and environment, there is development of ABCD or obesity. And to begin with, the state may be insulin sensitive or insulin resistant. But people who are insulin sensitive will develop mechanical complications to begin with, but people who are insulin resistant go on to develop the components of metabolic syndrome, and even the insulin sensitive individuals become insulin resistant in due course of time. Once they have metabolic syndrome, there is increased risk of getting hypertension, diabetes, and NASH, and the cardiovascular risk. But once you have diabetes, the risk is further increased and you have development of all the cardiac component, renal component, so on. So obesity is the key driver for development of type 2 diabetes, and to treat type 2 diabetes, we need to treat obesity. Again, what is the evidence? First evidence came from the bariatric surgery 30 years back from Walter Pori's group. It showed that bypass surgery was followed by 95% remission of diabetes, and this remission was sustained in 90% of the people at end of 10 years of follow-up. And we have comparative data between medical and surgical management of obesity clearly showing that surgical procedures give you significant remission of diabetes and significant reduction in the complications of diabetes. And we have also data from direct trial, which was discussed earlier in the presentations, that if you are able to achieve 15% or more weight reduction, there is 86% chance of remission of diabetes. We have data from STEP trials, which was the semaglutide treatment for obesity. And if you look at the STEP 2, which was done in people with type 2 diabetes, there was significant 10% reduction in people treated with semaglutide. But in addition, there was 2.2% reduction in A1C, and the starting A1C level was only 8%. So you are touching 6% or less A1C with the significant weight reduction, and similar data was seen in SURPASS 1 and SURPASS 2 trials, where tirzepatide led to a weight reduction of 12%. In addition, about 2.4% reduction in A1C starting from 8 or 8.2 percent of A1C levels. So if you look at the SURPASS data, people who were on 15 milligrams or more of tirzepatide, more than 50% achieved a A1C level of less than 5.7%. So it is not just the beta cell dysfunction. It is possibly obesity, which is actually, if you see, is hitting on multiple pathways leading to contribution of hyperglycemia. And we need to treat obesity. And Carmelo, which is cardiorenal metabolic liver obesity, actually offers a comprehensive approach to type 2 diabetes management. So with that, I come to end of my presentation. I think I have saved time in this presentation. I would also request you all to block the dates for forthcoming ACCD, which is going to be held on 15th and 16th of August, 2026 in New Delhi. Thank you so much for patient hearing.
Congratulations, Bridge. That was an excellent acronym and a great choice for an oration, which you have delivered so brilliantly. As I think conventionally, there are no questions in an oration. So I would like to pass the mic on to the organizers. Thank you. Thank you very much. I think he deserves a standing ovation.
Proceeding for the next oration ceremony, that is Professor V. Sheshaiah GDM oration. For that, I would like to invite Dr. P.C. Manuria sir, Dr. Rakesh Parikh sir, and Dr. Shankar Khobragade sir to be as a captains for this flight, and Dr. Jyotidev Keshavdeva sir from Tiruvananthapuram. Sir, kindly join the stage.
I request Dr. Shashank Joshi sir to please join us on the dais, please.
Dr. Sunil Gupta sir.
I'll do. Dr. Jyotidev Keshavdev is our technological man. He has immense interest in diabetic technology for last so many decades. He is the National President, Diabetes Technology Trust of India, Central Executive Committee member, RSSDI, Editor-in-Chief, International Journal of Diabetes and Technology, founder and organizing secretary, Global JPF Convention for the last 13 years, managing trustee P. Kesadev Trust. For the yeoman service in the field of medicine and an exemplary delivery of oration on integrating diabetes technology before, during, and after pregnancy, my journey and evidence-based recommendations. DCCJ and DCRC proudly accedes to your conventional service to the people living with diabetes and special penchant for technology integration with healthcare. We acknowledge your distinguished academic accomplishment, your impassable verses, and the humility with which you carry out lowering repute serve as a source of inspiration to all. It is our profound honor to present with you with this prestigious award, Dr. V. Sheshaiah, GDM Oration 2026 during the 13th Hello Diabetes Academia 2026 International Conclave on Saturday, the 20th June, Nagpur, India. Dr. Kesadev has a masterly approach of slowly unmasking the depth of the problem. His deliberations always leave behind an everlasting imprint in the minds of the audience, and I'm sure you will enjoy the flashes of his expertise during the discourse. Thank you.
Good afternoon, friends. Sir, congratulations. And I would like to request you to start your this very important topic, integrating diabetes technology before, during, and after pregnancy, and my journey and evidence-based recommendations, your experiences. And dear friends, this topic is very important, and I would like to request Dr. Jyotidev sir to start your lecture.
Thank you. Thank you, sir.
Oration.
Thank
This
you.
is
Thank you
oration.
very much.
Thank you.
Thank you very much. And I don't have any disclosures pertaining to this oration. So let me thank my dear friends. And we are friends for a long time, for many decades. And profound gratitude to Dr. Sunil Gupta, Dr. Kavita Gupta, Dr. Shlok, and the entire team and the family and the organizers for this appreciation. And this is an outstanding couple, and they are doing a wonderful job, education, training, counseling, not only for doctors, but also for the supporting staff locally, nationally, and internationally. And my best wishes for them to continue the good job, and God bless you. And thank you again. And this is Dr. B. Shesha. When Sunil Gupta called me and invited me for a lecture, I told him that I am not an expert in GDM. And then he said that you are going to discuss on technologies in diabetes and pregnancy, and that too in the name of Dr. B. Sheshaya. And this is Dr. B. Sheshaya delivering an oration at our JPF convention exactly 10 years ago in 2016. And this personality, I would say that this is a blessed personality. And I know him for many decades, Dr. B. Sheshaya, revered as the father of GDM in the country, and his birthday, March 30th, is now celebrated as the GDM Awareness Day in India as per the Government of India order. And he continues to be active, and he continues to motivate many of us, countless physicians across the country and across the globe. And thank you for giving me an oration in the name of Dr. V. Sheshaya. So now let me move on to my duty, and from pictures, let me now move on to a video. And this is a lady, and this is a video of a girl who is balancing on one leg. You can see that she is balancing on one leg, and then she is holding, let me show it once again, she is holding a ball on the other hand, a plate on one hand and ball on the other hand, and she is balancing and balancing in her life as well as in this game, and this is a snapshot from our Dreams project in Kerala. And this is related to type 1 diabetes, but here I have shown this video to have a similarity of this occasion with managing diabetes in pregnancy in a girl who has multiple responsibility, multitasking in her life, with so stringent targets at low at 63 and at a high at 140 milligrams. It is almost an impossible game. And the reality is that you are never able to reach those stringent targets without the aid of technologies. It is so indispensable. And let me now go back to a little bit of history. And on the top right corner is the picture of one of my staffs. And this picture was taken way back in 2004. And she is holding the CGMS Gold, continuous glucose monitoring system, the first ever CGM which was launched by Medtronic globally and in India. Globally it was 1999 and in India it was 2004. And why in GDM lecture a picture on CGMS Gold? And that is quite interesting to the physicians here. There is something which is so unique and interesting. And these are two publications by Yogev and the team in 2003. Why CGM is important in GDM understanding. Before the advent of continuous glucose monitoring, we never knew the exact numbers of the normal in pregnancy and in diabetes and in physiology. And it was after continuous glucose monitoring, there were insights into the fact that the glucose levels could be lower in a normal pregnancy when compared to somebody who is not pregnant. It can be even low. It can be even around 63 milligrams per deciliter. And we knew that these low numbers are required to prevent the fetal maternal complications. And I would say that continuous glucose monitoring and its innovation has completely revolutionized our understanding of diabetes and the physiology of glucose in pregnancy. And this is a lovely picture of a girl, and she's so happy and excited, proud to display the normal glucose levels in a Libre continuous glucose monitoring system. And she's probably celebrating her diabetes with the help of these technologies. But all girls are not the same. And in sharp contrast, there is another girl. There is a saying that men are from Mars and women are from Venus. And I had the experience. And this is a girl who came to me, the first consultation. She was so angry and arrogant. And she was literally threatening me to put her on an insulin pump. At that time, she was having an A1C of 10.5, 4 months pregnant, and with a history of 4 abortions in the past. And this is the first time she is meeting me. And it took more than an hour for my team and for me to convince her that the ideal time for deploying an automated insulin delivery system or insulin pump is not after becoming pregnant. The organogenesis happens during the early weeks of conception. So ideally, we could have started even before planning for the pregnancy, and this is not the ideal time at all. And you are not going to have any benefit if I am going to put you on an insulin pump at this stage of pregnancy, because it is already 4 months. And another scenario, and this is the history of a 28-year-old primie with a new diagnosis of GDM, and she contacted me over the phone to the hospital. In fact, the family had a consultation via the phone, and they said that this girl is sleeping all the time and she is tired, and she's eating more than the usual, and she's even disoriented at times, and she was given a basal bolus regimen from the hospital the moment she was diagnosed with diabetes, and the glucose was higher when she was diagnosed. And we requested the family to procure a glucose meter immediately from a nearby pharmacy because they didn't have a glucose meter at home. And then these were the reports. On an average, the glucose was always remaining below 65 milligrams per deciliter. So unfortunate. So unfortunate, and still it is happening. And we started her managing via our telemedicine team. This is how we manage our diabetes, and with a multidisciplinary team. And within a week, we introduced continuous glucose monitoring. She had a physical visit to the hospital, and the management continued. And this is the usual scenario. When somebody is managed, or when diagnosis of diabetes during pregnancy is referred to another physician in the same hospital. And the major setback in our scenario, I don't know whether it is the same everywhere, but at least in the South, this is a scenario. There is no interdisciplinary team effort. There is no dietitian, diabetes educator. In reality, to be successful, we all need to work together. The physician, the diabetologist, or the endocrinologist, the obstetrician, the gynecologist, everybody should work along with the supporting staff. And the continuous glucose monitoring devices should never be introduced after a crisis. You should be proactive rather than reactive. And this is a month later. So we began with this, and then now she's having a time in range of 98% with no excessive hypoglycemia. And this is a response from the girl. I feel so comfortable, doctor. When compared to a glucose meter and when compared to no monitoring at all, now I feel very active. I'm not sleeping. I'm exercising. And I feel so confident after being on continuous glucose monitoring. And I don't feel stressful managing my diabetes during pregnancy. And she delivered a healthy baby. The mother also remained normal. And this is the current scenario. I would say that this is a scenario in India. 10 times higher risk of developing type 2 diabetes with a history of gestational diabetes. And the prevalence data, I am not sure about the exact data in India, but from Kerala, my friends say that among 10 pregnancies, more than 3 or 4 of them are having diabetes now. And more than 80%, this also I am not sure, more than 80% of them are treated only with the diet and exercise. And how far it is successful, how far it is justified also, I am not sure. Whether we are monitoring them properly, whether we are aggressively reaching the targets also, I am not sure. And this is another scenario. It's a very rare syndrome, and this is a story of a Wolfram syndrome lady who started getting treated from me. And this is a publication. This is before insulin pump. We started her on an insulin pump, and then we made her, actually the family wanted her to get married. Very rare to have a marriage with Wolfram syndrome. She became pregnant, and during the delivery, I was with her in the theater, in the operation theater, and the insulin pump was continued during the cesarean session. She delivered a healthy baby boy, and she outlived. When compared to many others with Wolfram syndrome, she outlived. And this is a publication in the top indexed journal DTT, along with the world leaders in Wolfram syndrome, that is Alan Permut and Watson from the University of Washington. Very rare syndrome. Diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. If you are planning for technologies in diabetes, we need to plan it at least 2 to 3 months before planning for pregnancy. So before conception. And this is the overall planning, the pre-conception counseling. So if you go by the guidelines, whether it is the DIPSI guideline or the RSSD guideline or the ADA or the ACE guideline, uniformly everybody recommends for a hemoglobin A1C as low as possible, as normal as possible in pregnancy, if you can reach safely. Very important, if you can reach that target safely without inducing excessive hypoglycemia. And during the pre-counseling period, make sure that some of these drugs are discontinued. So many of them, especially those who are having obesity or pre-diabetes or getting treated for infertility, they are on GLP based therapy. So it should be discontinued 1 to 2 months before planning for pregnancy. And during pregnancy, I think this physiology is known to everybody. So in a normal pregnancy, in the initial stages, there is increase in the insulin sensitivity, and later on from 16 weeks onwards, there is increase in the insulin resistance. So subjects will require more of insulin, and the total daily insulin dose increases roughly 5% per week. And in third trimester, stage 3, the insulin requirement levels of usually doubles when compared to the pre-pregnancy levels. And once the placenta is delivered, there is a sudden increase in the insulin sensitivity and sudden drop, almost 34% reduction in the requirement of dosages. And this is how the insulin sensitivity improves in early pregnancy. And even in type 1 diabetes, there can be chances of a hypoglycemia. And this clearly depicts the significance of an automated insulin delivery device in difficult to treat diabetes during pregnancy, especially if it is known earlier. And there is a subgroup of people, not only patients or subjects who are pregnant, the family members won't be comfortable with the use of devices. So when we tell them that use a continuous glucose monitoring throughout the pregnancy, because it is so essential, they may not be willing. And sometimes they may not be willing for an automated insulin delivery device to be continued through pregnancy. They may argue with the doctor, so I am comfortable, I will be okay with only the lab measured glucose levels and the hemoglobin A1C. And these are the circumstances when we should be probably having an extra time to have a conversation to convince them. The doctor and the supporting team should convince them that there are limitations with the use of existing modalities when you are measuring only a hemoglobin A1C from a lab. And you have to reach a target, and reaching a target without significant hypoglycemia, if you go by the global guidelines or any guideline, the scientific evidence is pointing towards a hemoglobin A1C less than 6 is the best in pregnancy, but it is achievable. It should be achievable, but dangerous without proper technology and education. So it is life-threatening to reach or to accomplish a goal in pregnancy without the aid of technologies. So you had to tell them, you had to be very outright and sincere in telling them, convincing them, since this is a very sensitive period. And this is a concept clinical trial, well known, published way back in 2017 in Lancet, and almost for more than 15 years, it was only the minimum Medtronic devices which were used for continuous glucose monitoring. And it was then, it was proven that even 5% improvement in the time in range will translate to a significant reduction in the large for gestational age birth and for neonatal ICU admission. So phenomenal, remarkable evidence from the landmark concept clinical trial. And now we are not clear about the pregnancy, type 2 diabetes and GDM, the targets. So probably just 90% even more time in range. And this is the DIPSI guideline. So almost all these guidelines are endorsing with the use of devices in diabetes, with the use of continuous glucose monitoring in somebody who is going to be pregnant with type 1 diabetes. And these are the RSSD guidelines, in the use of insulin AAD, the screening targets, and again from DIPSI. So when to use continuous glucose monitoring? When to use the insulin pumps and automated insulin delivery? So this is a picture, and the background is type 1 diabetes and somebody is becoming pregnant. So all of these are a reality. You may be measuring only the fasting glucose, but overnight there is a hypoglycemia. There could be a somogy, there could be dawn phenomenon. The person could be missing the boluses when it is transmitted with a pen or with a syringe. So they need to be on an automated insulin delivery. So what is AAD? So AAD, all of you are familiar with an EAD. You require a reliable integrated continuous glucose monitoring devices, non-adjunctive, and along with a new generation of insulin pump and a control algorithm. And it is automatically delivering the bolus whenever it is required in micro boluses, and it is changing the base cell once in every 5 minutes. And this is the commercial space of the available AAD systems. But something which is very unique in pregnancy, which all of you probably should appreciate, there are different algorithms in automated insulin delivery devices. And not all those algorithms are approved for use in pregnancy. So you have CAMP APS, which works along with 2 insulin pumps. One is Dana from South Korea, and the other is Ipsomed, and it is rebranded now as MyLife. And this is 780G, which is available in India. So there are 2 devices, rather, there are 3 globally available devices which are approved. And this is US FDA approved, and this is in Europe CE approved for use in pregnancy, because it's so important that the targets in pregnancy need to be maintained. And the sensor should be more reliable. And not all of these devices, I repeat, are not approved for use in pregnancy. And these were the original guidelines published by us in DTT on the use of insulin pumps in the childbearing age group, especially when you are targeting with stringent lower and upper limits. You may require the aid of insulin pumps to avoid both hyperglycemia and hyperglycemia. These two slides are probably important for the clinical practice. Where will you apply the sensor and the pump in pregnant women? The preferred area is back of the upper arm. And acceptable, if there is a contraindication, the acceptable areas will be upper outer thigh, upper buttocks, and never over the abdomen, obviously. But in early pregnancy, the pump can be deployed in the upper abdomen. That is the first trimester. In the second and third trimester, you can apply the insulin pump over the insulin pump infusion site can be there on the sides of the abdomen, and these are the flanks of the love handles. And all the trimesters, it can be upper buttocks, it can be lower back, back of the upper arm and outer thigh. So these are the preferred areas. Since in pregnancy you cannot apply over the abdomen. So these are the recommended sites. And if you are going for a sensor, make sure that that particular sensor is approved for use in the buttocks or in the thigh, because some sensors are approved for use and the evidence is there only in the upper arm. And this is how, if you can have a lifestyle, diet, exercise and telemedicine incorporated, how much reduction can be there in the overall occurrence of a GDM, a reduction in the gestational hypertension, the reduction in the pre-eclampsia. And this data is so robust. And I would say, remember, in one of the cases that I have shown you from our hospitals, we have registered her in the telemedicine program. And almost all these studies, and this is 32 randomized controlled trials and meta-analysis have shown that incorporating telemedicine in practice of GDM have resulted in a significant reduction in cesarean deliveries, where PROM, hypertension, preterm birth, neonatal asphyxia, polyhydramnios, etc., etc., when compared to not incorporating telemedicine and only encouraging in-person. So it should be a combination of telemedicine and in-person. So for the sake of completion and not to eliminate all these sensors, so we have multiple wearable devices now. You have watches, you have the spectacles, you have the rings, and some of them are very good for tracking the physical activity in pregnancy. Some of them are very good in tracking the sleep in pregnancy. Of course, I agree that some of these are not validated for use in pregnancy, but definitely it works, especially integrating them with nutritional apps. So we have the data with Apple Watch. The Apple Watch data is even published in Lancet and New England Journal of Medicine. So it is a health app. It is a health device. Apple Watch is a hospital or a doctor on your wrist. And then you have the smart rings, and this is in the order, in the descending order, the popular smart rings in the Indian market. So this is a technology journey across the pregnancy. You have preconception, you have the first trimester, and then you have the second and third trimester. So before you are planning for a pregnancy, in vulnerable people, and this can be even in the absence of a frank diabetes. If somebody is obese or somebody is overweight, you can start planning for a continuous glucose monitoring device. And in people with known type 1 or difficult to treat type 2 diabetes, you can plan for an automated insulin delivery device. And once they are pregnant, in the beginning of pregnancy, start using CGM properly. Definitely you should go for only a real-time device. Adjust the charges in an AID, and with telemedicine, I would prefer telemedicine. You review the CGM targets every week. Second and third trimester, you keep on recalibrating the targets, and when they are getting admitted, make sure that the team within the hospital is aware of using it. They are also empowered and trained on using the devices when the lady is hospitalized. And this is the 2026 ADA recommendations, the published in Diabetes Care. The evidence level is A or B for the use of technologies in most of these scenarios, in type 1, in type 2, AID in pregnancy, and at the onset of diabetes. At the moment you are diagnosing a diabetes, now you are justified to start somebody on a CGM, and that is applicable for pregnancy as well. So you can start somebody on a continuous glucose monitoring device when you are diagnosing GDM. And these are the updated guidelines and pre-conception technology. And it is preferred that continuous glucose monitoring is continued beyond GDM. If there is a history of GDM, even after delivery, if the person is affordable, if the patient is comfortable, you can continue using CGM. The reason being, this is the risk of developing diabetes later on in life. 30% in 20 years, 20% in 10 years. So my humble suggestion will be, if you want to, as a doctor, as a responsible doctor, if you want to diagnose diabetes, go for laboratory investigations. If you really want to prevent diabetes in future with somebody who is having a history of GDM, then you have to encourage using either a continuous CGM or an intermittent continuous glucose monitoring. So this should be the goal for you postpartum. In type 1, you continue the use of AID and CGM. In type 2, AID, whenever it is indicated, CGM is strongly recommended. And the GDM postpartum, as I have already said, intermittent use and pair it with the wearable technologies that I have discussed. And this is one of my concluding remarks. We discussed about managing diabetes during pregnancy. And beyond managing glucose in pregnancy, the goal for a doctor and your team should be a lifelong metabolic health maintenance for both the mother and for the offspring, supported by the use of smart technologies. And let me invite all of you, with the consent of the organizers, Sunil, Kavita and the team, to the JPF convention. It's going to be the 14th year of JPF convention, July 10th, 11th and 12th in Kovalam. Let me take this opportunity to remember my friends and my mentors. So I have listed a couple of them, Benshi, Anuj, and Dr. Shashank, Dr. Mohan. They are from India. Dr. Srikumar Nair, Dr. Bob Rissa, who introduced me to technologies at the Mayo Clinic, and being with me for 15 years and more than 20 years, and my supporting staff, my family. And this is the snapshot which I have taken during the last year convention, the staff in my clinic, in my research and in my clinical trials and in my journal. Thank you, my dear friends, and thank you for this opportunity. Thank you.
I think Dr. Jayatidev beautifully demystified the integration of diabetes technology, CGM and automatic insulin delivery system in pregnancy before, during and after. Let's give him a big round of applause and a standing ovation.
Thank you, Madam Sir.
Proceeding for the next oration ceremony, that is late Dr. V.S. Ajgaonkar sir oration. For that, I would like to invite Dr. Sudhir Bhandari sir, Dr. Debashish Chatterjee sir, and Dr. Rajkumar Khandelwal sir. They will be captains for this flight. And I would like to invite Dr. Rishi Shukla sir from Kanpur.
It's a great pleasure to announce late Dr. Diabetes Care Foundation of India, Nagpur, and Sunil's Diabetes Care and Research Center Limited, Nagpur, is privileged to award late Dr. V.S. Ajgaonkar Oration 2026 to Dr. Rishi Shukla, Director and HOD Regency Health Kanpur, owner of Chief Consultant Center for Diabetes and Endocrine Disease, recipient of recognized national and international awards, Economic Times Award 2018, IMA Kanpur Ratna Award 2022, Lifetime Achievement Award ACP 2023, Ahuja Award ASICON 2025, Kolkata Organizing Chairman and Tie Up 3 Kanpur 2025 Award for such a great achievement where hope meets healing. This is an honor and pleasure he to be bestowed with Dr. V.S. Ajgaonkar Oration 2026 on 13th Hello Diabetes Academia 26. That is an international conclave on Saturday, 20th June 2026 at Nagpur, India. Heartiest congratulations to Dr. Rishi Shukla.
Good afternoon, friends. Thank you, Dr. Sunil, Kavita, Shlok, and entire Hello Diabetes family for this overwhelming respect, love. I'm overwhelmed for two reasons: that you thought of me, and the second thing, that you thought of type 1 diabetes. Last year, I spoke on type 1 diabetes as an oration in Endocrine Society of India, but this is a much different platform. And I'm very, very happy for the reason that not me, but type 1 diabetes is being celebrated. And I'm happy that it is getting recognized. I'm happy that something beyond boundaries has started being done for the type 1 diabetes. So I'll discuss a bit about initiation of type 1 diabetes, what I could do, and scientific way to proceed, and finally way forward. Dr. B.S. Ajgaonkar, I heard so much about him through Dr. Deepak Dalal, a good friend of mine. And I was fortunate to meet him in Mumbai in one of the type 1D sessions organized by Dr. Manoj Chawla. And he immediately recognized me and placed me. So that was only one-time interaction, but so much heard about him, Dr. Vijay Kulkarni, Dr. Dalal, and they were the pioneer man in that part of the country. And so in last tie-up meeting on type 1 diabetes, there was a suggestion that we should keep an oration by the name of Dr. Ajgaonkar, but there were some logistic issues. So what we did, we kept a name of hall by Dr. Ajgaonkar's hall, because good thing, good people, and good work should always be remembered to help for the cause. My journey started, I think, almost 30 years back. And I worked for a while with Professor Ish Bhatia at SGPGI, and he used one line: rich will get many Rishi Shukla, but the poor will not get a single. And that point, it was seeded into me. And I finished endocrinology from PGI Chandigarh in 1993, so almost 33 years from now. And these were the olden days. I think they're all now stalwarts, all if you recognize Dr. Anil Bansali, who is a retired head of SGPGI endocrinology, Dr. S.K. Sharma Jaipur, Murali Dharan from PGI, Arpan Bhattacharya, Bangalore, and R.K. Sharma ji is no more, he was based at Patiala. So finally went to our current place in 1993. against the wishes of my boss. My boss was not, Dr. Professor Das, my mentor was not willing me to go there. But two dreams I visualized while coming: doing something for diabetes and for something for senior citizens. And then what I did, creation of a SPAD, the Society for Prevention and Awareness of Diabetes. This was the organization that we created almost 30 years back. And 4 like-minded people met and started doing meetings. It was all challenging 30 years back. I mean, go back 32 years back, no pharma boom. And very challenging to get people for meeting, manpower, and make it financially viable. We have a teammates coming here. We knew how difficult was it to getting person for the meeting, getting funds, and getting things run. And what we did, one regular meeting on every 4th Sunday for both T1 and T2. And this meeting, I mean, 33 years back we seeded, and still we every 4th Sunday, in spite during COVID days, we continue to have these meetings. So it is probably, I think, nowhere in the country this has ever happened. Some of it did not apply for any world record or Limca Book of Record, but this is uninterrupted work. Soon we started a special meeting on type 1 diabetes on every 3rd month. This is again going on, and we tried to cover all possible topics inclusive of outdoor picnics. This is the old time, and Praveen ji is here. You can see he's sitting here. And this is my old time, almost 25, 28 years back. And the thoughts that I came in my mind, being emotional, looking at children, doing something is good, but being motivated is also good. We needed to be realistic also. And there should be something in black and white also. So that was the thought, and then journey started. I joined ISPAD, International Society of Pediatric and Association of Diabetes, and Dr. Bansi joined after that, and he did wonders. I'll share his work. And first we shared the behavioral problems, and what we realized is most of the people express pity after knowing type 1 diabetes, poor type 1. And majority of type 1 diabetic patients are not comfortable in social gathering. They stopped going to meetings. And those who know about relatives and close friends hurt most. And significant number of type 1 diabetes feel that they should not make their diabetes public, as against the thought that we feel it should be made public. Because then they comment, criticize, and make you hurt. We moved with the journey, and to evolve a model care for social support for type 1 diabetes. I think this model was a very important model, and it helped in generating awareness all across the country. In the meeting that I said, every 3 monthly, we discussed medical and social issues and focused on academic education, encouraging more dominantly to females to be independent in life, make them realize their potential, helping in their marriages. So much has happened, and each meeting comprised of lecture by a specialist, interacting with them regularly on day-to-day problems, sharing meals. If you sit someone and share meal, I think it makes a lot of difference. Sharing experience of type 1 diabetes who have achieved goal in their lives, and talent show by participants. They have diabetes, but they are as normal, as good, and as big as anyone else. And look at the outcomes. This was the patient's perspective. Better monitoring, prevention, and reversal. We have seen reversal of complications because 1993, the DCCT trial came, and that said that with intensive control, the complications, especially the microvascular complications, were reversible. Optimizing better and challenging educational opportunities, develop confidence in social gathering, less affected by negative events, and most of the children, they said they want to be independent and ready to face the problems of marriage, because once they went into the market of marriage, the things were very different. And the patient's response, help in coping with initial stress, realize that child can lead a normal life. I can send my child for studies outside. And many of my children went outside and they stayed independently, realized that he or she can do many things as in life against the thoughts. In case of arranged marriages, amount of confidence was very different. And look then and now. This was one model. And now so many similar models all across the country to touch various aspects of type 1 diabetes. So this was a almost role model. A word about marriage. We evaluated the problem of marriage in type 1 diabetes, and what we did, we discussed, the people were invited in one of the meeting, the individual experience, role of society, excited house participation, possibly. So, I mean, if you recognize Dr. Jargar, you can identify Dr. Vijay Lakshmi Bhatia. He is Dr. Sunil Gupta on the slide. He also came 2007 in one of these meetings. And what we concluded that maximum problems are with females due to social circumstances and awareness of type 1 diabetes, and that problem is very less in the society. Therefore, nobody wants to marry, quote unquote, a sick lady. So this is Eisenhower's thought. Then and now what has happened in 2026? Lot has happened. So many centers across the country, all are doing commendable job. Dr. Ramchandani is sitting there, I think. Dr. Archana Sharda will be coming today. Dr. Sunil Gupta, they're all doing commendable work. And good T1D are more confident now, our T1D. And most of the female type 1 are more vibrant and working. We wrote an article in RSS textbook and counseling issues about marriage and social issues affect glycemic index control. So this is one, and there is a lack of awareness at patient, family. So overall, the awareness problem is there, and very nice counseling is needed at female and male T1D level. So this is very much required. And the milestones in our journey. This was a national type 1 diabetes meet in 2007, almost 19 years from now. We invited type 1 patients all across the country. Normally, doctors are invited. Here, patients were invited. And total participants were 400 at that point of time. It was 2-day meet, 27 and 28 Jan 2007. We discussed almost all relevant issues related to them and their families, and people went back with very positive thoughts. I think Mr. Rajesh Shukla, the BCCI president, he inaugurated it. Dr. Vipin Mishra, my senior colleague, and this is me. And in the background, the role models are there. And especially at the background, this gentleman is our ex-MP, Mr. Pachauri ji, who is the good friend of Gadkari ji of Nagpur. I think Dr. Vijay Lakshmi Bhati, everybody recognizes. She also came and addressed. Dr. Jargar is sitting at the back, 2007. And the outcome, this generated enthusiasm all across the country. People realized that a lot can be done and we can do it. So every center people felt that they can do it. Clinicians working on T1D accelerated their work, and many people started working on this neglected area. People thought we can't do anything. I am a storyteller. I learn a lot from people with whom we conversate, and I always believe that if things are presented in form of a story, so this was the article that we shared with Sanjay, because storytelling, if you tell and express things in a lighter way, it stays longer. This is our work on mindful meditation as adjunctive therapy to improve glycemic care and quality of life in patients with type 1 diabetes. I think as yet this is the only work on meditation in type 1 diabetes. There are a lot of work on type 2 diabetes, but this is as yet the only work, and this was published in one of the international journals. And all type 1 and D1 were on AGP on both the arms, and there was improvement in blood sugars in time. We had two arms. One arm underwent meditation, and the other arm a normal arm, and we put ambulatory glucose profile, and what we realized that there was a difference in time when in the group who meditated. The cataract work is not being done, and this is again an interesting study that we had 10 people, and 10 T1D operated cataract, and we followed them up. And again, not much work on cataract and type 1D in the country. And what we realized that in all cases, visual improvement occurred like a normal. Usually cataract was soft, and outcome of phaco and all the procedures will have a similar efficacy. Usually bilateral, and interesting, all the patients had a bilateral cataract and not linked to macrovascular complication that we know. And interestingly, there was associated with diabetic ketoacidosis. Those who had cataract, This is another work. The steatosis, our recent work, steatosis in adolescent and adults with type 1 diabetes and its associations. So we had 40 children, we took data, and what we concluded that steatosis was very strongly associated with SGPT, BMI, and duration diabetes. Nothing known, but steatosis and NASH is not a known thing in type 1 diabetes. It is a known thing dominantly with type 2 diabetes. We wanted to look at it, what it is. And interestingly, the retinopathy steatosis, those who had steatosis, they had 17 times more chances of having retinopathy. So this was again a very interesting finding that we had, and it was a oral paper presented and inspired by one of my colleagues. Celiac disease in Indian children. So what we did, we do tissue transglutaminase at the beginning, at the time of presentation, and then 14 children with TTG negative developed TTG positive in 3.9 years of span. So celiac disease is common in India and develops in most within 5 years. So once diagnosis negative does not mean it is negative. You should do it maybe once a year or once in a 2 years. We were not kept silent, and we worked in COVID, and we had 2 centers study and 89 participants, and increased level of SS was seen among adults and young. So contributory factors were female, gender, salaried person, but now COVID is no longer, but it was a work. This is a happy paper that was a 4-center journal of type 1 diabetes, self-care in urban school in India. So 4 centers, Hyderabad, Delhi, Aurangabad, were included, 2 centers from Delhi. And what we noticed that the schools were better in supporting T1D children, because those were all higher level of a school. But again, there's a problem with the school. This was an oral poster on pump therapy. My colleague Sanjay Saurabh did, and this was a 3 hours awareness program on pump, and it was compared with the individual. So we invited people, potential people for pump, and gave a common counseling. And what we realized, and after that, out of 12 participants were ready to use insulin pump. The future perspective to control glycemic variations in patients with type 1 diabetes, millet-based diet. So millet-based, lot of work is there, but hardly any work is in type 1. So 15 children and adults in type 1 diabetes, and breakfast and dinner were replaced by a regular meal for a month. And we put ICANN before and during study into all, and breakfast values were 3% more in time and days. So no difference in other values. So this was a short study, but we needed to have a better study. This was a very interesting and a happening thing, that energy booster approach to touch people with type 1 diabetes, a fashion show. I realized Manoj is sitting here. Manoj, in Mumbai, you did a similar type of thing, a more modified, but we did long back. And what we did, a 4-season display of fashion show by all T1D children, and they were so happy. They were so happy, and look at the response post-event, the subjective responses recorded post-show, and awesome, fantastic, wonderful, mind-blowing, superb, and innovative concept. So this was a very nice thing that we could do, and I think they bring a lot of life into type 1D. But this was not associated with pains. I think last year I wrote article in Indian Journal of Endocrinology and Metabolism, and the pain I am sharing, what happens that many patients skip insulin doses, poor glucose monitoring, lack of physical activity, irregular doctor visits, and failure to apply diabetes education in their day-to-day life. Because this bottom line is the base. If they are educated appropriately, probably they will not be neglecting it. With it, thank you, Bansi, Archana, for this common platform. Inspired like where anybody interested in type 1, inclusive of type 1 patients, technicians, doctors, they can join. So this was the 3rd meeting we organized in Kanpur. So Graham Mugle from Child for Life is here. And this was a very useful and successful meeting in spite of, if all of you remember the Indigo crisis last year. Suddenly all flights were cancelled and disruption, and that was the time, but still we moved on. We had a first residential camp for type 1 diabetes in UP. People have been doing in different parts of country. Maharashtra, they have been doing regularly, but this was the first camp in entire state of Uttar Pradesh. So Dr. Saurabh was my younger colleague, was the organizing secretary, and he's type 1, a very nice singer. We had a meeting, and what we did, if you see, we did a yoga, walk. Dr. Shrikanta from Bangalore, he came and stayed for 2 days to share his experiences. So this was a very nice and very positive meeting. Staying with them, eating with them, sharing with them was a very sweet feeling, but challenging too. Finally, I tried to touch many aspects from society to science. India has changed with respect to T1D, and we could make a change. Then 1994 and now 2026. ESI, RSSDI, Diabetes India, even current oration, and many more. The number of topics on T1D had drastically increased. Earlier used to be 1 or 2 talks on T1D. Now number of symposia have gone up in every meeting. Earlier we never heard of solo meeting on T1D, and now this is happening, T1 tie-up. So this is again a very interesting. I remember 25 years back I used to say, please put one talk on type 1 diabetes to people with endocrine society, people with RSSDI, and people with diabetes. And they say, you come and speak. Then I say, it's not me. This is the topic and this is the awareness. And that is required. Now you see the entire symposia are there. And this was all not possible without team. If you look at center, Dr. Sangeeta, my wife, she withstood. She is eye surgeon, but helped me logically. The left side, Dr. Deepak Yagnik, like my younger brother, he also withstood and helped in many ways. Dr. Bhaskar Ganguly, my senior colleague in the city. And then my colleagues, Dr. Saurabh Mishra brought lot of technology and did lot of life into my life, because as we age, we tried to keep ourselves away from technology, but he pushed me into technology. Dr. Manisha on left side, she again put me into technology. She focused on type 1 diabetes, and she did a very innovative job of fashion in diabetes. So did a wonderful lady, wonderful girl, and did a lot of good things. Left side, Dr. Vibha, my fellow now, has become consultant in my department, did a lot of good work. Our pregnancy data, we have 30 years of type 1 pregnancy data we have sent for publication. A lot of my academic work is done by her. Dhani, Alappan, all responsible for good work. Neha Agrawal is my old fellow. She's a consultant in Lucknow, and cataract data was all published with her. And these are the backbones. And the rest of the thing was superficial. Praveenji, he himself is a diabetic for last 40 years. At the age of 17, he developed diabetes, and he helped hundreds of children in type 1 diabetes as an educator, and he has his own work and business, but just for his mental sake he comes and he has joined me. Thank you, Praveenji, for being into my life. Ranna ji, I think more than 25 years, my dietitian educator. She has become mother of, I think, 700-800 children. So such a young lady becoming mother of so many children. Sudha ji, all logistic issues are handled by her. Meena, the technology lady of my all pumps, CGM, AGPs, apps, this is all handled by her. So this was all not possible without a team. And finally, big thanks to Dr. Bansi, who made my dreams true. Because I gave a thought and he executed. He had a lot of meetings, I remember, at Ahmedabad. He did a lot of 1 or 2 meetings where we had a discussion, and then eventually we came out with something better and something more useful. And Dr. Anurag Bajpayee, my younger colleague, a pediatric endocrinologist in my department, who withstood me in research, in academics, in tiny suggestions, and this made me moving. And so thank you. This is my family. This is center me, my wife, my son, and this is my daughter-in-law. My son is not a doctor. He's a political economist, and she is the journalist. So this is my family. And thank you, Dr. Sunil, Dr. Kavita, for celebrating the day for type 1 diabetes. I will remember it for long. And thank you so much for the opportunity.
Great show by Dr. Shukla. Dr. Shukla has dedicated his professional life bringing science, compassion, and hope together in diabetes care. His work has particularly touched the lives of individuals living with type 1 diabetes, where treatment extends beyond insulin to education, empowerment, emotional support, and lifelong guidance. He has consistently emphasized that every child with type 1 diabetes deserves not only survival but also a normal, productive, and fulfilling life. Heartiest congratulations to Dr. Shukla. I think he deserves a standing ovation for his outstanding contribution to type 1 diabetes.
Thank you, sir. Proceeding on for the next session, that is a debate. For that, I would like to invite our captains, Dr. Kshitij Kumar sir and Dr. Praveen Pant sir from Chandrapur. Our expert will be Dr. Shashank Joshi sir. For this debate on diabetes apps are increasing diabetes distress rather than improving outcome. For I have Dr. N.K. Singh sir and against Dr. Manoj Chawla sir from Mumbai. Welcome you all, sir. For against, we have Dr. Manoj Chawla, sir.
So he's here. Oh.
Sir, it's a debate. So yes, definitely.
Am I supposed to interrupt him in between also?
No, no, no. Manoj, no.
Then I'm just joking, sir.
So, a very interesting topic for debate. Diabetes apps are increasing the diabetes distress rather than improving outcome. And Dr. N.K. Singh will defend the topic, and Dr. Chawla sir would rebut the things. I request Singh sir to please start.
Yeah, thank you, sir. Good afternoon. Manoj, remember why this topic we are discussing today? I was going with Dr. Sunil Gupta from Chennai to some place, 3 hours. And उसने बोला कि इनके डायबिटीज एप्स को लेके पेशेंट को खाली एंजाइटी हो रही है मेरे पेशेंट को, तो मैं चाहता हूं कि इस पे एक डिबेट हो जाए. तो बोले सर एंजाइटी इफ यू राइट देन इट विल बी वेरी डिफिकल्ट टू डिबेट. देन डॉक्टर Arvind Gupta is here. He told no, it should be diabetic distress. So that's we are discussing today, that diabetic apps are increasing diabetic distress rather than improving the outcomes. Definitely, my disclaimer is that without technology you cannot live today. I am big fan of AI, and I run a group of world largest academic forum on the WhatsApp, you know, that is CME India. So I always loaded with all the apps I know. You will, Manoj might be showing. So, but let's us see what is the reality. The distress paradox is that if the digital tools genuinely relieve emotional burden, the distress curve in today's world have been bent down. But this is not happening. 36% global prevalence of diabetes distress is being reported today. So remember this. And more data. So Manoj will tell, though we have got more data, more data, more data. But remember, more data does not equal the better care. We don't want that with a bit of the glycemic gain, you have lots of psychological strain, which is so much of the under loop. So instead of solving the diabetes distress epidemic, the uncalibrated digital interventions which you are doing today are amplifying the emotional burden guilt and overwhelm that actively undermine the self-management. And this is the big problem. This is what is happening today. These tools were invented or whatever it may be, were supposed to solve the distress management crisis, but this is not happening at all. There is more and more data overload. There is a transient gain which he will show, and the care inequality is happening. And then the first point is this CGM alarms or other alarms. This is a very big disturbance where the CGM apps emit a near constant stream of alerts. The device wakes you, frightens you, and trains you to distrust it. So this is the reality in our day-to-day life. So there is a clear-cut anatomy of the alarm fatigue. Remember, there is desensitization, then there is disruption, then our patient get burnout, and then they become deactivated. So this is the reality, which is what is happening today. See here, from the dosing reminder, alarm is coming, then the trained alert, 11 a.m., then sensor calibration, and suddenly at 3 o'clock, when we are in the deep sleep percentage, there is some nocturnal alarm. And 40% of caregivers and the parents report feeling nervous and sleep deprived from the frequent nocturnal alarms. So this you must have also experienced. And also the distress tracks the perception that device amplifies. With CGM, glucose is now visible in real time. This study, one study I'm showing, mapped daily distress against both objective CGM values and subjective perception. And if you are giving the continuously displaying number every minute that this your sugar is this and this becomes an emotional reactivity that did not exist when glucose was invisible between the finger strips. So I'm not advocating that we should go to back, but this is happening today. So there is a sensor error, calibration needed, trend down, rate app is app store, the battery sometimes low and low glucose. With that, there is up to 38% of people, this study is showing, of people with diabetes show disordered eating at baseline. Remember, this is also happening. That 38% have shown in this study, this was a 2025 study, while CGM gives you healthy changes, it may also contribute to distress, particularly in younger adults, those with obesity, those who are high aggressive and eating disorder symptoms. So this wellness CGM craze manufactures the distress. And the technology does not merely comply diabetes distress, it can create a comparable distress in the worried well. So data sharing, then you have lots of data sharing today. The data is with you in your app, it is going to your doctor, your caregiver, your family, and this study is showing that the families reported frequent lacking understanding of how best to involve while feeling burdened and distressed and worried about the hypoglycemia. So this part is also happening, that shared data can mean shared anxiety and constant monitoring, and this gives you a big distress hit at all. So near universal uptake, no relief in the emotional outcomes. The strongest answer to but app's help is that today what we find, there is no link that in a large young adult real world cohort, high CGM satisfaction did not translate to lower distress, no significant association between CGM use and the distress. And even some RCT is showing that an RCT of CGM, if you compare with the usual care, did not reduce the diabetes-related anxiety in youth and the type 1 diabetes. With that, I will say you, even if you go for the outcomes, see here, the short-term novelty you are getting with this all apps, but at the long term, this meta-analysis is saying you that reveals the modest short-term HbA1c reductions of only 0.36 to 0.49% compared to the standard care. And this you see that this even with the short lots of the apps, your long-term efficacy is not very good at all. And so you are only getting a short-term gains, but long-term fade. And then with the all clinical reality, the cost and the failure at all. So what is happening? The app goes to the graveyard. With the modest initial improvement, you are happy, but when there is high dropout rates, most users engage less than 10 times before amending due to time, effort and technical error. They go to that app, they don't want to use the app at all. Then he will tell about something about the consensus statement, the latest ESD and ADSH, that there is inadequate evidence of accuracy, clinical validity, safety, and sustained effectiveness of most standalone apps, remember. So unregulated apps risk spreading misinformation and adding burden without proving any long-term clinical outcomes. So this is also a reality. And then why standalone tech is failing? There is unregulated data, punitive alarms, flawed outcomes. With that, the diabetes distress has become a reality. Clinical depression is a reality. And you can see the digital promise with the clinical reality, the psychological impact, clinical outcomes, and even the user engagement. Everywhere there is lots of failure. And lastly, you are also doing a collateral damage of connected care. 40% of the caregivers report feeling nervous directly due to the device alarms. So this is a big problem. And then those who need support, the most are often the ones who benefit the least from the current digital interventions. So this is not for everyone. These apps are only for few society, not all parts of strata of the society. So let us forcing patients to become their own IT department, Manoj. You are just forcing. Patients are already managing a complex regime, diet and complications, and adding you the tech support, technical glitches, and app crashes directly correlates of a higher regime-related diabetic distress. Remember, and these are one of the WhatsApp chat you can see. Yeah, I just wanted to sleep and what happens, so this is our chat. So we need a shifting from the data generation to a holistic support with better regulation and evidence, burden reducing design, and human integration. And there is a feature for what's the reality? The reality is that the paralyzing fear of future high and low, relentless exhausting hyper super vigilance, crushing guilt and self-judgment when arbitrary targets are missed. With that, always remember that the true measure of a diabetic cap is not how much data it generates, but how much burden it removes. And here, it is a total failure, sir. And with that, the missing is a psychological integration. Data without empathy is just a noise. You can see these 4 peaks. This see the one peak. How do you feel by seeing this peak? And this peak. So many things are you see. This is happening with all the apps. And now see this. This is my photo I took in the Switzerland. Now you are feeling cool now. And see this. तो धूप में निकलो, घटाओं में नहाकर देखो, जिंदगी क्या है मनोज थोड़ा किताबों से निकल कर देखो. So see this. So don't become a digital Ravana metaphor with all these apps. I don't want that you should become a digital Ravana metaphor. Be like this, defeating the digital Ravana with overcoming diabetic data fatigue. And let us have a path of simplicity, the focused health, the simplified management, and this is the need of the time in the 2026. Technology should simplify the burden of chronic illness, not become a chronic illness of its own. With that, I will end here. It is the weather edge deployed today through always-on alarm-driven, number-saturated apps. It is adding a new and measurable layer of emotional burden. So evidence says, Manoj, the motion stands. Thank you very much.
I think let's all clap for Dr. N.K. Singh because nothing can be more difficult to speak in a debate when you don't have conviction about the topic you're trying to defend. So as we all know, Dr. Singh Saab is, and he introduced himself as the founder of one of the biggest educational initiatives on an app and other social media. Dr. Singh Saab's most of the slides were made through an AI app. He can let us know which AI app. Unfortunately, most of them did not have references below that. And to my surprise, one of the slides that Singh Saab showed, I don't know how many of you noticed it, had an N of 1. I think sir must have noticed it, that he's showing paper where it says N is equal to 1 and quoting that. So well, let's see how I defend the fact that diabetes apps are increasing diabetes distress rather than improving outcomes. And I respectfully disagree with the founder of CME Forum that it's not true, sir. If digital apps truly increase the distress more than they improved outcomes, why has every major advancement in diabetes care, from CGMs to automated insulin delivery, all built around the smartphone technology. And I tried to hack into Dr. Singh's phone to see the number of apps, but it said it has already an app which prevents you from hacking into it. That's the strength of apps inside. So the real question is the app creating distress, sir, as you said, or is it actually revealing the reality of diabetes that was previously invisible? In terms of diabetes distress, much before people started speaking about it, there was this paper on euthymia and diabetes, which Sanjay Kalwa and group and A.K. Das sir is here. We led that. And in that itself, way back, we showed that the introduction of the concept of euthymia or distress in routine clinical practice is important to improve the quality of life. So there is no doubting that there is diabetes distress, and that distress has to be reduced by whatever means that you can to having better connected care. And then we had this aspect of euthymia model in which, as you rightly said, communication is so important. Empathy is so important to reduce diabetes distress and use any tools which can help people live better with diabetes. Imagine asking somebody to drive through Mumbai or Nagpur or Dhanbad traffic without a dashboard. You have no idea where you are going. No speedometer, no fuel gauge, no warning lights, and you're just walking blindly into the rooms and crashing into places. So what is diabetes distress? It's the emotional response to living with diabetes. It stems from the burden itself of relentless self-management. You did mention that a person with diabetes has so many decisions to make and is living with that burden. The possibility of long-term complications, the social impact, the stigma against diabetes itself, the lack of understanding in the population, and of course, the financial implications. All of this is diabetes distress and not an app-related distress. Apps actually improve glycemic outcomes. You questioned that whether it's 0.3%, but let me show you data with the references for the same. And evidence from a meta-analysis of 14 randomized clinical trials did show significant A1C reduction, better self-management, improved medication adherence. For type 1 diabetes, it showed CGM-linked apps improve time in range. I don't think you doubt that. They reduce hypoglycemia and they improve confidence of the user in insulin dosing. For type 2, the mobile coaching lowers A1C by 0.3 to up to 1% depending on what digital health technology you're using, better weight management and better adherence. And this is the reference for that same paper, which concluded that apps may be an effective component to help control A1C and could be considered as an adjuvant intervention to the standard self-management today, sir. Also, the other paper of efficacy of mobile apps to support the care of patients with diabetes mellitus. This also concluded the systematic review that use of apps in patients with diabetes could help control A1C. In addition, the app seems to strengthen the perception of self-care. Would you not like to have your patients that confidence of self-care and a sense of belonging and being in control? That's what the apps are offering today. Apps also reduce uncertainty. They reduce patient uncertainty. So what was happening before the digital tools came in, and all of us here have been treating diabetes? The question one would always ask is, am I low? Am I high? Is this meal safe that I'm having? Is exercise really helping me? But the answer would come hours later. Today, you have real-time glucose readings coming through any of your CGM apps on the phone. It is showing you the trend arrows. It is showing you a pattern recognition. It is showing you predictive alerts. Now, there is an alert. There is an alarm. There is a notification. It's just like your fire alarm, which is going to ask you to walk out of that place which has fired and not get distressed. If you're getting distressed, it is for your safety to get out of that building which is on fire, sir. CGM user experiences. So you're looking at qualitative study insights and not just four quotes without any referencing there. This study involved 24 participants with a 100% opt-in rate. 18 interviews had prior experiences. So you asked parents also and the users also about their qualitative experience. What did they say? SMBG at times can be frustrating because you don't know what's happening. It's like walking around with a blindfold, and you can walk into a room even now and then and take the blindfold off for 60 seconds, and then you're back onto it, so you don't have any vision. The teenage daughter is saying, if she says, the parent is saying, I don't feel quite all right, she can glance at it and decide where the sugar is rather than making blind decision. It beeps when you're going high, which causes distress to Dr. N.K. Singh's patients. Having that, just that the knowledge that you've got something looking out for you, just in case you do not miss it, is so relieving, sir, like ridiculously good. It's just another level of freedom and not distress. In a way, the arrows are more useful to you than the actual number, because it is not about what you are right now. It's about what's going to happen when you go to sleep and a preventive action that you can take. Also, of course, quotes from celebrities across the world. Before Dexcom CGM, managing my diabetes was guesswork a lot of the time, and now I can predict my levels. Somebody else saying it's not like this is rocket science, so don't get distressed. It's just that once you have the data, you make the best informed decisions. Patient experiences CGM and insulin pump therapy, well, no longer sore fingers, no severe hypos, bigger picture on what is going on with my diabetes. They enjoyed the ability to play more sport. I can do the things I like the best, and it is just fantastic. I'm sure you heard about the individual who won French Open, who's been using an AID system with the app guiding him towards better healthcare. The impact of real-time continuous glucose monitoring, not only in young, even in 65 years and elder. The data suggested that real-time CGM use in seniors is associated with reduction in episodes of severe hypoglycemia and improves quality of life, suggesting that if you restrict the use of real-time CGM in the Medicare age population in the US, it can be deleterious with economic and quality of life sciences. The problem is not poor design and not digital, it's actually poor design and not digital health. So standardizing that all apps can cause distress is wrong. Well, alarm fatigue can happen, and hence you have abilities now to put the alarms off or set different settings. Notification overload can be there, data overload can be there. I agree that these issues are there, sir, but it's not a failure of digital health. We do not abandon insulin just because it can cause hypoglycemia. We make right means of better insulins and better usage and guiding to our patients. Similarly, we improve the app designs. Digital health actually democratizes diabetes care in India, and you would know that as you go across the country, even in rural places, there is limited access. Doctor visits may be months apart. There is education gap. The apps become source of education, reminders, monitoring, teleconsult. In fact, for many patients, their smartphone is the only educator that they have and not an individual that they can talk to. Empowering patients through knowledge and not limiting information. So just those concepts of constant monitoring increases anxiety that Singh Saab referred to. Notification creates stress. Some studies have shown increased burden. Patients become obsessed with numbers. All of these issues have to be handled with empathy and with the knowledge of having digital health and help in their hands. Digital transformation in diabetes care is happening. India has over 100 million people living with diabetes, but not those many diabetes educators. So it's your apps which become the guide, and technology is helping them for benefits, for overcoming challenges, and you have now recommendations by the EHD and ADA technology group, which you refer to. Richard Bergenstahl and all in 2020 itself had said, stay informed. For an HCP also, stay informed on the app. Inform the patient on digital tools for management and lifestyle, and use health data to improve the quality of care and health. So diabetes distress comes from feeling helpless. The best diabetes apps, sir, they inform, they connect, and they empower the patient. There should be better understanding, better support and progress. Finally, let me conclude by saying diabetes causes distress, but good digital tools actually reduce it. And you can see how people actually using the technology can live happily, like to the fashion show that Dr. Rishi Shukla referred for at DTech in Mumbai. All these are individuals with type 1 and type 2 diabetes using technology and flaunting the use of technology and apps because it's improving their quality of life, and they overcome. Don't look at it as distress, but look at it as an ally. While I end my debate and wait for Dr. Singh's rebuttal, I would still invite you to use another app and submit your cases for the RSSDI CGM clinics, which we run every month. Thank you once again for being here, and thank you, Singh Saab, for giving me that opportunity to debate with you.
Can I, sir?
Hello. Yeah. I think both our proponents and opponents are, I don't know on which side of the coin they are. Okay. Frankly, both of them are confused. Both of them are under duress. Both of them need to de-stress and not distress. Okay. So that's my first take home. I think apps are here to stay. Whether they increase distress or they don't increase distress is based on the person who is using that app. It has nothing to do with the app. App is inert. It has no life of its own. But it is the user who needs counseling, and it's the user's personality which decides how he wants to react to it. So we have different people, and different generations. So Dr. Singh, probably I am a senior citizen like you, and they may not be very digitally savvy. And for them, using an app itself is an exercise, but whether it will give them happiness or it will cause them unhappiness is a very debatable issue. As I said, it is very individualized. That's my take on it as an expert. We have millennials, we have Gen Zs, we have the alphas, and now we have the GLP-1 generation. For them, Manoj, they feel it's a way of life. Without an app, they can't get up. They want to order food, they will order it through an app. They want to use it on and app is a way of life. I mean, I was about to miss a flight. I had a DigiYatra. We just walk through a DigiYatra every day. So we're using apps every day. I don't think that DigiYatra is increasing my distress. But if I didn't have a DigiYatra to enter an airport, okay, it itself will mean that I have to have a photo ID. Then I have to use everything. Then I have to enter everything. So that whole task has been reduced. So I think it's ease of use and ability to use, whether it will generate stress, anxiety, or it will generate happiness. And that will depend on the user. So I think it's the user's personality which decides, but I think we live in a digitally intoxicated world. And again, I come back to Sunil, that Sunil, allowed me to talk on digital detox here 3 years back. And we definitely need some digital detox and some food for thought. I want to open this debate to the audience here with a show of hands. How many people are with Dr. N.K. Singh?
I feel we have still rebuttal left.
We want to have a rebuttal from Dr. Singh. He has an opportunity, and then a rebuttal from Manoj also. Then
1 minute each for.
1 minute each from both of them. I personally feel that this was a delayed debate. Okay, with hypoglycemia, with a lot of people, and it was a good debate from both sides. I think Dr. Singh used a lot of Rashtra Bhasha and a lot of Hindi in his lingua franca. Manoj, as usual, was at his level best. Very difficult to choose between the two of them. So maybe 1 minute each, put shots at each other, and then we can have a show of hands.
So just I have to make one point, Manoj. You told that apps are so good, technology is very good. Where I told that it is not good, it is not bad. I only point is whether it is improving the outcome or not. So there is no data at all that it is improving the outcome. Apart from without improving the outcome, we are getting more and more problems, more distress. So that was the point in which I told you.
So I think, sir, it depends on what you're calling the outcome. If the outcome is reduction in A1C, there is data. If the outcome is improvement in time in range and reduction in hypoglycemia, there is improvement. I showed Polanski's paper. William Polanski is known best for his work on psychosocial impact across the globe. And that paper clearly showed about the reduction in diabetes distress. So if you're calling about quality of life,
for short time only.
there is data still. But as I completely agree. The only thing I would go in an extent to speak to what Professor Shashank Joshi said is, it's definitely the user that you assess and individualize it, who's finding it.
Yeah.
But it also the believer or the one who proposes the use of the app who can reduce the anxiety and improve the training around it. At the end of the day, the app is going to be advantageous. Can there be distress? There can be if you don't choose the right patient, but you have to work around that and teach them what to do. And the current settings actually allow you to put off the alarms or change your ranges to prevent those alarms from disturbing you. So you can individualize that and yet get the best out of the apps.
So the last 1 minute, half a minute I'll take. There is a good digital distress and de-stress. Okay, the distress is seen very clearly when on CME India there is a digital war.
Yeah.
And Dr. Singh has to expunge that. Okay, that is a classic example of digital distress. And Manoj and me are witnesses of that many a time. Sometimes I have to call him offline and say that expunge this remark. So that is distress. So that is to your defense.
Yeah.
But I think we all still, as Manoj said, are going to go to your app, which is your victory.
Yeah.
So actually in Manoj's victory is actually your victory.
Exactly.
Okay. So if you see it from that standpoint, for CME India, you have to lose to Manoj to get your victory. Okay. That is how I would summarize it. But we will have a show of hands.
Yeah.
Both of you all did a very good job. Please put your hands together for both us, this thing. And I think now we'll have first show of hands for Dr. N.K. Singh.
Only one or two. But I think that Sunil, you have to come forward. Because you told me that it is creating lots of problem to me. Everybody patients are coming.
Shashank, you can figure out if people are lazy or they actually want to raise the hands for me also.
No, now I think, yeah, for Manoj,
It's all believers here.
Yeah.
As they said,
Let's
it is
hear
Dr.
1
Singh,
minute from
it is
Dr.
Dr. Singh
Gupta,
and his
yeah.
app who wins.
no, so now the last word is from Sunil.
Yeah.
Sunil is Sunil, I think you should not be doing Hello Diabetes. We would like to see you as a MLA or a member of parliament from here. and I think that would be the best example for us to do that. So you will have your leadership, comment on it, because you have very firm beliefs in these apps, no apps, etc.
No, I feel what Shashank has said, we have to choose the patient properly. It is a misuse of these technology by many people across, by themselves. If it is going through a proper channel, proper recommendations, well validated, and with, of course, you have a evidence-based outcome benefits of various apps, then I feel it will be good. But unfortunately, what happens is, we have even, suppose now GLP-1, say we have 40 companies or 45 companies coming, they all will give you diet charts. They all will give you insulin people. They all will come to you, will show you some insulin. So, they are being burdened with multiple apps coming from various things, apart from the social aspect. I feel that is what is a burden. So it's an overall, if you see, you have to select it properly and use it properly, and rest of them have to be dumped, which are giving you stress.
Completely agree. I think the new word is interoperability and integration.
Yes.
So, all of
So I
people
think
agree
Manoj
that we get burdened
and
with
NK,
those
please
many apps.
put your hands. Everybody's hungry here. But Sunil, one point, small thing, that we are going to be wedded to chat GPTs and the clouds of the world. And outside waiting, as our waiting time in the waiting room increases, people go on all these new age doctors, which are the AI doctors. And our patients are so educated that they already have got a DM degree from chat GPT. Okay. And therefore, one of my patients, couple of weeks back before I went to US, he was telling me very, very aggressively how he has diagnosed his own Cushing syndrome, etc., through a chat GPT. When he was only thing, he had a pseudo Cushing syndrome because he was an alcoholic. Okay. So he could not distinguish that alcohol causes a Cushing syndrome like manifestation, but with chat GPT made him believe that he has Cushing syndrome. So I had to tell him that it is your alcohol talking from both ways. And alcohol and Cushing syndrome causes pseudo Cushing's. He did not know at all. Rakesh has seen this happening in KM hospital before. So you need to understand that we cannot be living with a chat GPT. Then the same patient, I told him that don't worry, I am also learning flying through chat GPT, and now I have got a certified pilot license from chat GPT. Okay, so you have to also tell that we are going to be wedded in this current world and we have to encounter this. So I think both of you all have made some very good points, and I think we have to intelligently use but distress can go up. Particularly, I see this distress going up in mothers, Manoj, or fathers of type 1 diabetic. When they have a child with type 1 diabetes, the amount of distress they have when they have a CGM on board is very high. By the time they embrace the technology and it eases their comfort, there is a gap. And that gap has to be filled by education. So I think it's education, empowerment, that conversion needs a lot of time. And I think that is the crux. And unfortunately, we don't have time and we are not able to bridge that gap. If we are able to bridge that gap, that distress and anxiety will be converted into an opportunity or an outcome. Exactly. And that is something which we all need to do. We need to spend more time understanding technology and using it for happiness and health. Exactly. Thank you.
Thank you very much. Let's give a big hand for both of them. And yeah. We are running almost 1 hour late, and I'll be very happy if all the subsequent speakers can donate some 1 or 2 minutes of their lectures, if not incoming to them, if it is okay. Dr. Makkar donated 10 minutes. So big hand for Dr. Makkar.
I now request captains to felicitate our respected pilots and move towards the felicitation terminal. For the next session, I would like to invite our captains, Dr. Rakesh. Yeah. Dr. Anil Kumar sir and Dr. Ravindra Jharia sir. I now request Dr. P.C. Manoria, sir, pilot of this session. Dr. Anil Kumar, sir, the captain of this session. I would like to invite Dr. Anil Kumar, sir. Sir, you can start. Over to you, sir.
Good afternoon, everyone. I have been knowing Dr. P.C. Manoria. He's from Bhopal and a classmate, a batchmate of one of my brother-in-law and sister-in-law, a very well-known person from Bhopal. I invite him to talk on this new topic of lipoprotein A. Over to you, PC.
So for the next 12 to 15 minutes, I'll be talking on lipoprotein A, a genetic time bomb. But before delivering the talk, let's see some interesting case scenarios. Now, this is the story of a 40 years old male who does not have any conventional risk factor for coronary artery disease, but his father died of AMI at the age of 35. The lipid profile is displayed on the screen, and you can see his LDL is 100. He doesn't have other risk factors for coronary artery disease. He consulted his physician and he was told that you are a low risk for ASCVD because you don't have any conventional risk factor, your LDL is okay. But the next week, he gets admitted with acute intraseptal myocardial infarction, develops cardiogenic shock, CAG LAD is 100% and multivessel disease, unfortunately dies. Blood was sent for lipids. So where is the error? Any comments from the postgraduates? The error is you should do LPA if there's a family history of premature death. His father died at the age of 35. And therefore, this patient who does not have any conventional risk factors for coronary artery disease, his LDL is okay, he still is at a very high risk of coronary artery disease or ASCVD. Therefore, patient with a normal or near normal LDL can get AMI because of the hidden risk of lipoprotein A. Lipoprotein A estimation is recommended across the globe by all guidelines before the age of 18 or earlier if you have a premature history of ASCVD, but the screening is suboptimal across the globe, not only in India. This is the second case scenario. 50 years old male, physically active, does not have any conventional risk factor for coronary artery disease, had PCI for LAD 3 years back on high intensity statin plus ezetimibe. His LDL is okay, 42. But after 2 months gets admitted with NSTEMI and now his right coronary artery shows 90% occlusion. Second PCI is done. Again, where is the error? The error is LPA has not been estimated, and therefore the message is even if your LDL is to target and if your LPA is elevated, you are still prone for recurrent coronary events. Another case, 40 years old male, no diabetes, none of the other conventional factors, his LDL is only 90. He gets calcium scoring done, and to his surprise, it is 650. So whenever you get a disproportionate calcium scoring compared to your LDL, again, the culprit is LPA because LPA is also procalcific, proatherogenic. So his LPA is also procalcific and proatherogenic. Another case, 30 years old female came for medical checkup because of detection of murmur by a family physician, no history of rheumatic fever, diagnosed as mild aortic stenosis. 2 years later, he developed severe calcific stenosis. Again, if somebody rapidly develops aortic stenosis severity within 2 years, culprit is again LPA. So when we look at the issue, can elevated LPA is a risk factor for ACID but also a risk factor for valvular heart disease? The answer should obviously be aortic stenosis. Another individual, 30 years old male, sudden right-sided weakness of body, CT shows in MCA infarct, no AF, normal carotids, thrombopilia panel normal, diagnosed as cryptogenic ischemic stroke, but the culprit is again LPA because not only pro-atherogenic, it's also pro-thrombotic. Last case, 42 years old male, came for follow-up after PCI, LAD for stable angina, lipid profile, his LDL is 180, and he is on rosuvastatin plus ezetimibe plus bempedoic acid. But follow-up after 12 weeks, the LDL is still 135, which is a surprise because once you use a triple therapy, LDL should drop to low levels. Again, the error is when you estimate LDL cholesterol, it is a combo of LDL cholesterol plus LPA cholesterol. So if your patient does not respond to statin, suppose you give a high intensity statin, it should drop by 50% or 40 to 50%. If this is not happening, this is another way to suspect the patient is having raised LPA. So if there is suboptimal response to statin in your day-to-day practice, don't forget LPA. Unfortunately, LPA screening is very, very suboptimal across the globe. The incidence is 25%. So 25% of people sitting here are having LPA elevated. So your heart wants to say something to you. Measure LPA in all individuals before the age of 18 or earlier if there's a family history of premature STD. But the screening, as we said, is very poor across the globe, not only in India. So let's see why we should know about LPA. The first reason is it is 6 times more atherogenic than LDL. Why? Because it's pro-atherogenic, pro-thrombotic because of homology to plasminogen, pro-inflammatory, pro-calcific. The second reason why we should know LPA, it is the most prevalent genetic lipoprotein abnormality associated with atherosclerosis. You can see the prevalence, South Asians is 25%. 1 out of 4 has elevated LPA. Global burden 1.43 billion and South Asian contribute 469 millions. The third reason is it is increased since birth, so atherogenic risk starts accumulating since birth, and the cumulative exposure of the vessel wall to LDL and LPA, which are the major determinants of premature atherosclerosis. So atherosclerosis occur prematurely with LPA. It is causally related to ASCVD and AS. Data from panoply of trials shown on the screen, or whether you talk of meta-analysis or Mendelian randomization or genome-wide association, it is a causal relation between LP and ASCVD, and the hazard ratio you can see is 3 to 4 for CAD and 3-fold for AS. Rapid progression of AS, don't forget LPA. Suboptimal response to statins, don't forget LPA. But the most important why we should know about LPA, a lot of trials with pelacarsen and small interfering RNA are ongoing. And hopefully if these trials come out to be positive, LPA-induced cardiovascular disease may be transformed from an orphan disease to a self-resolved disease. So what is LPA? LPA is nothing but is composed of one molecule of LDL, which has an ApoB on it. And this is attached to one molecule of ApoA by single disulfide bond. And this ApoA is composed of many kingles, and kingle 4 has many subtypes. The more the subtypes, less it is atherogenic because the number of particles less. So if it is less than 22 kingle 4 V2 repeats, small isoform, which is more atherogenic compared to large isoform, which is more than 22 K4 2 kingles. LPA should be estimated by isoform independent method, and the normal value is it should be less than 30 milligram per DL. Less than 30 milligram per DL, and after 50 it is very high risk, in between is gray zone, but it is preferable to measure in nanomoles because it indicates the number of particles. Milligram per DL does not indicate the number of particles. Less than 75 is normal, more than 125 is highly atherogenic. All guidelines across the globe recommended estimation of LDs at least once in lifetime, as we said. And if your LPA is more than 180, the risk is equivalent to FH, which is a deadly disease. If you have both LPA and FH combined together, is very deadly, as you can see on the screen. So let's talk about LPA therapeutics. This is a place which is vacant. No drug is approved for LPA at the moment. But what can we do at the present state of time? If you control all the risk factors vigorously, you can reduce the atherogenicity of LPA by 66% as shown in this. So if you have a raised LPA, control all your risk factors to the targets. Aspirin is the only condition which is recommended for primary prevention of cardiovascular event. Otherwise, we do not use aspirin for primary prevention unless the case is very, very high risk. But aspirin for elevated LPA is mandatory because this is also prothrombotic. You can see the benefit of aspirin. LPA apheresis is a guideline approved therapy and it decreases the MI, it decreases cardiovascular events and MACE. But what is the future? In future, several drugs are being evaluated. Pelacarsen, which is an antisense to ApoA, 3 small interfering RNAs, we'll see Movalaprin, which is an oral molecule, CETP inhibitor, obicetrapib, and gene editing with CRISPR-Cas9 technology. Now, these are the 3 small interfering RNAs, olpasiran, which is being tried in the OCEAN trial, lepodisiran, which is being tried in the ACCLAIM phase 3 trial, gelbasiran, which is finished phase 2, Elpacar, and is now being tried. The beauty of these drugs is that they decrease LPA by 95 to 98%, unlike pelacarsen, which decreases by 80%. Then we have this small interfering RNA, oral molecule, movalaprin, which decreases LPA by 65%, the only oral molecule. Otherwise, other therapies which are being evaluated are all injectable therapies. This is pelacarsen, an antisense to ApoA, and it produced very good results in phase 2 trial. 98% of patients, the LPA was dropped to less than 50. And the Horizon trial is ongoing. The results are expected this year, and hopefully it may come out to be positive. CETP inhibitors were used for elevating HDL. All trials failed, but now this CETP inhibitor, obicetrapib, is now being evaluated for LPA, 54% reduction in LPA, and also, of course, for LDL reduction. So it is being transformed from HDL therapy to LPA and LDL therapy. CRISPR-Cas9 gene technology is a unique technology which can target LPA gene, and this is a single-time treatment for the rest of the life, but this is being evaluated. What are the futuristic strategies for LPA management? Pelacarsen, small interfering RNA, because it is pro-inflammatory. Colchicine is being tried because it is prothrombotic. Low-dose rivaroxaban is also being tried because it increases platelet adhesion. So aspirin is being tried. And of course, the research is CRISPR-Cas9 technology, which is a gene editing technology. What can artificial intelligence do? With this, we can identify people with high LPA before they become patients with high LPA. Interestingly, diabetes has an inverse relationship. So if your LPA is high, the chances of development of diabetes are much less. And therefore, in summary, elevated LPA is an independent, powerful genetic risk factor for ASCVD and calcific AS. South Asians have the highest global share of elevated LPA, 469 millions. 1 out of 4 is suffering from raised LPA. LAI recommends initial screening for LPA at 80 years or earlier if there's family history of FH or premature ASCVD. At present, no drug is approved for treatment of LPA. Lipid apheresis is the only FDA-approved treatment for lowering LPA. But pelacarsen, an antisense, which is a gene technology, and 3 small interfering RNAs are being evaluated. Movalaprin is an oral molecule, and if these trials hopefully come out to be positive, LPA-induced disease will become a salvageable disease, and gene editing by CRISPR-Cas9 technology is being tried, and if it comes out to be successful, this will become a single one-time treatment for the rest of life. It has been found to be successful for lowering LDL cholesterol. What are the unresolved issues in LPA? The current lab method do not allow discriminating between LDL and LPA cholesterol. So when you measure LDL cholesterol, it is a combo of LPA cholesterol plus LDL cholesterol. That's why I say if the patient does not respond to statin, suspect LPA. The racial and ethnic disparities vary across the population. The reason for these disparities are not well understood. Asians have 25%, South African 30%. The interaction between LP and other severe disorders like diabetes requires further study. No dedicated trial of pelacarsen or small interference is ongoing for primary prevention. What trials are ongoing is only for secondary prevention. So it will take a lot of it. The screening for LPA is very, very poor across the globe, including India. Thank you very much for your time.
Thank you, Dr. Manoria. You gave a very lucid talk on LPA, and the take-home message I would say is at least everyone should do LPA once in a lifetime to know about it, and always keep the LPA less than 30 milligrams. Thank you.
Thank you, Jaria sir, for your valuable insights and active participation.
Do we have questions? Because we are running short of time. Okay. आवाज नहीं है. Okay.
Not audible. Mic is not working.
Hello.
Hello. Sir, why do we need to screen for lipoprotein A universally if there are no currently approved pharmacological treatment available to lower it?
Yes. We still screen because you can reduce the atherogenicity of LPA by 66% if you control all your risk factors. If you happen to have, along with FAH, apheresis is an approved treatment. So even if you don't have these drugs, still, because I tell you your LP is elevated, you will control all your risk factors very strictly. That is the reason we screen for it.
I think my question also remains the same. Basically, you mentioned 6 cases where you have shown high LPA. Suppose we could have done it, I don't think we could have prevented any of the events which happened in those patients because there is no approved treatment as on date. Maybe in future, yes, but as on date, I don't think we could have done anything more except for telling the patient that you have got elevated risk. That's it.
If LP is elevated with FH, PCSK9 is a guideline recommendation for treatment because there is many times.
None of them are
Yes,
FH.
for FH and LP, it is a guideline recommended. For other condition, it can be used as an offline. At the moment, we don't have. But because PCSK9 decreased by 25 to 30% LPA.
Sir, we have been traditionally taught in early years, almost 10 years back, that it is a non-modifiable risk factors. So I feel that's one message which still holds true. It's a non-modifiable. There's no therapy at this moment of time. But I feel you are very correct that if you diagnose it, that you can be more aggressive for correcting all other factors which are responsible for it. I feel that's what
Hopefully,
the
it will
message
become modifiable in the dicta. You estimate only one time. You may be repeating it again and again after this trial comes out to be positive. Then we'll see how much the LP has been reduced. But that is the future.
Statin therapy increases LP.
Yes, yes.
How do you manage that?
See, statins, they increase the synthesis of LPA. They increase by 10, 11, sometimes even 15%. But this does not mean you don't use it. Statins have to be used if your LDL is elevated. Doesn't mean your LDL is elevated, LPA is elevated, don't use. Statin has to be used. The increase in LPA, the harm is much less than the benefit of lowering LDL. So still it becomes an indication, very strong, rather class 1A indication.
No. Next. Thank you, sir. I now request Ravindra sir to felicitate our pilot at felicitation terminal. For the next session, I invite Dr. Vinod Mittal sir, Director, Delhi Diabetes Care Center, and Dr. Amit Achalia sir, Senior Consulting Physician from Amravati. Dr. Ajay Yadav sir, pilot of this session. Is from Nepal. all the way from Nepal.
Good afternoon, everybody. From the earlier speakers, we have already seen that the Indian phenotype, they are more insulin resistant and we have more of carb in our diet. With that background in the mind, I'll now invite Dr. Ajay Yadav sir for this important topic on the future of glitazone, glinites and AGIs in this world of semaglutides and tirzepatide.
Thank you, Chairperson. First of all, I want to thank Sunil sir and Kavita ma'am for giving me this opportunity. So, like on the born of the new baby in the house, don't forget the older one, because the older one is going to good care of the new one. So, shifting type 2 diabetes in the paradigm, that modern dominance, like the era in the dominance of the SGLT2 and the GLP-1 RA, dual antagonist, focusing heavily on the cardiovascular, renal, and the severe obesity endpoint over the pure glycemia. The legacy means is despite modern advance, older OAD remain the clinically relevant for the specific pathophysiology target, distinct phenotype, and the pharmacoeconomic reality. South Asia phenotype, high insulin resistance, as Saurabh told, and distinct dietary habit, high carbs, and the early onset beta cell decline, mandate tailored regional guideline. So according to the ADA and the RSSDI, both guidelines, like emphasis like on the ESV and heart failure and the CKD, like pioglitazone was the insulin resistance stroke secondary prevention, that is on NAS and the muscle management, and the glinide and the AGI generally disparitized in the global algorithm, recognized mostly for the cost-effective or the extreme niche cases. So phenotype centric, enclosure of the thin fat Indian characterized by the high truncal obesity and the severe insulin resistance, AGI performance the high placement of the like as our diet content 70 to 80% of the carbs, heavy Indian diet having the severe postprandial exhaustion. So early combination advocate for the early initiation of the metformin plus DPP4 plus pioglitazone to tackle care defect of the synergistic. So glitazone, resurrection or the retreat, like trifecta effect of the pioglitazone, like targeting the insulin resistance, NAFL, and the fat redistribution for the metabolic balance. So type 2 diabetes and the NAS are the both subsequent of the insulin resistance. So NAS is the largely unrecognized complication of the insulin resistance. So over the insulin resistance, insulin sensitizer like thiazolidine, the lead to the better the exchange and the lower the free fatty acid. So like the promote the fat cell differentiation, reduce lipolysis, and the alternative adipose level to decrease the to increase the insulin sensitizer. So protection of the multiple organ by the pioglitazone, like the brain and the vascular, decrease the 47% secondary stroke prevention, as the like the proactive trial have shown, and reduction of the carotid intima, media thickness, heart and the coronary, like decrease the 28% of re-infarct, that is proactive trial, and decrease the 37% acute coronary syndrome, stop progression of the atherosclerosis. So kidney and the renal benefit, decrease EMI, stroke and the death in the CKD, decrease microalbuminuria, and liver, that is NAS. Reduction of the inflammation and the necrosis, decrease 50% risk of the hepatocellular carcinoma. So position of the pioglitazone, like first oral agent, insulin resistance patient with the renal impairment and the cost concern. Second oral agent in the insulin resistance, like on the top of the metformin insulin at high risk CVDs. And third oral agent, triple oral therapy, when to avoid injectable seems preferable. And the injection on the top of the insulin when large dose of insulin fail due to the insulin resistance. ACT now a study result, like trending down, 72% reduction in the development of the diabetes. So IRIS study also, like 24% after the 1S, that the pioglitazone reduced the insulin resistance. So globally, we have the muscle in the type 2. Subsequently, we can see that muscle is increasing day by day. like 65% of type 2 diabetes with the muscle. And it is increasing subsequently day by day. So, role of pioglitazone in NAS, like decrease insulin resistance, decrease fibrosis, decrease lipid concentration, and decrease inflammation. Majority of meta-analyses have proven that pioglitazone is both safe and effective in the treatment patient with the NASH, even in those with the significant fibrosis. So ADA 2026 also strongly recommend pioglitazone recommended in the patient with the type 2 diabetes and the NASH. So combination therapy with the GLP-1 RA plus pioglitazone reduce the greater and the more durable reduction in the HbA1c than the controversial therapy and the prevent the increase in the body weight over the 3 years period. However, it does not prevent the decrease in the BMD in the women above the 50 years of the age. RSSDI guideline, like strongly like TZDs are highly recommended as the add-on therapy when the insulin resistance dominates. Suglinide, the forgotten secretagogue. Meglitide is a modern diabetic management. So physiological loss, early phase insulin secretion, like defective dynamics, loss of the early phase insulin release lead to the rapid post-meal spike. Vascular stress, these rapid post-meal excursion cause a high level of the systematic oxidative stress and vascular danger, that is a fluctuation spike damage the capillary wall and the fuel progression. Glinide fix the targeted sulfonylurea receptor 1 action, like replinide act on the sulfonylurea 1 with a faster binding dynamic than the sulfonylurea. Rapid clearance, fast onset of mimic the natural insulin pulses. And postprandial glucose suppression, preferably timely postprandial, controlled with the limited of target effect. So glinide as with sulfonylurea, as we can see, like it is better in minimize risk of the late phase fasting hypoglycemia. It prevents the severe hypoglycemia. So managing glycemic variability, oral meal, one dose, strictly with the food, fasting. Scenario provide the highly clinical safety during the complexity reducing fasting, such as the Navaratri fasting and the Ramadan, and the vascular protection, reducing the sharp glycemic spike, protect against the cumulative endothelial damage. So niche use of the CKD and in the elderly, like it is a highly reliable option in the moderate to severe renal impairment. In older, it prevents the severe hypoglycemia. Glad beyond the 2026, where do it fit? Like irregular, if there is a irregular meal pattern, like ideal of the shift worker, elderly patient, Ramadan fasting, and the patient with the gastroparesis. Postprandial glucose targeting, ADA 2026 position, the glinide use should be limited due to the lack of severe renal benefit and the increase the hypoglycemia risk. Elderly increased fracture risk. Renal impairment, like no dose adjustment required in the rapaglutide and natiglutide, ADA 2026, and the resources limited setting, and the triple combination strategy. So AGI, the undisputed cornerstone for managing the carbohydrate heavy South Asian diet and the severe postprandial excursion. So as we know, our diet contains high carbohydrate. So enzyme inhibition and the microbiome modulation and the endogenous GLP-1 should be needed. So postprandial excursion blunting, as we can see, there is a like control standard meal, there is a spike, but in the after the AGI, meal plus AGI therapy, there is a blunting. The AGI mandate, first line utility. RSSDI support AGI usage immediately upon the diagnosis for the patient with the isolated postprandial hyperglycemia and the common presentation in the India. Strategic combination, high endothelial in the fix of the combination with the metformin and the DPP-4, voglibos metformin to prevent the comprehensive weight neutral glycemic approach. So cardiovascular neutrality and the pre-diabetic prevention. Legacy modernity, like pioglitazone plus SGLT2, yin and yang that shows that pioglitazone primary adverse effect is the fuel retention, that is edema. SGLT2 inhibitors naturally promote the osmotic, diuretic, and the sodium excursion. So metabolic boost, combination powerfully insulin sensitizer with the profound calorie glucose dumping result in the cellular HbA1c reduction. So AGI plus DPP4 got best synergy, and the clinical result exertion carotid and the PPG spike with the absolute weight neutral and the near zero hypoglycemic risk. So cost effective is the most concern, like accessibility gap. Despite guideline universally recommended novel agent, SGLT2, GLP-1 RA, widespread implement in the South Asia is severely hindered by the out-of-the-pocket cost. Financial reality, glitazone, glenide, and the AGI available as a high affordable, heavily tested generic, and the value-based scale, when used precisely in the right phenotypes, these older drugs deliver the exceptional cost to the benefit ratio, preventing the long-term microvascular complication without financial burden on the patient. So clinical decision framework, who gets what? Like type 2 diabetes, muscle, and dyslipidemia. So pioglitazone 15 to 30. Type 2 diabetes, CKD stage 3 to 5, irregular meal pattern. Soraplugin will be the better option. Type 2 diabetes and the high carbohydrate Asian diet, post-prandial dominance, voglibos will be the, and acarbose will be the better option. Type 2 diabetes plus insulin resistance phenotypes, weight increase and TG increase, HDL decrease, pioglitazone will be the better option. So pre-diabetic, impaired glucose tolerance prevent the target, acarbose 25 to 100 and voglibos 0.2 mg TDS. So type 2 diabetes plus post-ischemic stroke, no diabetes like pioglitazone will be the better option for the secondary prevention. So for the research front end, what next beyond 2026? That is TG date. So there is a a study, lots of trial is going on, and there is a pioglitazone plus GLP-1 RA for the Alzheimer prevention. And glenide, rapaglinide, there is SGLT2 combination of the rapaglinide plus SGLT2 for the CKD patient, addictive PPG benefit. And alpha glucoside like acarbose have an anti-aging effect, and trial of anti-aging form ITP mouse data shows that there is an anti-aging effect, and the study should be needed. So South Asia perspective, high carbohydrate diet pattern, rice, roti, and the noodles, and muscle epidemic in both Nepal and India. Religious fasting with glenide, rapaglinide especially are the ideal. Dose only when the eating, skip when the fasting provide the flexibility of the religious practice. So lean type 2 diabetes phenotypes, lower BMI, high visceral adiposity, pioglitazone addressing the visceral adiposity. Affordability and accessibility advantage and pre-diabetic burden. So key takeaway message for the clinical practice, pioglitazone remain the only anti-diabetic drug with the proven history benefit in the muscle and the mass in the GLP-1 era. It is a potent, cheap evidence-based add-on, not a drug to discontinue. Glenide occupy a precise niche, irregular meal schedule, advanced CKD, and the resource-limited setting. AGI are the underutilized in the South Asia, despite being the ideally suitable to the high carbohydrate diet. Voglibos and the acarbose prevent the type 2 diabetes by 36 to 40% RRI, reduce the CV event, and modulate the gut microbiota. The anti-aging biological of the acarbose and the exciting front end for the further trial. ADA 2026 standards support that individual phenotype-based prescribing these three drugs classes used in the right patient, completed GLP-1, RA, and SGLT2 with the unique non-overlapping mechanism. So precision medicine in diabetology is not merely about utilizing the newest molecule, but deploying the right molecule for the exact pathophysiological defect. Thank you.
Thank you, Dr. Ajay Yadav, for that enlightening talk. And yeah, it's clear that all the molecules going to stay. Especially pioglitazone is the only insulin sensitizer available. And for MASH, after GLP-1, the second agent is pioglitazone today for diabetic patients, and then SGLT2 inhibitors. So combination of pio and SGLT2 is also there. And other two are again for South Asians, Indian people, high carb, so postprandial excursion, which is a cardiovascular risk marker, high glycemic variability. So I mean, in the past we used to call these molecules as poor man's Lispro.
Yes, sir.
But the only thing is, they have to given 3 times a day, 3 meals, 1 time of the day, 1 meal. So the compliance may be a problem in patients where it is to be given 3 times. So with this, we can have one question from the audience, else we move to the next talk. Okay, so we move to the next session.
Thank you.
Thank you.
Thank you.
I request our captain to kindly felicitate our speaker. For the next session, I invite Dr. Vasant Kumar, sir, Senior Consultant Physician, Apollo Hospital, Hyderabad, and Dr. Ramesh Munle, sir, Professor, Department of Medicine at NKP Salve Institute of Medical Sciences. For the next session, I call Dr. David Hopkins from UK.
Good afternoon, friends. I think now it's time for us to listen to one of our dignitaries who has come all the way from UK, Dr. David Hopkins, who is going to speak to us about managing hypoglycemia, the present and the future. So thank you, Dr. David, for taking the trouble to come all the way to us. So we look forward to listen to you.
Thank you very much. Just to start off with, just a few people have asked me where I'm from, and so I thought I might just clarify that. But I currently work and live in this island, Jersey, which is a very small island off the coast of France, but is actually a self-governing part of Great Britain. But most of my work that I'm going to be presenting is from my work at King's in London, where I spent most of my career, and where I, in the 1990s, with my then mentor and colleague Stephanie Emile, set up a specialized hypoglycemia clinic. So I've been spending most of my career looking at hypoglycemia. And in looking back, I think it's quite useful to think about some of the historic background to diabetes. Going back to the 1920s, before we had insulin, type 1 diabetes was a fatal disease with severe wasting, dehydration, coma, and death. And thus, the actual appearance of insulin and the changes that that brought about was really dramatic. These photographs are of the first person to be treated with insulin, and there he is later after recovery. And this quote is from one of the other first people to get insulin, unspeakably wonderful. However, with insulin, hypoglycemia became became a problem quite early on. And these are quotes from the first couple of years of insulin treatment. So-called insulin reactions, what we call hypoglycemia, were recognized very early. Insulin, not a cure, a potent preparation for evil and good. And this is remarkable. This is from 1923 by Banting, and it is a description of the symptoms of hypoglycemia, which is exactly how we would describe them today. And interestingly, the problem of hypo-unawareness, which I've spent a lot of my career looking at, has also been described very early. This is again from 1922, this quote from Jocelyn. And R.D. Lawrence, who himself lived with diabetes for 40 years, clearly described losing his symptoms of hypoglycemia, and that also observed in his patients. So moving on, in the 1970s to the 1990s, there was increased recognition of the importance of type control. In 1993, this landmark study, the DCCT, showed the importance of tight blood glucose control. But it also showed that achieving tight blood glucose control at that time mostly meant increasing hypoglycemia. And here, with improving control here in glycemia, there is an inverse relationship with hypoglycemia rates getting extremely high when the best levels of blood glucose control were achieved with the tools that were available in the 1980s and early 90s. And I was very struck yesterday by a presentation by Dr. Patel in the other room about the dead in bed syndrome. And he described some of the first presentations of that in around 1990. And indeed, when I first started in diabetes was around that time. And this was the burning question, the high numbers of young people dying of hypoglycemia, which sadly still happens. These quotes are from 2015 of 2 cases of hypoglycemia death in the UK press. And I was really struck just a couple of weeks ago in my clinic. In one clinic, I saw 3 people with type 1 diabetes who had lost siblings with diabetes to hypoglycemia. So death from hypoglycemia is still a major issue. And apart from this tragic cases, there are very broad issues with hypoglycemia. It may contribute to cognitive impairment, and recurrent hypos make more severe hypos more likely, and it has impact on memory formation, which may impact on learning in children in particular. But also there are significant cardiovascular effects with risk of ischemia, arrhythmia, and increasingly recognized pro-inflammatory and pro-coagulopathic effects, which may explain the very high numbers of cardiac events occurring after episodes of hypoglycemia. And then there are social factors, falls and accidents, and I've seen several people with major trauma related to hypoglycemia, and loss of privileges, including driving, but also social isolation from not being able to do your normal activities. So extensive problems. So how do we define hypoglycemia? And I think this is important. We've often lacked a good quality definition, but in 2017, an international study group came together to create a consensus. And this now defines hypoglycemia as 3 levels. Level 1, 70 mg per deciliter, which is actually within the normal population range for blood glucose, is a good warning point of incipient significant hypo. But 54 mg per deciliter is now classified as level 2, which is clinically significant. And this is the level at which cognitive impairment starts. And then level 3, or severe hypo, has no glucose threshold, but is defined by the fact that you need help from another person to manage this. And one of the reasons why we get to level 3 is hypo-unawareness, which I've studied quite extensively. And these are data from studies done in the 1990s, looking at people without diabetes, people with diabetes with no hypo issues, and people with recurrent hypoglycemia who had lost their awareness of hypos. On the left, this is the adrenaline response to experimental induced hypoglycemia in a controlled manner, where we brought patients' glucose down progressively to 2.4. And this is a standard questionnaire symptom response measured repeatedly at different glucose levels. And you'll notice that in the aware patients with type 1 diabetes, there was some significant blunting of the adrenaline response. But despite this blunting, they still had the same symptoms as those without diabetes. But in those with problematic hypoglycemia, there was virtually no adrenaline response and virtually no symptoms. Indeed, some patients had 0 symptoms, right down to 2.4 millimole per liter. And this is why they become so at risk, because they become cognitively impaired before they can act. So what are the approaches to managing these patients? Well, as I say, we developed a specialized clinic as a national referral point for people with problematic hypos. And we basically look at optimizing insulin, education, technology, and transplantation. And I'll briefly go through those. Firstly, and I was reminded yesterday about the challenges of different strengths insulin. In Europe, we now only have U100, but I recognize here you have U40, and it could be catastrophic of using a U40 syringe with U100. Indeed, I had a case from Russia who moved to London, and in Russia they use U80, and he was using English U100 with a U80 syringe with unexplained hypos at the same dose until we realized it was the insulin. In terms of specific changes with insulin, we recognize there's less hypos with NovaRapid compared to the original soluble insulin, and Afrezza inhaled insulin also has less post-meal hypos. Of the basal, Tresiba is the only insulin that has been shown to have statistically significant reduction in severe hypoglycemia, and we do use Tresiba as our main basal insulin in those on MDI who have problematic hypos. Also then moving on to education. Now, looking at the approaches to this in the UK, RDL, who was our founder of my clinic, he introduced the line diet back in the early days of insulin, which was very rigid amounts of carb through the day with matched insulin. This was largely abolished in the 80s, which was actually also the time when hypos became more problematic, perhaps because there was more chaotic matching of insulin to carb. And this wasn't working. In Germany, Michael Berger and Mulhauser in Dusseldorf, Germany, they presented data that showed very low hypo risks and better control than elsewhere in Europe, with an approach of therapeutic education, teaching people in great detail about managing diabetes and insulin. And in 1998, a group led by my colleagues Stephanie Emile and Simon Heller from Sheffield went and observed this program in Germany, and on the basis developed a UK version which became known as Daphne. And Daphne has been rolled out very widely in the UK as our main education for people with type 2 diabetes, for type 1 diabetes. And at the outset of this, I set up a database so we could collect data on all people having Daphne. And what we saw is moderate improvements overall in HbA1c in the real world, but very significant reductions in improvements in quality of life. And when we looked at severe hypoglycemia, 25% of people coming into Daphne had at least one severe hypo in the last year. And among this group, there was a very substantial reduction in mean severe hypo rate from 7.8 to 1.6. And half of the patients reported restoration of awareness at 1 year post-Daphne, showing that an educational program could manage severe hypoglycemia. This has been taken further by my colleague Stephanie Emile, who developed a specific program called HeartDoc, which uses behavioral clues to try and help people recover awareness of hypoglycemia. And in the States, a similar program called BGAT also focuses on clues to changing in sensations. And both of these have been shown to reduce severe hypoglycemia. Now, what about technology? Again, I want to say that nothing's new. 1963 was this portable insulin pump that never quite took off. And in the 1970s, the Viastat laboratory device, which provided the first closed-loop systems. Since then, there's been a massive evolution technology right through to our current closed loop. And this has become the mainstream for how we managed hypos and kings. And particularly the introduction of low glucose suspend was critical. This is one of our early patients with the first low glucose suspend pump, and there's a nice example of a suspend. And these were really revolutionary for people who are having hypos because of shutting off the insulin supply. However, the low glucose suspend is critical. This was before we had low glucose suspend. And note this person had significant nocturnal hypo and slept through all of these alarms. So the suspend function is important. Also, the alarm fatigue can be a problem. This was somebody who had severe hypos at night, also had hypo in the day. But because of the effect on their family life, they stopped the alarms at night and stopped the sensor. So they had no warning when they were asleep. Hybrid closed loops have made a huge difference. And this is a sample from a patient I saw, a 30-year-old recently with hypo problems. Now got beautiful control. but still occasional days when they do lose control despite closed loop and still have some hypos, but has had no more severe hypos. And in the UK now, we're very lucky in that the hybrid closed loop technology has been broadly rolled out and is available now for most people with type 1 diabetes if they have a sustained A1C above 58 or 7.5% or have hypoglycemia. So what about those who don't have still have problems with closed loop? Well, the next step is transplantation. And at King's, we've run a transplantation clinic since the early 2000s. This followed the success of the Edmonton Protocol, which was the first glucocorticoid-free immunosuppression regime and demonstrated insulin independence in a group of patients who they managed with this protocol. And following this, there's a UK program with transplants across several centres, and there are about 18 to 24 islet transplants a year in the UK, which is now NHS funded for those who need it. This is just very briefly the islet procedure from the King's lab. Pancreas is taken, cadaveric pancreas, digested and progressively purified before it is infused radiologically into the portal vein. And just as a case study, this is one of our patients who had prolonged severe hypos despite closed loop. And here, not perfect, still some hypoglycemia, but no severe hypo post-transplantation. Globally, there have been now over 1,400 individuals who've had a transplant, predominantly in North America, parts of Europe, and in Australia. And the outcomes are very good in terms of hypoglycemia, the lower bar, with the prevalence of hypoglycemia after transplant is prolonged for 5 years, even if the patient does not remain insulin dependent. And just to put it into context of one case, this was our second King's patient who had a transplant in 2003, totally debilitated by hypoglycemia. Actually did no exercise. And less than 1 year after the transplant, she carried the Olympic torch through London. Never got off insulin, but got down to 4 units with a HbA1c of 6.4. And she was free of all hypoglycemia with minimal doses of insulin for 6 years after this. In terms of the future, well, 20 years on after Edmonton, islet transplant's still a niche, and there are major barriers to implementation. Limited supply of islets, lack of long-term independence of insulin. And we're not at the stage yet. But will bioengineered islets move us forward? And that is really the next question. And we are now getting the first artificial islets, and the first one of note is this drug, this preparation, Zimslecel, which has just completed phase 2 studies. Just to highlight, it really is an islet, and this is crucial. It's not just beta cells, but the complication is derived from human embryonic stem cells, but you need the full range of islet cells, and the mesenchymal cells are critical to the function of the intact islet. Their phase 2 study with 14 participants was recently published. These were selected on the basis of severe hypos, so very much like our King's patients, and 12 were insulin independent at 1 year and or free of severe hypos. So very exciting and promising data. Of note, though, they did have 2 deaths, one directly related to immunosuppression. An ongoing requirement for immunosuppression will be an issue with this kind of treatment, though I do see this becoming more mainstream as time goes on. So to put this together, we now have a clear sort of pathway for managing hypoglycemia. And this was put together by one of my colleagues, Pratik Chowdhury, who's now a professor in Leicester, that's trained with me at King's. And this is really based on the way that we work things through the King's model. Starting with structured education, together with hypo-specific education if needed, moving on to use of insulin pump, and this is a bit out of date now, then sensor augmented pump, but now we go straight to closed loop with everybody. And when this fails, islet transplantation. And in fact, in the clinic that we run for Isles, King's hasn't actually done a transplant for the last 3 years. And this really shows the fact that the closed loop has been revolutionary in managing these patients. The vast majority who are now referred for islet transplantation consideration are sorted with technology. And that really does make a difference to most people. So I'd like to conclude on that point and say that, hypoglycemia is still a challenge, but there's been amazing progress, and in the course of my career, a greater degree of progress than I would have anticipated 25 years ago. Thank you.
Thank you, Dr. David. It has been an amazing experience of you in managing patients of hypoglycemia in type 1 diabetes, and you rightly said there is a hope for patients of type 1 diabetes with the help of islet cell transplantation. Are there any questions for Dr. David?
I think finally what we hear from Dr. David, the best thing would be to prevent hypoglycemia, and especially in a setting of unawareness and so many things. And so how do we prevent is teaching the patients using proper insulin and in proper dosage, as you mentioned.
Yeah, and I think it's also teaching early, because hypo-unawareness develops over time. So in our clinical practice, everybody goes on the DAPHNE program within the first year of diagnosis. So we really focus on teaching in the right way to use insulin. And for type 1, we pretty well use exclusively now Tresiba and the quick-acting insulins like NovoRapid or Humalog right from the start. And anybody who's getting problems with hypo, we do move quite quickly to pump now. Also in pediatric practice now, insulin pumps are used virtually from the start in the UK. And I think that will also reduce, because the cause of hypoglycemia unawareness is those milder hypos occurring. And if we stop that happening, then hypo-awareness is preserved.
Yes, sir. Especially in geriatric population, as you said.
Absolutely.
That's why we are looking at the higher targets. Don't
Yes,
try to
absolutely.
over-jealously manage diabetes in older people, which can lead to hypoglycemia, as you mentioned. Friends, so you have, Dr. Sunil?
I feel once you have hypoglycemia unawareness, which is practically it's a clinical diagnosis, and we do that the only treatment which at this moment of time for hypoglycemia unawareness is avoid hypoglycemia. That's what sir said, that you have to keep it, that your target should be not be now 70 to 180, target could be maybe 100 to 200. So I feel this could be also treatment of hypoglycemia unawareness is avoiding recurrent hypoglycemia. And I feel there are wonderful encouraging results of your islet cell transplant. That's what I wanted to share, because I could not see a single orange bar there in our country,
sure.
but most of them are in US and
very
from
much,
the European.
very much North America and Northern Europe.
So we have to, but we are still we have some promising future of this.
Dr. Sunil, you think the future is promising? Maybe we are going to get some newer technologies.
Hope is always
the future is not immediate; it's a distant future.
But
But
by
let's
that,
hope.
till we achieve this hope of having beta cell or islet cell transplants or pancreas transplant as a reality, we have to keep the organs of our type 1 diabetes fit to sustain this transplant.
Yeah. So we profusely thank Dr. David for this very elaborate and lucid talk. Thank you.
Thank you, sir. I request our captains to kindly felicitate our pilot. I request Dr. Sunil Gupta, sir, to kindly join.
Now for the next session, we are moving to the flight, our very prestigious HDA Triennial Oration. For this, I call upon Dr. A.K. Das, Professor Emeritus Medicine and Endocrinology, Dean Academic, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapith, Pondicherry, and Dr. Kamlakar Tripathi, Sir, Padma Shri, ex-professor and Head Department of Medicine, Division of Nephrology, IMS Banaras, Hindu University, Varanasi. Dr. Shashank Joshi, Padma Shri, Consultant Endocrinologist, Leelavati, Mumbai.
Shashank? By the time Shashank joins, we will
start this program. Dear friends, it's a great occasion today while we are listening to one of the greatest oration of this conference, the HDA tricentennial oration, and the orator is no less a person than Dr. Arvind Gupta. May I request Arvind to kindly come to the dais. And Arvind Gupta from the city of Jaipur is MD, FRCP, Glasgow, Edinburgh, FAC, FACP, and also FDIV India. He is a senior consultant and head at the Department of Internal Medicine and Diabetes at the Rajasthan Hospital, Jaipur. He has got many fellowships, many awards, including RSDI Gold Medal Oration, Sri Arumugam Award, member of the National Executive Committee of the RSSDI Delhi chapter, past chairman RSDI Rajasthan chapter. So he is absolutely, he has been in the forefront. Now we'll have the celebration of felicitating him. I'll request Professor Kamala Katlebar to kindly join me. Efforts of Edinburgh, FAC, FACP, Senior Consultant and Head Department of Internal Medicine and Diabetes, RHL Rajasthan Hospital, Jaipur, for the women service in the field of medicine and exemplary delivery of oration on the vicious cycle of diabetic kidney disease from early screening to prevention. The Indian experience, DDGCI and DCRC Nagpur proudly accedes to your benevolent service to people living with diabetes and visionary focus in research. We acknowledge distinguished academic accomplishments. You, the investigated, you ignited others by your impeccable virtues and humbly on the humility of your character. It is our most profound honor to present you with the prestigious HDA Tricentennial Oration 2026. During the 13th Hello Diabetes Academia 2026 International Conclave on Sunday, the 20th June 2026 at Nagpur, India, signed by all the officials. I request Professor Kamalakat Tripathi and Sunil kindly present it while you are sitting. Okay, receive it. Yeah. Yeah, I request everybody who says on whatever person invite it to
For ages, centuries and decades, diabetes was being recognized as disease of kidney and still continues to be proteinuria, producer's earliest manifestation, then followed by glomerular disease. So we have lot of development, lot of newer molecule now available for the prevention and to reduce the progression and retard the progression and the slope of the kidney disease. Dr. Arvind Gupta has done tremendous work in basic science and the biomarkers in the prognosis of the diabetic kidney disease and some of the genetic markers he has worked in last 15 to 20 years. So over to you for the oration.
Thank you, chairpersons. And at the outset, I thank my younger brother Sunil, Kavita, Swar, Shlok, and the beautiful family for honoring me on this beautiful and very prestigious oration. Thank you very much for the organizing committee. Probably this is really an honor to present the oration in front of the gurus of Guru, Padma Shri, Professor Kamalakar Tripathi sir, who is the doyen and the legend in the field of medicine, nephrology and endocrinology. And again, another legend, Professor A.K. Das sir. Actually, these legends actually inspires us. And when I was actually just after my post-graduation, I saw them on stage and giving the lectures and about the research. Actually, you inspired all of us. So we owe everything to you. So these are the people actually who inspires for the research. And what I'll be presenting today for my young doctors and the young budding people, then how the research can be done and how this research can be translated as a pharmacogenomics. So let us see some of my journey of the research in the field of diabetes kidney disease. But before that, just a word about I found in Oxford Dictionary about the tricennial. Tricennial, I found it is a 30 years. So exactly 30 years back, I started my first research in diabetic kidney disease, and probably I don't know, this is a coincidence that I'm getting this oration from you. Thank you very much. My disclosures are there. So let us see, really it is a problematic, and this is a storm going on all over the world. Not only in the world, but even our India is the epicenter of diabetic kidney disease. And if you see here, 8.7% global prevalence is there. This is something which is very, very high. And it is actually not only this, if you see the Indian prevalence, and it is around 40% of most of the type 2, most of the diabetes people are affected with the diabetic kidney disease. Very, very high, a very grim situation in the future. And it is compounding by the so many big risk factors which are already going as an epidemic like hypertension, dyslipidemia, obesity, and sedentary lifestyle. And these actually compounding all the diabetic kidney disease. And this type 2 diabetes especially is the leader for the driving for the end-stage renal disease, and actually the people are suffering, real sufferers who are on dialysis every week, every 3 days, financial burden, mental stress, and so many things are going on, not only the patient, but whole family is suffering from the financial and mental stress if the person is having diabetic kidney disease. And this trajectory is unchecked. This is going on like epidemic. And if you see here, this is like in even diabetes, if you see in 2025, it is 1 in 19 adults, and now it is 130 million in 2030 projection. And 2050, the projection is around 853 million population. Just see the people who are suffering from diabetes, and then the suffering from the diabetic kidney disease. And then the cost, how the people are having the cost of inaction. We are not doing enough for the management of type 2 diabetes, and especially the diabetic kidney disease. And if you see the mortality to the tune of around 954 million population dying by diabetic kidney disease. And if you see the disability adjusted life years, 25.69 millions Delhi is there. So this is again a real problem. And epicenter, I told you just now, it is if you see the India's mortality burden, type 1 diabetes population, 15.4 million type 1 diabetic populations are dying with DKD. Type 2 diabetes, around 56 millions. So around 71 million population dying because of the diabetic kidney disease. And this is something nearly 80% of the total population who died with the nephrological complications, very high. And if you see the impaired kidney function, this is in general population. If you see in the general population, 3.2% overall weighted prevalence is seen as a impaired kidney function. This is in general population. And of course, gender disparity is there. Males around 3.8% and females around 2.6%. So it is very, very high. This is in general population minded. And again, if our own study, the ICMR, and I was a part and parcel of, sir is there, the ICMR in diabetes study, and what we found, that there is a regional disparity. And if you see here, the highest risk is found in the Goa and Telangana, which are having 7.4% as compared to the very lowest risk is the Chandigarh, which is around 0.6%. But regional variation is there. Our Rajasthan is also having in between these two highest and lowest risk of the diabetic kidney disease. And the synergistic, we all know that if you have a hypertension, it actually increases the risk sixfold by the diabetic kidney disease. So dear friends, what is the window of this systemic intervention? We need to have the systemic intervention if we want to really reduce this burden of diabetic kidney disease. And the first and foremost is the screening. We have to have the good screening, early screening, or I can say the earliest screening for diabetic kidney disease. And if we found little bit of that, then protection, and these days we have SGLT2 inhibitors, we have the GLP-1 receptor agonists, we have several drugs to protect from cardiorenal burden of the diabetes. And of course, we still need to have a good infrastructure of having the dialysis or any other nephrological protection in the country. So 30-40% type 2 diabetes burden by diabetic kidney disease, it actually causes the kidney crisis in our country. Not in our country, but also all over the world. So dear friends, the million-dollar question is, can we slow down the decline in the renal function? And that was the question asked by so many people. Can we do something? Yes, we can do something. And I'll answer all these things. The first important thing is the preventive aspect. We all know since our student days, the prevention is the better than cure. And we need for the chronic kidney disease, especially the holistic care. Professor Tripathi sir, you must be agreeing about this, that prevention is the most important thing. And if we can think of some early biomarkers, sir has already done. So in the morning, I have seen the Professor Siddharth Das also did the early biomarkers. So we can think of early identifying the problem. And if we can identify, we can think of reducing the progression of diabetic kidney disease, or especially to prevent from diabetic kidney disease to the ESRD or end-stage renal disease. So we should have the best of the better biomarkers so that we can diagnose the disease very early. So that is the most important thing. And then we have a generalization that the screening is the protocol of screening is there in the world. And we should, at each and every visit, whether patient comes at the earliest onset of diabetes or the late duration of diabetes, we should screen each and every person from whether doing the just spot of urinary albumin creatinine ratio or serum creatinine or especially the eGFR. This is a must for every type 2 diabetes and every type 1 diabetes person. So eGFR and spot USCR is the must for each and every person from the screening point of view. And now this is the one which we have recently published as a site study. And it also says that there are several initiators and promoters of diabetic kidney disease. And these are the either hypoglycemia, hyperglycemia, and predisposing genes. I will be telling this especially just now. And the promoters are like hyperglycemia, hypertension, dyslipidemia, insulin resistance, smoking, procoagulant stage, long duration of diabetes, anemia, and of course, our Indian phenotype people. So there are multiple risk factors for causing. So let us see how our kidneys are damaged. So either there are basically two methods by which our kidneys are damaged. One is metabolic pathways and another is hemodynamic. Basically, these are the two basic mechanisms by which our kidneys are damaged. So it is the glucose per se or hyperglycemia per se, which actually increases the advanced glycated end products, and then it leads to extracellular matrix cross-linking. I'll be coming just a little bit later. And another pathway is the hemodynamic pathways, where the glomerular hyperperfusion or hypertension leads to increased cytokines, increased inflammatory cytokines like protein kinase C, MAP kinase, or NF-kappa B, or either through the vasoactive hormones, you have to have the increase in the transforming growth factor beta 1 and VEGF, and by which also there is an extracellular matrix increases, and it causes starting from the basement membrane thickening, which we all know from the physiology days, the Kimmel-Stell-Wilson disease or KW lesions. So what is the link? How does it take place? That is the question. And exactly 30 years back, when Dr. Prasanna Kumar sir and Dr. Amini and we were sitting together, we were actually thinking in terms of the same thing. How this, not every diabetic kidney, not every type 2 diabetes person or type 1 diabetes person gets a kidney disease earlier. There may be some mechanism. There is something other than the duration of diabetes, hypertension, glycemic control. There must be something. There are several studies in the world which they are doing, most of the scientists who are doing either cytokines, growth factors, lipid mediators, prorenin, nephrin, so many people were doing. But in the Africa first time, the genetic predisposition was seen during when they were seeing the retina, or the retinopathy people, ETDRS. The studies are there. And then we started the first study, that is the RAS genes. And then we studied in the University of Delhi under the laboratory of Dr. B.K. Thelma, sir. Sir is there. And Dr. B.K. Thelma, she is no more at present, but she gave us all the facilities in University of Delhi 30 years back, and we started doing the RAS gene through the CSIR projects. Pushpalata and Arun Prasad, they were the people, they were the students who actually did all the RAS genes for us. And what we found these two, especially the AGT and CYP11B2. These are the two important polymorphisms. What we found that if you have these two genes, these people actually progress to diabetic kidney disease earlier as compared to the people who do not have these two genes. So these are the first studies we found in our population. And then what we found, how these genes actually causes the damage. And when we saw the same patients, we did the oxidative stress pathways, and we know that if you have an increased reactive oxygen species, there is an increased peroxidation of the cell membrane, oxidation of proteins, renal vasoconstriction, and it can damage to your DNA. And then we did all SODs, the superoxide dismutase, uncoupling proteins, we did nitric oxide synthase, we did all sorts of oxidative stress. And we found that if you have those genes, EGT and CYP11B2, you have increased oxidative stress through these markers. And there is a definite role of inflammation and the cytokine, especially the interleukin 1, which is implicated for more of the TKD. Of course, the other interleukins like interleukin 6 and interleukin 18 also implicated, but interleukin 1 is the most important thing. And then we did the TNF alpha, the inflammatory cytokine, and the most important thing, what the TNF alpha does, it causes direct renal injury, it causes apoptosis, it increases the glomerular hemodynamics, and endothelial permeability is increased. And later on what we did, this is the most dreaded inflammatory cytokine we found in our patient is the transforming growth factor beta 1. We did all beta 1, beta 2, and beta 3, but it is the beta 1 which is implicated for the diabetic kidney disease in our patients. And these are the patients from Jaipur, Delhi, and the Bangalore. These are the people. So we have the cosmopolitan population sort of thing. And really we found that it is the TGF beta 1 especially which is implicated for the diabetic kidney disease. What it does, induces the transformation of epithelial cells of the tubules into the fibroblasts, and this process is responsible for renal fibrosis. And actually, if you see the nephron, the basement membrane thickening, actually the first thing is because of the TGF beta 1. And then we found the microRNA, sir. MicroRNAs in the form of ADP-RT1, AKR1B1, RAGE, GFPT, PI1. We did all sorts of things. We wanted to really know how the genes actually causes damage to the kidney cells, and these are the biomarkers. Then most of the scientists actually did all sorts of biomarkers. I don't want to go into the details of that, but the most important thing is the final pathway we found, the dopaminergic pathways. Through the COMTs, DRD1, DRD2, 3, and 4. These are the dopaminergic pathways which actually damages or causes, as a microRNA, it goes into the DNA of the nephron cells and actually causes the wrong protein synthesis. And ultimately there is an intercross linking or the cross bridging occurs between the two cells. And then it goes from the nephron to the proximal tubule, and there is a basement membrane thickening. And that is the KW lesion, which we actually knew it hundreds of years back, that there is a KW lesion and basement membrane thickening. And because of that, the first microalbumin leak is there because of this basement membrane thickening. So dear friends, we found the link, how this damage took place, that what we have shown earlier through the metabolic and hyperglycemic pathways. So this is how we did our research. We did the genetic susceptibility first. We found 2 RAS genes. Then we found the 2 reactive oxygen species like superoxide dismutase, uncoupling protein, nitric oxide synthase, and VEGF. And ultimately, they lead to increase in the inflammatory cytokine like TNF alpha and TGF beta 1. And it actually causes the wrong microRNAs, wrong DNA, wrong protein synthesis. interbridging or cross-linking between two renal cells, and through the dopaminergic pathways, they damage our renal cells and causes the basement membrane thickening. That is the starting of the diabetic kidney disease. And this is the basement membrane. Here is the first brunt goes to of the diabetic kidney disease, because if you have those genes. So what we can do, the most important thing, and dear friends, the good news is that seeing our pathways, we have already sent for the Nature this paper already, and Stanford people have already took our project, and what they did, they actually now working on TGF beta blockers. So now, dear friends, even if you are genetically susceptible people, you have the genes for the diabetic kidney disease. But if you can actually block this pathway of TGF beta blocker, we can think of preventing or slowing the diabetic kidney disease. That is the full pharmacogenomics, what a person can do in the future. My younger colleagues can actually see these things and can go further with these type of researches in our country. So dear friends, till the drugs are there for the prevention, we have several protective pathways. We can have the good blood pressure control. We should have improved metabolic parameters, good ambient pro-inflammatory pathways or markers in the blood, potential direct cardiovascular effects should be reduced. And the important thing is that we have now the drugs available with us. And before that, these are the usual things we can do for the prevention of diabetic kidney disease. Assess early. Screening is the most important thing. Screen every person, whosoever comes to your clinic. First time you do UACR and GFR, you just see all the CKD risk factors, and then go with the goal-directed therapy. The blood pressure, sugar, lipids, these are the most important, and lifestyle. Of course, exercise, nutritional things, the weight loss, and smoking, again a dreaded thing. If a person is having diabetes, smoking should be stopped as far as possible to all the patients. And of course, now we have got the medications. We have SGLT2 inhibitors. We have the non-steroidal MRAs. We have the GLP-1 receptor agonists. Till that, the new drugs are coming. We can use of these drugs. And this is the last one, which the Goldman says, early detection and early treatment of CKD in patients with type 2 diabetes has major health, quality of life, and cost benefits. And this is an important message for all the clinicians who work in the primary care. Incorporating CKD screening, using a renal profile as part of person's routine clinic visits could increase the screening uptake in the primary care and consequently facilitate the diagnosis of CKD earlier when it is very easier to manage. So dear friends, thank you very much for patience listening. And this is all the co-investigators, Professor Prasanna Kumar from Bengaluru, late Professor A.C. Amini, who actually did all these things for us. Professor Rajiv Gupta from Jaipur, Dr. B.K. Thelma, she is also late Professor B.K. Thelma, Dr. Pushpalakash and Arun Tiwari, they are the best geneticists at present in the USA at present. Professor Satish Chandra from AIMS, Dr. A.K. Sharma, Bilal Gupta, S.C. Tiwari, and Priyanka, she is working in Bangalore at present. And these are the people actually who helped us. And the legends who are sitting here, Professor Tripathi and Professor A.K. Das and Dr. Shashank and all the people who inspired us for doing this type of research things. So take-home message already has been given. Thank you very much.
Thank you, Professor Dr. Arvind Gupta, for a very, it is very heartening to note, and I have seen you for many, many years, Arvind, the way you are ignited, inspired for research. I must give you the example from the very beginning. You were always for the basic research and marrying it with the experimental research. Since morning, we are discussing why the diabetic kidney disease is 35 to 40% in contradistinction to much less elsewhere. We have been breaking our heads to find out why after all we're getting this disease and what can we do to control it. We also know that because of these genes, the diabetic kidney disease in India, not only glomerular disease, from the morning breakfast meeting to Siddharth's very nice talk and discussing that diabetic tubulointerstitial disease is increasing, and they proceed to the ESRD much faster than glomerular disease. So somebody has said that we should call it diabetic nephron disease, diabetic nephronopathy, and your talk shows the way, and also beautifully you have shown that for the diabetic nephronopathy, especially for the tubulointerstitial disease, it is possibly a SGLT2 inhibitor, the ARIs, the aldoleukin inhibitors, non-steroidal, and also GLP-1RA will become the drug of choice to prevent it. Dear friends, you have also highlighted we cannot choose our genes, we cannot choose our parents, but what we can do is to modify modifiable factor. And beautifully you have shown how the sugar control, BP control, cigarette cessation, Anita Nambiar gave a beautiful talk in the morning. And and all the modifiable factors we should do. Dear friends, if we do not take care today, diabetic kidney disease will overwhelm us. All of us have seen how the numbers are increasing. Dialysis, number one diabetes. Transplantation, number one diabetic patients. So we have to do something, and your talk goes a long way in showing the light. Thank you very, very much, and we really congratulate you, Arvind. And I know that he has done it very painstakingly, and with collaboration with people from Bangalore to Delhi to AIIMS to Jaipur, and you deserve, Arvind, a standing ovation for the great talk and the great arrangement. See, giving a basic science talk is very difficult. Thank you, Jackie.
For our next flight, flight number 53, Innovative Physician Forum, I invite Dr. Supratrik Bhattacharya, Senior Consultant, Department of Endocrinology, Diabetes and Obesity, Manipal Saltike and Manipal Broadwaves Hospital, and Dr. Madhuri Hole, currently working as an Associate Professor, Medicine, NKP SIMS and LMH Nagpur, and Dr. Bharat Salve, Ahmednagar.
Madam Youth, would you want to? Yes. Would you want to introduce?
Yeah, you.
Yes, sir. So it's my pleasure to introduce Professor Dr. Jugal Kishore Sharma, who is, a very well-known speaker and the founder and secretary general of Innovative Physicians Forum. He's also the medical director, Central Delhi Diabetes and Obesity Center, New Delhi. He's been the IPF Global Ambassador and conferred DSc honoris causa by HNBU Medical Education University, Uttarakhand, India. And also he's been the first international fellow with distinction from RCPE, Honorary Professor IMA Headquarters, International Advisor for Royal College of Physicians of Edinburgh, Advisor to MGU MST, Jaipur, and it's been the MRCP UK PACES Examiner. So once again, it's a pleasure and honor to have you here. Over to you.
Thank you very much. Good afternoon, everyone. I can see all these very senior people, my teachers, sitting here. And thanks to Dr. Sunil for allotting me a very important topic. Though if you look at this, it looks very simple. And after having listened to these orations, mind-boggling orations and the mind-boggling research, I will try to bring it down to something which is looks very simple, but it is not. The double-edged sword, what are they? The vitamins and the supplements. Their use, abuse in diabetes mellitus. So we will go through a critical evidence-based review of the supplement use, misuse and the clinical implications and diabetes care. I have no financial disclosures. This is a very simple slide which we have been reading since our physiology days. Vitamins, essential micronutrients required for normal metabolism, growth, immunity, and the tissue repair. These three factors are very important: the growth in the body, the immunity, and the tissue repair. And despite their importance, vitamin supplements are increasingly consumed without the medical indications. Patient coming to us, diabetic patients, grossly uncontrolled, hypertension, simply saying, डॉक्टर साहब कोई दवाई ऐसी दे दीजिए जिसमें ताकत आ जाए, कोई ताकत की दवाई दे दीजिए, and then he comes out with at least 5, 6, 7 packets कि ये तो मैं ले रहा हूँ, ये मेरी बेटी अमेरिका से लिया है, ये बेटा लंदन से लिया है, ये तो मैं ले रहा हूँ, कुछ और अच्छी दवाई दे दीजिए. So the global vitamin supplement market is growing rapidly, driven by health awareness, aggressive marketing, and the self-medication. Challenge is distinguishing evidence-based supplementation from unnecessary or potentially harmful use. We all know the fat-soluble vitamins, A, D, E, K, water-soluble vitamins, vitamin B complexes, vitamin C, then vitamin D, the indications in deficiency states, osteopenia, osteoporosis, osteomalacia, elderly population, and these are the evidences: vitamin B12, then folic acid, vitamin C, and vitamin B1. But the allure of the natural fix. Look at this. Why millions of diabetes patients are turning to dietary supplements, and what the science really says about this. This is again 30 billion industry in the US alone. The US dietary supplement market that exceeds 30 billion annually, driven largely by wellness culture and chronic disease burden. Many consumers, they perceive supplements as safer and more effective than prescription drugs for managing diabetes, and a perception largely unsupported by the clinical evidence. This belief is fueled by aggressive marketing and a cultural preference for the natural solutions. Marketing, we all know, by these pharma companies, sorry to say. I will not go into the epidemiology of diabetes epidemic. So, what is the patient behavior when we talk of the supplements? Why supplements? The search to control. Patients with diabetes are increasingly seeking ways to manage their condition beyond conventional medicine. Several factors drive this behavior. Desire for autonomy. That is very important. Greater perceived control over the personal health decisions than a natural appeal. And then dissatisfaction. Side effect of the conventional medication drive the supplement adoption. So unpacking the evidence, what the science says. Navigating a complex heterogeneous body of literature to find clinical signals worth acting on, and the challenge of research, a sea of studies. Sheer volume of supplement literature makes comprehensive review exceptionally difficult. Many existing reviews are narrative and lack the rigor of systemic or the meta-analytic methods, and a landmark 2020 automated literature review identified top supplement ingredients and their association with diabetes outcomes, setting a new benchmark for the field. Promising but weak evidence, like chromium, cinnamon, and berberine. Chromium may improve insulin sensitivity, studies limited by small sample size and the short duration. Cinnamon, again, very, very common. Some RCTs show modest fasting plasma glucose reduction, effect size inconsistent across the population. And berberine, comparable to metformin in some small trials. Large-scale confirmatory studies are still lacking. So methodological limitations preclude the definitive clinical recommendations at this time. Alpha-lipoic acid, again, when you see the prescription, the orthopedic surgeon, the physician, the diabetologist, then the geriatrician, they all prescribe neurologist alpha-lipoic acid, a glimmer of hope for neuropathy. It's a potent antioxidant with emerging evidence for clinical benefit in diabetic neuropathy. Reducing oxidative stress, which is the seat anchor for the pathogenesis of all these problems. Clinical trials in the Sydney 2 trial, they demonstrate measurable reduction in the neuropathic pain scores. IV and oral formulations, generally well tolerated at the therapeutic doses, but therapeutic doses are too heavy, 600 milligram per day. Role of fiber, selenium and the zinc. Dietary fibers among the most studied show glucose absorption, reduces postprandial hyperglycemia and improves HbA1c in multiple randomized controlled trials. Selenium again an antioxidant properties relevant to insulin signaling pathways, and zinc essential cofactor for insulin synthesis and secretions. Zinc supplementation associated with improved fasting plasma glucose and HbA1c in the meta-analysis. Nutrients with very low certainty evidence like the chromium, vitamin C, PUFA, very low certainly evidence for HbA1c improvement. Then comes the probiotics. They are superior to placebo for the HbA1c. And vitamin D again, superior to placebo for the HbA1c. Now the magnesium, zinc, vitamin C, prebiotics and the polyphenols. Magnesium, zinc, vitamin C and these probiotics and polyphenols, they all demonstrated superiority over the placebo for fasting blood glucose reduction in the pooled analysis. And the insulin resistance measured by the HOMA-IR, vitamin D showed statistically significant superiority to placebo for improving the insulin resistance, a key driver of type 2 progression. And what is the clinical implication? Even modest improvement in the fasting blood glucose and insulin sensitivity can translate to meaningful reduction in the long-term complications in diabetic patients. But there are certain ingredients with no supporting studies, like several widely marketed supplement ingredients. They yielded 0 qualifying studies meeting screening criteria for diabetes management, like minerals and vitamins, phosphorus, pantothenic acid, glutamine, isoleucine, tyrosine and choline, and the performance compounds like the creatine, monohydrate, magnesium, especially formulas. Now the dangers of abuse and the misinformation. When supplements cross the line from the adjunct therapy to dangerous substitution and how misinformation fuels the harm. FDA warning, too good to be true, actively warns against products making unrealistic or fraudulent claims for the diabetes management. And the products labeled as the natural diabetes cures. We have listened to Dr. Shashank Joshi in the morning regarding the cure of diabetes or claiming to replace insulin or metformin are marketed illegally by the FDA. And these products, they may contain undisclosed pharmaceutical agent or the adulterants, and several enforcement actions have been taken, including product seizures and the injections. When supplements harm, what are the serious side effects? We have heard of kidney problem, kidney damage. At least 3-4 speakers, even the auditors have taught us about the these researches going on in the kidney disease. But I'm sorry to say, high doses of vitamin C, chromium, picolinate and herbal compounds have been linked to nephrotoxicity. And this is a field of further research for the researchers. Hepatotoxicity, kava, germander and certain Ayurvedic preparations have caused drug-induced liver injury. And then the cardiovascular risk, high dose niacin associated with increased cardiovascular events in landmark trials. So the clinical principle is replacing established diabetes treatment with unproven product is a patient safety emergency. The abuse factor, more is not always better. We see that the hypervitaminosis, the mineral toxicity and the polypharmacy risk. And in this supplement context, abuse is defined as consumption that exceeds recommended safe level or use for inappropriate indications. Risk of interaction, drug interactions, berberine with metformin, additive hypoglycemia risk, omega-3 anticoagulants, enhanced bleeding risk, vitamin E in high doses, statins, reduced statin efficacy, St. John wort, multiple drugs. So all supplement used may disclose to the treating physician, especially in polypharmacy patients. And this cannot happen without asking the patient proactively about what all medicines and supplements he is taking. Now, what are the real world data? Supplement use and the mortality. Longitudinal population level evidence from the NHA-NES which is the gold standard of US nutritional surveillance research. In our country, this needs to be researched, and this National Health and Nutrition Examination Survey from 1999 to 2018 prevailed 54% reported regular supplement use. All-cause and cardiovascular disease mortality assessed via the National Death Index linkage, median follow-up of approximately 9 to 10 years. So the regular use is defined as supplement use in last 30 days with cumulative duration of 90 or more than 90 days. Vitamins 87.3%, minerals 75.3%, botanicals 51.5%. Then overall supplement use, no clear mortality benefit. The NHNES nutrition analysis that revealed that overall supplement use was not associated with a statistically significant reduction in all-cause mortality among patients with diabetes, and emerging protective effects. While overall supplement use showed no mortality benefit, specific subgroups revealed meaningful signals like amino acids, all-cause mortality, fatty acids, CVD mortality, and the glucosamine, again the CVD mortality. The nuance of the regular use. This study employed a rigorous definition of supplement use to ensure clinical validity by the recent use, by the cumulative duration, and the research implication. Short-term or irregular supplement use is unlikely to confer measurable physiological or the clinical benefits. Navigating the supplement landscape, the informed decision. Empowering the clinicians and patients with evidence-based guidance to make safe, rational supplement decisions, and the importance of professional guidance which can come from us. Open clinician-patient dialogue is the single most important safeguard in supplement use. Always consult your physician or the registered dietitian before initiating any new supplement regime. Clinicians should routinely ask about supplemental use as part of the medication reconciliation. Assessment should cover potential benefits, documented risk, and the interaction with the current medication, and use validated resources like the Natural Medicines Database or NIH Office of Dietary Supplement for evidence-based reviews. Beyond supplements, the foundation of diabetes management, we all know about the healthy nutrition, physical activity, sleep, and stress. And for individuals with type 2 diabetes, sustained lifestyle intervention that can achieve clinical remission. It's not reversal, it's remission, and outcome no supplement has demonstrated yet. Reversing pre-diabetes, which is again important. If you see with the yoga itself, in many studies it has been seen that 40% is the prevention of pre-diabetes turning into diabetes. And for the estimated 96 million US adults with pre-diabetes, evidence is complaining. But no supplement has matched this evidence base in the pre-diabetes reversal. This is the clinical evaluation, questioning the claims, identifying the potential benefits, specific nutrients like the amino acid, fatty acids, and the glucosamine. And these findings are hypothesis generating confirmatory RCTs with pre-specified endpoints in diabetic populations are urgently needed. Safety is first, understand the risk. So the future of supplement in diabetes care, the need for more research. This is the research agenda which is lacking in our country, and personalized nutrition approach is a must. The future of diabetes nutrition is precision supplementation, moving from population averages to individual optimization. Balanced perspective, supplement as adjuncts and not as replacements. Adjunct role only, evidence hierarchy matters, clinical communication is key, and future is personalized. With that, I thank everyone, but before that, I would like to invite all sitting here for this 8th Annual Internal Conference of Innovative Physician Forum on 29th and 30th of the August at New Delhi Hotel Pullman. And the theme is Metabolic Medicine at Crossroads, Diabetes, Obesity, and the Future of Internal Medicine. With that, I thank, and my special thank to my friend. You must have seen that these slides are AI generated. With editing has been done, and I don't remember any name other than Dr. Alok Modi. Is he here? So he has helped me a lot. Thank you, Dr. Alok. And thank you, everyone. Thank you, sir.
Thank you, sir. Very informative and nice talk today. It is entirely though simple, it is a very different topic. First time discussed in this conference. And most of you, everybody has seen most of our prescription, like doctor's prescription, more than 90%, the vitamins are the part of this. And that makes us to think that whether we are really using it properly or we are just misusing it, and which you throw the light, and it's very, very informative and nice.
Madam, it is the duty of we primary physicians, the internal medicine people, to look what patient is exactly taking, what is their composition, and then find out patient is taking methylcobalamin in 3 preparations differently, one by the orthopedic surgeon, another by the physician, another by the gynecologist. So that also we have to look. Thank you.
Very informative talk. So there should be some schedule or some protocol should be prepared at national level or some level to prescribe such particularly fat soluble vitamins. They have like toxicity reports available. Such kind
Sir,
of
there are very associations here, Research Society for Study of Diabetes in India, Endocrine Society of India, API, ACP. So all these associations should take along with these researchers to find out what is the protocol, how much it should be. This is the topic of real research now.
So just one quick question from the hall, if anybody wants to ask something.
Yes, madam.
So, yes, sir. So the discussion is going to be there after all the talks.
Okay.
So we have scheduled
Oh,
the
fair
discussion.
enough. So,
So we
Small question, if I'm allowed to.
Ma'am, I'm sorry, but we are really running. We are running 45 minutes late.
yes, yes.
I'll-
So we'll save the questions for later. Yeah. Thank you.
We have a discussion session at the end. So
Sure.
Perfect. Yeah. So thank you so much.
Thank you, sir. Thank you very much.
Big round of applause.
Now I request the chairpersons to felicitate the speaker. For next session, we are moving on to the next flight, flight number 54, on topic MASLD, a precursor of CVD, how to handle. For this, I would like to request Dr. Subodh Banjal, sir, who is a consultant endocrinologist, professor of medicine, Sri Aurobindo Medical College and PG Institute, Indore, and Dr. Ashish Bhattacharya, who is a senior consultant physician, Aurangabad. And our speaker, Dr. Anil Virmani from Jamshedpur.
Thank you, Dr. Sunil, for invite. I think we have very, very important topic to be discussed. I don't know whether the MAFLD is the part of the metabolic syndrome, but it's a precursor of CVD. That's important. So none other than Dr. Anil Virmani is going to talk about it. He is MD Medicine, DRM, FICP, and FRCP from London, Edinburgh, Senior Fellow of IDF, Consultant Physician, Cardio-Diabetologist from Jamshedpur. He is Dean of Indian College of Cardio, Diabetology and Metabolic Disease, CEO, Clinical Cardio, Diabetes Society of India. Awarded many awards with him. He's a master teacher of all. Over to you, Dr. Virmani. Thank you.
Good evening. Thank you. Honorable chairpersons, respected seniors and dear friends. At the outset, thank you, Dr. Sunil Gupta, Dr. Kavita, Dr. Shlok, and the wonderful team of Academia 2026 for inviting me. My topic today is MASLD, also called fatty liver. Is it a precursor of cardiovascular disease and how we should handle it? Early in the morning, Professor Das had already covered this topic. So I'll be concentrating only on the cardiovascular disease aspect. Now, why the name was changed from non-alcoholic fatty liver to MASLD? Basically, for 3 reasons. To improve awareness and patient identification, to reduce the stigma of alcohol, and to imply a broader metabolic involvement in these patients. Now, unfortunately, we have always talking about the South Asian phenotype. We have a higher proportion of subcutaneous and intra-abdominal fat, increased insulin resistance, and reduced muscle mass as compared to the ethnic groups. But if you look at the cardiovascular complication, there's a complex relationship. But the underlying soil is same: insulin resistance, diabetes, hypertension, dyslipidemia, metabolic syndrome, and liver fibrosis. There is a strong correlation between the severity of hepatic fibrosis and the likelihood of developing cardiovascular abnormalities, and the spectrum varies from coronary artery disease to atherosclerotic cardiac remodeling anomalies, hypertrophy, heart failure, arrhythmias. And there is evidence to suggest that accumulation of fat in the liver is a predictor for impaired myocardial metabolism and subsequent cardiac dysfunction. And it's not only the functional abnormalities, there are structural abnormalities also take place, such as left ventricular hypertrophy, enhanced epicardial fat thickness, various arrhythmogenic manifestations, and this is all because of the liver. Now, we all know 1 in 4 people suffer, and there are genetic predispositions. The diagnosis is based either on biopsy or imaging evidence of more than 5% fat liver and at least one cardiometabolic risk factor. That is very important. Now, what are the pathogenesis and systemic implications? This is one of the best slides I've ever seen, and it very nicely tells us, look at the dietary fat and carbohydrate we take, along with de novo lipogenesis, increased fatty acids in the liver, beta oxidation, increased triglyceride and cholesterol biosynthesis, endothelial reticulum stress, fibrosis, inflammation, and there is systemic spillover into the cardiovascular system, kidneys, muscular dystrophy. So it is basically a spillover of fat in the liver. It's a multi-system disease, as I said, and there's a bidirectional relationship. CVD risk factors, you all know, at baseline are associated with increased risk of developing fatty liver. And on the other hand, baseline liver fat is associated with greater risk of hypertension, type 2 diabetes, and cardiovascular disease. We must remember one thing: the most common cause of death in these patients is cardiovascular disease and not liver disease. Now, how to diagnose? This is the latest November 2025. We must look for, assess for the presence of cardiometabolic risk factors, and if there are present more than one, then we look at the amount of alcohol intake. Less than 140 grams in females, less than 200 is basically MASLD. Anything more than 350 and 420 is alcoholic liver disease, and in between is the continuum, so-called MET-ALD. So this is part of the continuum. But if there are no cardiometabolic risk factors and the alcohol intake is less than 140 grams into 10 grams, then the specific etiology for steatotic liver disease has to be found out, and usually it comes out to be cryptogenic liver disease. Now, what non-invasive scores, what should we do? Of course, ultrasound is the first thing. We all do it. FibroScan is the second. MR imaging is available, but it is not recommended for routine clinical practice. Currently, no reliable biomarkers. Every patient with so-called fatty liver must undergo a risk stratification as per the 22 AC guidelines. FIB-4 score is the main one, takes into account age, AST, ALT, and platelet, but unfortunately, less than 35, more than 65, it is unreliable. If the FIB-4 score is less than 1.3, it's low risk. If it is more than 2.67, it is high risk. In between is indeterminate risk. In patients with indeterminate risk, you go for liver stiffness measurements by elastography or FibroScan. ELF blood test is also there. but I think more for academic reasons. So low-risk patients should be managed by the general physicians, primary care people, endocrinologists, others, and the focus is basically on obesity management and cardiovascular disease prevention. Indeterminate risk and high risk should be managed by hepatologists. When should a biopsy be done in these patients? When the diagnosis is uncertain and we want to evaluate dual etiologies. When non-invasive tests for fibrosis show discordant or indeterminate results, or in ethics-approved clinical research. The goals of treatment, all these are high-risk patients with the proper history, rule out secondary causes, and the goals of treatment are two: prevention of cardiovascular disease and prevention of cirrhosis. How? Obesity, diabetes, hypertension, atherogenic dyslipidemia to be managed. If you look at the progress of these patients, 12 to 40% will progress from simple steatosis to MASH, 15 to 25% to cirrhosis, and around 7% to hepatocellular. There, the answer is only liver transplant or death. So where we should be acting as physicians, primary prevention between steatosis and MASH, lifestyle, SGLT2, GLP-1, and pioglitazone. Suppose the patient has developed steatohepatitis. Their secondary prevention, again lifestyle, GLP-1, but we have now two more, thyroid receptor beta agonist and FGF21 analogs. It's a multidisciplinary approach because there are extrahepatic manifestations, including cardiovascular disease, kidney disease, and sarcopenia. Lifestyle intervention is the pillar of treatment. But addressing chronic inflammation and oxidative stress through targeted pharmacological intervention is very important. We all know the effect of weight loss. Less than 5% or 5 to 6.9%, there's improvement in ballooning, steatosis. If it is around 10%, it's NASH, more than 10%, fibrosis regression. So the treatment of obesity is the cornerstone. But the problem is meaningful weight loss is rarely achieved without medical intervention. And it is very clear a sustained reduction of more than 5% to reduce liver fat, 7 to 10% to improve liver inflammation, and more than 10% to improve fibrosis. What are the current medications that we have in India? Of course, pioglitazone is the most commonly used, and we had this trial where it was compared with the placebo, but we must remember the optimum dose is at least 30 milligram, and that must be up-titrated to 45 milligram. Then we have saroglitazone approved in India and by almost most of the organizations in India. We have evidence for that, and I don't want to say, but it really does work. So both pioglitazone and saroglitazone may be used, but not targeted therapies. We must remember. And there is a study going on at the moment in patients with MASH and fibrosis with saroglitazone, which is going to tell us whether it really reduces fibrosis or not. Initial data with SGLT2 and GLP-1 was very promising. Tirzepatide has shown good results. Combination therapy with pioglitazone and GLP-1 is a wonderful combination. But the only two drugs that are really targeted therapy and approved is resmetirom, the thyroid hormone receptor beta agonist, FDA approved in March 24, the European Medicine Agency in June 25, and semaglutide, FDA approved in August 25, and it has been given to European medicine this year only. We all know the action of semaglutide, reducing lipid overload, increasing fat oxidation, improving insulin sensitivity, and the resmetirom basically increased fat oxidation, improved mitochondrial function, anti-inflammatory, and anti-fibrotic. So how do we approach these patients? If the patient is normal weight, go for 3 to 5% weight reduction. Obesity class 1, more than 5%, as I said, for steatosis reduction. 7 to 10% for hepatitis resolution, more than 10% for fibrosis. Class 3, bariatric surgery. Diet, physical activity, lifestyle, long-term goals, we all know is quality of life and survival. So they are there. So it's a multidisciplinary general practitioner, cardiologist, endocrinologist, dietitian, everybody is involved. If the patient develops cirrhosis, standard management of cirrhosis, consider liver transplantation. Otherwise, metabolic dysfunction associated, resmetirom in US, Europe, saroglitazar in India, semaglutide in US. We must treat the associated problems, type 2 diabetes, with GLP-1RA and the co-agonists, SGLT2, and of course, obesity and dyslipidemia, statins. Statins have a big role. The only way statins are contraindicated is in decompensated cirrhosis. Otherwise, they can be given throughout. So this is the latest from the 2026 standards, ADA standards. Early stages, MASLD F0 to F1, treat for obesity, diabetes, MASH pharmacotherapy is not required. That is, I'm talking about resmetirom and semaglutide, unless you're using for diabetes. MASLD with F2 to 3, that is at risk MASH, there you give resmetirom and GLP-1. Compensated cirrhosis, decompensated cirrhosis, avoid MASH therapy. And in decompensated therapy, cirrhosis, avoid obesity pharmacotherapy also. This is the latest FGF21 analogs, still in phase 3 trials, but showing excellent results. I've seen 2 or 3 patients who were prescribed this drug by Professor Sarir, and they're doing very well. There are a lot of drugs in the pipeline, and mostly we are excited about those which are anti-inflammatory and anti-fibrotic. So gentlemen, the key messages that I want to give you, MASLD is now recognized multi-system disease, is basically a liver's manifestation of the metabolic syndrome, closely linked to cardiovascular disease, and that cardiovascular disease is the leading cause of death in this population. Lifestyle modification, intensive weight loss remains the foundation of treatment. Drugs like PIO, saroglitazar, SGLT2 are promising for liver markers. Semaglutide and resmetirom are the only 2 drugs approved for liver fibrosis. And recent initiatives that we are talking about, the so-called cardiovascular renal hepatic metabolic model, that tells us the importance of integrated multidisciplinary care for managing these patients. Thank you for a patient hearing.
Thank you, Dr. Veeramani sir. That was excellent, precise and very well delivered. Just like baby's life starts in the mother's womb, diabetes actually starts, we all know, in the abdominal adipose tissue and is actually a vasculopathy. Thank you, sir.
Thank you, sir.
Any questions are there, please?
So we are running short of time.
Okay, fine.
So yeah.
Thank you. Thank you very much.
Yeah, okay. So I request our captains to kindly felicitate our pilot. For the next session, I invite Dr. Tejas Shah, diabetologist and director, IVA Diabetes Care Center, Mumbai, Diabetes Care Research Centers at Malad and Andheri, and Dr. Ashok Vasalwar, consulting physician, cardiologist and diabetologist from Chandrapur.
Dr. Vijay Panikar is a well-known diabetologist. He is honorary consultant to Department of Endocrinology, Diabetes and Metabolism, Lilavati Hospital, Mumbai. He is Vice President of Research Society for the Study of Diabetes in India, past Chairman for the RSSDI Maharashtra chapter, organizing Chairman of RSSDI National Conference in Mumbai.
Bus, we are running short
He has
of time.
more than 20 research papers
We are running
And
short of time, sir.
He's well known to all, so I request him to start the station.
Thank you. Thank you very much. At the outset, I must congratulate Sunil and his entire family for this wonderful show and for having invited me here. The topic for the day is from evidence to action. Timely triple quadruple therapy for type 2 diabetes and CKD. Basically, we are moving beyond the glucocentric approach to treatment. We are now looking at the cardio-renal metabolic protection. That is the in thing today. Diabetes is a driving force for global CKD. There are over 850 million people, 40% of diabetics have CKD, and India is one of the fastest growing diabetic kidney disease burdens. Now, if you look at this, diabetes is a strong risk factor for CKD. And if you look at the diabetics have a 3 times greater risk of developing CKD. And for any given EGFR, the risk of end-stage renal failure goes on increasing in a diabetic. So the take-home message would be, diabetes not only causes CKD, it accelerates the journey to end-stage renal failure. Look at the mortality and life expectancy. Diabetics have a 4 times greater incidence of mortality compared to non-diabetics with a CKD. Early CKD, just non-diabetic, tends to lose about 6 years of his life. A diabetic without CKD will lose about 10 to 12 years of his life. But if he's got associated CKD, he stands to lose 16 years of his life. So again, the take-home message is that combination of diabetes and CKD is particularly deadly, dramatically increasing mortality and shortening the life expectancy. Heart failure, CKD are closely connected. 58% of type 2 diabetics will develop CKD, and diabetic patients have a 5 times higher risk of developing heart failure, and heart failure and CKD go hand in hand. But if you look at this, obesity exacerbates all these health issues. So here, diabetes, CKD, and heart failure are interconnected disorders. Managing one requires screening for and protecting against the other two. Very important. If you look at CKD progression to type 2 diabetes, it's a combined effect. You have a hemodynamic effect. Dr. Arvind Gupta showed a wonderful original research work looking at all the biomarkers there. Hemodynamic, you have metabolic, glycemic control, and inflammation and fibrosis. This leads to tubulointerstitial damage, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and ultimately renal fibrosis. And that fibrosis is what leads to CKD progression. So CKD progression is driven not by glucose alone. It's a combined effect of hemodynamic stress, metabolic injury, inflammation, and fibrosis. Now, if you look at the albuminuria, this typically precedes the decline in EGFR in diabetic patients. That's your EGFR, initially you have hyperfiltration and then it starts going down. But if you look at the proteinuria, here you have microalbuminuria at this stage. Then you have overt proteinuria, and as that proteinuria increases, you find the EGFR going down and going to the end-stage renal disease. If you can intervene here and prevent or delay the progression to this stage, you would have done a yeoman service to your patients. So why is CKD in type 2 diabetes underdiagnosed? There is no symptoms in the early stage. There is lack of disease awareness, and there is an underutilization of the urinary albumin creatinine ratio. Less than 15% of patients with risk for CKD have a urinary albumin creatinine ratio tested. So it's very unfortunate. We all look at creatinine, or if there is a gross proteinuria, then we may look at it. But we need to look much earlier. So you cannot diagnose what you don't test. Routine annual screening for EGFR and urinary albumin creatinine ratio in all patients with type 2 diabetes is essential to pick up early CKD. and that can lead to a timely intervention and kidney protection therapy. So screen early, screen smart. What gets measured gets treated. If you're not looking for it, you're not going to treat it. So annually, do a urinary albumin creatinine ratio. eGFR is automatically calculated. Why do you need to do this? Because microalbuminuria is the earliest marker of kidney damage. By the time you see protein in a routine urine, it is more than 300 milligrams of microalbuminuria. It's only after crossing 300 that you will see proteinuria in the urine. So you pick up early and that would be the thing. Don't wait for the creatinine to rise and then start looking at the kidney. No, that's what we do, unfortunately. So diabetes plus CKD is a perfect storm. 30 to 40% of people with type 2 diabetes develop CKD. CKD dramatically increases cardiovascular death, heart failure, and the end-stage renal failure and hospitalization. And most patients will die of a cardiovascular disease before they reach the dialysis stage. That is unfortunately the truth. So the problem is we are still glucocentric. We treat HbA1c very aggressively, but we don't look at the kidney that seriously. We are waiting for the creatinine to go up before we open our eyes. So diabetes is no longer just about glucose. It's about kidney survival and cardiovascular protection. So the real enemy is diabetes, which leads to CKD, which leads to CV death. So our goal is an early, layered, evidence-based intervention. I repeat that, early, layered, evidence-based intervention. So the first layer is the hemodynamic protection, which is a RAS blockade, and this is the foundation. ACE inhibitors, ARB, the mechanism is decreases intraglomerular pressure, decreases proteinuria, and slows the CKD progression. The evidence base is the renal trial, the IDNT trial, and the on-target trial. So ACE inhibitors, ARB, are the first step in kidney protection. If you look at the renal trial, this was losartan versus placebo. And you had a 16% reduction in composite renal outcome, 25% reduction in doubling of serum creatinine, 28% reduction in progression to end-stage renal disease, and a significant reduction in proteinuria. The IDNT trial used irbesartan, but here it was irbesartan versus amlodipine versus placebo. And if you look at a 20% reduction of primary composite endpoint versus placebo, and a 23% reduction versus amlodipine, and significant delay in doubling of the creatinine and beyond BP lowering. So the one message from this was all antihypertensives are not equal. RAS blockade is renoprotective. Amlodipine does not protect, which was seen here, as compared to amlodipine 23% reduction. Then we had the on-target trial, which compared telmisartan and ramipril. And there again, very effective like we saw earlier, and both were similar, not inferior, no significant. No. They even had a combination of telmisartan and ramipril, which significantly further reduced albuminuria, but this did not translate to better renal outcomes. In fact, the renal outcomes were adverse. So when you use a combination of an ACE and an ARB, you are increasing or reducing the proteinuria, but you are increasing the risk of complication. There is increased dialysis, increased doubling of the serum creatinine, acute kidney injury, hyperkalemia, hypotension. So although dual RAS blockade produced greater reduction in proteinuria, it was associated with worst renal outcomes and more adverse events. So more proteinuria reduction does not always mean better kidney outcomes. Understand this. And the question is, why this renal harm if you combine an ACE and ARB? There is an excessive fall in the intraglomerular pressure, and this is the same mechanism which reduces albuminuria. The albuminuria is reduced because of reduced intraglomerular pressure. The glomerular filtration depends partly on the efferent arterial tone. The dual blockade, there's a marked efferent vasodilatation, and the GFR falls significantly. And this increases the risk of acute kidney injury, especially in the elderly and CKD, because of volume depletion. Even routinely, when a patient of yours is on an ARB and they develop gastroenteritis and hypotension, and if they are on ARB, please stop it immediately because they can go into acute kidney failure, shutdown. So proteinuria improves, but the filtration capacity declines. And the evidence for this is there are two trials, the on-target trial which combined ramipril with telmisartan and the VN-Nephron-D trial, losartan with lisinopril. So the current concept is you need optimal RAS blockade, not maximal RAS blockade, optimal. So the hypertension, there should not be an associated hypotension in these patients. So the key message for RAS blockade is ARB slowed CKD progression independent of BP control. RAS blockade was the first breakthrough. Every CKD deserves RAS blockade. Even after RAS blockade, there is substantial CKD progression. So still, beyond, in spite of this, it still persists. So what? Newer therapies are there. We had the layer 2, which was the tubuloglomerular protection, EMPA, DAPA, gliflozin. That restores the tubuloglomerular feedback, reduces hyperfiltration, lowers albuminuria. Credence trial. I'm going a bit fast because of lack of time. Good reduction. Message was robust renal protection with SGLT2, and these were all on ACE and ARB, so that was a combination. The dapagliflozin CKD trial showed benefits even without diabetes, good results. These were the major trials for SGLT. ACE-ARB combination does wonderful because the ACE dilates the efferent arteriole, SGLT constricts the efferent arteriole, and that is how you get the combined benefit there. So this is the renal, credence, and DAPA which tells you that you could have this combination. But in spite of that, a lot of cardiovascular thing, still we'll desire something more. And that is where the finerenone comes in. These are the mineralocorticoid receptor antagonists. And what is the action of mineralocorticoid overaction? It causes sodium retention, inflammation, fibrosis, structural kidney damage. And finerenone targets this common final pathway. It targets inflammation, fibrosis, and aldosterone-mediated injury. And this is what fibrosis drives the CKD progression. You have these two major trials, Fidelio DKD trial, Figaro DKD trial. They did good 18% reduction of primary endpoints, reduced CKD, significant reduce the CV outcomes. Key message, I have to go fast because of the time. Figaro did the same thing but reduced heart failure outcomes. There was a Fidelity trap which pooled the data of both and showed significant cardiovascular reduction, kidney, hospitalization for heart failure and stage renal failure. So that was the foundation antifibrotic pills she came. So you had three drugs, RAS, SGLT2 and finerenone, and these independently block this. But should we start them together? The confidence trial tested this hypothesis. They did finerenone alone, finerenone, empagliflozin with the others, finerenone plus empagliflozin, RAS blockade was already there. And the combo, triple drug combination versus finerenone alone, 29% greater reduction versus empagliflozin alone, 32% greater reduction. So these were the Credence, DAPA, Fidelio, Figaro, all 30%, but if you use them together, you get a 50-55% reduction. So triple drug combination was there, but was it enough? Now obesity itself is a major risk factor for progression of diabetes. Obesity is not just associated with CKD, it is a direct contributor to kidney disease, an important therapeutic target for kidney protection. FLOW trial showed good improvement kidney outcome by 24%, MACE 18%, and so on. And if you look at these different studies, 24% kidney outcomes, slower GFR, 29% CV death reduction. eGFR means protection was there very significantly. So you could add an SGLT2 to patients another 2-3 minutes for obesity with high BMI, poor glycemic control, establish ASCVD, persistent albuminuria. Now, if you look at this study with combinations, this is the CKD progression, the first on top here. And you look at this level here, SGLT2, GLP-1 and MSRNA, maximum benefit is with that triple combination. All-cause mortality, SGLT2, GLP-1, mRNA. So basically, if you look at the combination and the effect of it, approximate your RAS blockade plus SGLT2 will reduce by 50 to 60%. If you use a triple drug, 65 to 75%. If you use RAS blockade, SGLT2 with semaglutide, 60 to 70%. But if you use all four, it's 70 to 80% reduction in albumin creatinine ratio, and some patients may achieve 80%. So, four drug combination can give you 70 to 80%, almost reaching remission in albuminuria. So today CKD is just not a kidney disease. It's a hemodynamic disease with inflammatory disease, metabolic disease, cardiovascular disease. And multiple pathways require simultaneous blockade. So we are treating atherosclerosis, heart failure, inflammation, and so on. You have the four drugs, multiple pathways. So currently the updated 4 pillars for CKD prevention and treatment is use RAS inhibitor, use an SGLT2, use a Finrenone, and then a GLP-1 analog. And you will do wonders for a patient, but start early. Do a urinary albumin creatinine ratio on every type 2 diabetic patient right early so that you can institute this treatment fast and give the best results to your patient. Thank you very much, ladies and gentlemen. Sorry, I had to go fast because I think I made too many slides.
No, it's okay. Carry on. Thank you very much. It's not. You can carry on.
Any questions, please? Thank you, Dr. Panikkar, for a nice lecture. Thank you so much.
Thank you, sir. I request our captains to kindly felicitate our pilot. For the next flight, I invite Dr. Santosh Malpani, sir, consultant at United Diabetes and Endocrine Clinic, Nanded, and Dr. Sachin Gathe, diabetologist and president, IMA Nagpur. I request Dr. Anil Virmani, sir, to kindly chair the session, please. Yes, sir. I invite Dr. Vasant Kumar, sir, from Hyderabad for his talk.
Good evening, friend. I'm sorry. Yeah, you.
Sorry. Good evening to all of you. Flight number 56 is about to take off with one of the best pilots in the country, Dr. Vasant Kumar. And he is going to tell us people don't want to take insulin, but he says, how do we improve happiness indices with insulin? He is a senior consultant physician, Apollo Hospital, Hyderabad. The past president of RSSDI, he has done a huge work in shaping the present RSSDI. He's also the president of the Indian Society of Hypertension, Diabetes and Youth Society, supporting kids with, he has got a lot of passion for working with type 1 diabetes, and he has organized a number of conferences, many guest lectures, orations. I don't know, but he is my elder brother or brother. Over to you, sir.
Thank you. Thank you so much. Good evening, friends. This is probably one of the simplest talks, but we ever had all of this day. It's going to be simple. It's just somehow Sunil has given us this topic. I don't know how the pilot can fly only for 15 minutes. Taking off, landing itself takes that much of time, but I'll try to finish it off surely. So this, you have already seen the name of the topic. So actually, why happiness matters in diabetes, which is very important. We always concentrate more on just control of blood glucose. Are we looking at the attitude of the person? Is the patient or the person happy? Is he out of distress? We know that because this is a chronic disease which requires self-management and it has got high burden because so many decisions are taken while treating. They are worried about the complications. There are so many restrictions you are telling them on lifestyle. So naturally there is emotional burden. So how do we define happiness in diabetes, which is actually doesn't really look realistic? How can you really make a diabetic happy in spite of all the issues that they face day-to-day life throughout their life? So we are looking at better quality of life, if he's satisfied treatment-wise, if diabetes distress is less, emotional well-being is there, and if they sleep well, if they don't have so much of fear of hypoglycemia, so definitely they are happier. But to make it true, make it happen, is not going to be an easy task either for the patient or for the treating doctor. So what is this burden? 20 to 40% of diabetes patients affected by diabetes distress. It happens to them, you know, it's a chronic disease. They're worried about the complications. They're worried about the management itself. Each time they go to the doctor, they're really scared what the doctor is going to tell them. Is he going to add more medications? Whatever happens. So finally, when somebody has poor control, it leads them to anxiety. And of course, they might even change the medication and subsequently leads to bad control of diabetes. So we are talking about insulin. This topic is not supported by any insulin makers. This is just the subject that Sunil has given me. So insulin, is it a double-edged sword? We heard Dr. David telling us about dangers of hypoglycemia. So what are our concerns? We always know. Of course, it's an injection. The patient thinks that there is going to be a prick, so it pains. Weight gain is something that worries. Hypoglycemia, is it a social stigma till? We need to answer this. And then the dosage changes. All these are concerns. But when we optimize them properly, we reduce the symptoms, the person becomes more confident, and he has also improved satisfaction, and probably he does better in his life. So how does it improve the happiness actually? So when somebody has better sugar control and he feels more energetic and the reduced disease-related worry, and of course symptoms are less and he sleeps well, and he's not worried about any acute metabolic stress, and he or she becomes more confident. So what happens? So all the symptoms that person has before being shifted to insulin, like fatigue, polyuria, weight loss, blurred vision, and reduced vitality, all these obviously improve because you're managing diabetes, you're giving them insulin, which is relatively safer on some switch. I'll come to that point. So what happens? They have better vitality, productivity improves, physical functioning improves. They even become more socially acceptable and they become more confident. And subsequently, the psychological impact that they had because of the disease changes. And sometimes hypoglycemia, of course, is one of the major issues that always worries us. Any anti-diabetic management, many of them can cause hypoglycemia, especially the oral hypoglycemic agents, sulfonylureas. And that's one thing that worries both the doctor and the patient. So we need to look at this aspect and avoid this. And so when somebody has hypoglycemia, the quality of life suffers. The person doesn't feel happy. He has reduced satisfaction, and he might even try to reduce the dose and lead to more issues. But generally, if you see what is the type of insulin that we give to type 2 diabetics when they don't respond to adequate dose of oral anti-diabetic drugs, it is a basal analog that we always use. We all know about it. And it is perhaps the simplest and easiest way to give somebody just one single prick a day and probably reduce. Too much of metformin dosage can cause more side effects, as you know. So instead of increasing, escalating the doses, giving insulin, basal analog, long-acting, single shot, giving them better quality of life, so they feel comfortable, their confidence level improves, they do generally well. So these are some of the, of course, the reported outcomes. What has shown us, the quality of life improves, patient feels better, the diabetic distress itself comes down when you are not trying to escalate the high dose of oral medication, which obviously result in more gastrointestinal side effects. Just starting with small dose of basal insulin may not really lead to hypoglycemia, but better quality of life, better control of sugar. We know about this, and I'm sure all of us are using. And of course, somebody doesn't respond to single dose, you need to shift them to whether pre-mixed insulins twice or even basal bolus insulin, which is not going to be an easy thing for the patient to accept, but it certainly gives them better life and longer life when you start it, when it is required. So of course, when you're talking about technology, things become even better. When you're using the, whether you use continuous glucose monitoring or the glucose system itself, and if you are giving different types of things. Of course, we are talking about time in range, we are talking about glycemic variability. All these certainly improve when you put somebody on insulin, whatever regime that you prefer, depending on the patient's requirement and the need. Is it not? So we've been talking about it. Many speakers did speak about the glycemic variability and what is time in range. I'm not going to speak to you anything about it. So by the time I try to speak too many things, I'll be asked to land the plane, Captain. So what are the barriers? We certainly have barriers because injection itself causes them think is a big barrier, and they are worried about hypoglycemia. So it all depends on how you handle the patient. You are going to talk to the patient in a different manner to handle him. You are not going to scare the patient, say that this is the last stage that you have reached, you need insulin, tablets are not working. That's not the way we deal with someone when you initiate insulin. You're only telling them, I don't want to increase the dose of tablets. It's always better for you to shift to an insulin, which is a safer option, better option, and also the one which improves the quality is what is important, but also make him a part of your decision making. Don't underestimate any patient. I always tell even so-called uneducated, illiterate, or rural patients, many of them, they have intelligence enough, they are emotional, so you need to talk to them, you need to explain them. It certainly helps us, and they will definitely do better. So the communication improves. So don't tell them that oral therapy has failed. So you need to talk to them the way you need to. For example, this patient has got 10.2 HbA1c. So what do we do? The dosage is more, so we just put him on basal insulin and talk to the patient. Slowly he's improving. So practical steps for physicians, don't forget, minimize hypoglycemia, individualize the regime, and then see how you handle these patients very carefully. So what are the future directions for those who are on insulin? We are talking about basal, mixed insulin, multiple dosage, but maybe we are even thinking of weekly dose, and there could be another ways of insulin delivery systems we already have, and it could improve, but be sure that very, very few can afford it, especially in our country. So what is more important is we need to talk to the person with empathy, with confidence, and take the patient into confidence, and let patient and doctor be two people together to take the decision to shift them to insulin. And remember, there will be a lot of patients, almost 20 to 30% of type 2 diabetic patients by the end of 5 years would require insulin. There's no point in postponing. Starting simple basal regime is what is important, what is mentioned here. Diabetes distress will go, they will do much better in life. And hypoglycemia is one thing that worries. This is all my topic. I want to tell you all these slides are made by AI. I did not take any help of Alok Modi, as my brother said, because nowadays AI is very simple. All you have to do is you ask a question, couple of things, ask what slides you want. The slides will come, look at them. If required, you don't even need to modify the slides. AI is more intelligent, AI is more knowledgeable. is everything more than me. So all I do is sometimes if the slides are too many, I need to remove. Coming back to, these are some of the slides of my own. This is not AI. I manage many type 1 diabetic children who belong to poor socioeconomic status. I thought when we are talking insulin, can you look at them? They are actually happy, they are smiling. Can you believe that they are diabetic for last 10, 15, 20 years? They belong to lower socioeconomic state. There are girls and ladies who are married. They are on very simplified plain insulin, not even analogs. And I can actually see 2, 3 of them smiling and they look happy. And see this little one, Bansi, Diabetes India program, and see this little fellow came, and some of our speakers and faculty which came from abroad, including our friend Paul, they were so happy looking at this. This is a 2-year-old child who takes 4 shots of insulin, and he says, I run for T1. It's wonderful. So this is one more voluntary organization we actually run for these type 1 children. Just want to say that insulin can make many people happy, including the children. Thank you. I've got 2 minutes left for the organizers.
I think there is no harm in using AI, but a word of caution, always cross-check the references it gives you, because 40% time they are hallucinating. And in my last 48 years of experience that I have been using insulin, I found 2 things very useful. One, I start preparing the patients at least 2 to 3 months before I initiate insulin. And number 2, when the day I initiate insulin, the first injection, even if it's 1 unit, I give it myself so that they know how to take it. And after that, the patients feel so happy that they've not felt the needle prick at all. And then they happily take it. I think that's a happiness in this.
Agreed, sir.
You want to say something?
Any other
Thank you,
comments?
sir. Thank you, sir. Happiness is a vital sign, a 5th vital sign in diabetes patient. So, of course, the fear is most important. Instead of saying insulin is a drug, we should call it as a tonic or something, right? So, best thing, the physician inertia about the insulin to remove it, right? Thank you, sir.
Thank you. Okay.
Any questions from audience?
For all the 4 speakers. It's such a simple topic.
Okay.
There won't be
The
any
panel
questions.
discussion. For all the 4 speakers, any question? There are no question answers. So over to the rapporteur.
Thank you, sir. Thank you. I request our captains to kindly felicitate our pilots.
Now moving on to next slide of discourse, I would like to call upon Dr. Vijay Patni sir, who is the founder Diabetes Research and Welfare Association from Kolkata, and Dr. Vishwas Jhade, who is a senior physician from Chandrapur. Dr. Abhishek Srivastav from Jabalpur and Dr. Rakesh Parikh sir from Jaipur.
Topic. Good evening. Welcome all. And we are going into a very important session, a duologue basically. And I thank Dr. Sunil Gupta sir and the scientific chair team who has not made it a debate, which is better. What they are going to discuss is about tirzepatide and semaglutide, which, who, and when. And the person who's going to speak on tirzepatide is Dr. Abhishek Srivastava, a known face, I think internationally now, and Dr. Rakesh Parikh. So again, a known face, obviously, being in RSSDI committee, secretary, and what not, right? So basically, Can we have the slides? Yeah. So Dr. Abhishek Srivastava is from Jabalpur. He is the chair DSN CML at American Association of Clinical Endocrinology, and is also a chair-elect DSN CML leadership group in ACE. Executive committee member RSSDI MP chapter and a lot of other accolades. I think Dr. Abhishek, as because this is not a debate, right? So the best part is that we can speak for both the molecules, correct? Now, what we need to impress upon is actually giving a practical view of which molecule to be used when, where, and how, right? So I'll start with you.
Dr. Rakesh.
No, first is yours, Abhishek. First, no, I've actually prepared for a debate. I was.
So I think they have a confusion out here. You can start, sir.
Okay.
Okay.
So I asked Abhishek to start first. The reason is that I was told that I have to debate against Dr. Sanjeev Phatak. Sanjeev Phatak is a very senior person, very mild, humble person. So I prepared my slides, very polite slides. It's not, there are not slides like we do in the debates. So anyways, I'll start first. And the topic given is actually very simple, tirzepatide versus semaglutide, which, who, and when. I just modified it, which, who, and why, so that I can give justification for every reason that I do. So these are the who's that we'll talk now. And these are the different conditions that will weigh sema and tirzepatide for obesity, for pure weight management, childhood obesity, obesity with high ASCVD risk, T2DM for glycemic control, T2DM for high ASCVD risk, T2DM with CKD risk, OSA, MSLD, and also those people who have injection phobia, those people who can't afford it because of some cost concerns. And on each of these points, we'll weigh the evidence, and then I'll give my honest opinion. I won't be debating against Abhishek on this point. Regardless, we all know that weight management is a very important aspect of managing diabetes, and we all are aware of these benefits of weight loss. So whatever amount of weight loss you can achieve, you get some or other benefit. And if you lose enough of weight, you can even get the remission of diabetes, even the reversal of fibrosis in patients with MSLD. Now, the first question was about the first who's was the people who are having only obesity and where you want to use a drug which can give you maximum weight loss. Now, on that, I'm sure Abhishek will put up this slide. SURMOUNT-5 trial is the head-to-head comparison between these two drugs. I'm not going through all the other trials which have shown that SEMA also gives you good weight loss. Around 1/3 of patients lose more than 20% weight. But when you compare these two drugs in a head-to-head comparison, these are the results, and where definitely tirzepatide wins. So tirzepatide has got a higher amount of weight loss numerically compared to semaglutide in this head-to-head comparison. The comparison is between tirzepatide 15 mg and semaglutide 2.4 mg, which was the maximum dose which was available till recently. But now we have a study which is STEP-UP trial, where they have used 7.2 mg of semaglutide, and here with that dose you can achieve the same amount of weight loss with semaglutide also. So at higher doses of 7.2 mg, semaglutide gives you as much of weight loss as you can get with tirzepatide 15 mg. And this is the reason because of which through US FDA, it has got a approval which was very fast. This is a special program by FDA, that is CNPV, Commissioner's National Priority Voucher. And here they give a priority approval to drugs which are having some importance. Now, these are the conditions which are mentioned on the right side. Any issue which is of public health crisis response or innovative breakthrough therapies. And among those lists, semaglutide 7.2 mg stands as the fourth molecule which got approval recently for weight management. So because of the data which is available, which is very strong, FDA gave it a priority to approve this drug for weight management at that higher doses. So now, although semaglutide 7.2 mg gives you equal weight loss, just like tirzepatide, but still I would say we don't have 7.2 mg available in our country. So maybe when your objective is pure weight loss, at that time maybe tirzepatide wins here among the two drugs. What about childhood obesity? So that's a very big problem in our country, and we see a lot of children, adolescents below the age of 18 years who are having obesity, which is the drug available for them. And for that, this is the trial, STEP-Teens trial with semaglutide, which has shown that by using this drug, you can get a weight loss of up to 15 points reduction in the BMI. And around 1/3 of people lose more than 20% body weight, half of them lose more than 15% weight. So this is a very convincing data from semaglutide. And based on this data, semaglutide has got approval for usage in adolescents below the age of 18 years. So anyone about 12 to 18, you can use this drug for pure weight loss. Tirzepatide, do they have data? Yes, they have data, but it is not for weight loss. Tirzepatide is not approved for weight management in adults below 18 years, individuals below 18 years, although it is approved for use as a anti-diabetic drug. So someone who has got diabetes, T2DM, above the age of 10 years, tirzepatide is approved, but not approved for weight management. So again, for childhood obesity, semaglutide is the only drug which is approved by the regulatory authorities. What about obesity and ASCVD risk? So this is a SELECT trial. We are all aware of this trial. It was done in people who were only obese, did not have type 2 diabetes, and the data is very strongly convincing here that semaglutide gives you a good benefit in terms of reducing the ASCVD risk, whether it's the primary composite endpoints, death from cardiovascular cause, heart failure, death from any cause. On all these fronts, the drug was much better than semaglutide. And the point to be noted is that the separation in the curve starts immediately after the drug is started. So the effect or the cardioprotective effect of semaglutide doesn't depend on weight loss. Long before the patient achieves weight loss, the benefits start arising there. So there is something in the drug which is giving this protection to the individuals who are using semaglutide. Another sub-analysis of the same trial, here they have looked at heart failure. There are 4 graphs here. So one is for placebo, one is for semaglutide. And then in individuals who are having heart failure at baseline and those who are not having. So all those were analyzed, and in both the groups, whether they have heart failure at baseline or not, the heart failure rates go down when you use semaglutide. Now, based on this convincing data, again, semaglutide has got approval for using in individuals who are having obesity and high ASCVD risk. Tirzepatide, as of now, does not have approval for that indication also. What about T2DM for glycemic control? Now here we have the plethora of evidence from the SUSTAIN program, all the different kinds of population. This drug was compared against placebo, against gliptins, against GLP-1s, against insulin, against metformin, and so many other drugs. So they have studies with all the different kinds of population that you can think of, and throughout they have shown that semaglutide at a dose of 1 milligram itself gives you A1C drop of something between 1.6 to 1.8%. So it has got a very high glucose lowering efficacy. Although if you talk about the comparative analysis, then might be Abhishek will talk about this study again, that is SURPASS-2. Here they compared tirzepatide in different doses with semaglutide only 1 mg. And here tirzepatide had got a better A1C drop at higher doses. Although in this trial, they had only semaglutide 1 mg arm, they did not have the higher doses of semaglutide here to compare. But still, if you look at the guidelines, the ADA guidelines say that the drugs with highest efficacy for glucose lowering, among those they mention GLP-1 RS, particularly semaglutide as the first drug, and then tirzepatide. So it would be fair to say that both these drugs are having similar efficacy in glucose lowering, and both of these drugs are approved and highly recommended by the guidelines. What about T2DM with high ASCVD risk? We have SUSTAIN-6 trial, which was a CVOT trial with semaglutide. The data is again strongly convincing, 26% reduction in the 3-point MACE in the people who are using semaglutide compared to those who are using placebo, and that is why this drug again has got approval for using in people with T2DM for with high ASCVD risk for reducing the risk of events. Again, tirzepatide doesn't have this label indication as of now, although the trials are ongoing and they might get it soon. What about people at CKD risk? So here they have a FLOW trial where they looked at people with type 2 diabetes and they looked at the composite kidney outcomes. Again, there was 24% reduction. When you look at the UACR, there is 32% improvement in UACR compared to placebo in the people who are using semaglutide. And again, in terms of kidney failure also, the decline was there in people who are using semaglutide. So that is why semaglutide has got approval for using in people with T2DM for preventing the CKD events also. What about OSA? This is a study with tirzepatide, and there is a good amount of benefit in people who are using tirzepatide compared to placebo, and that's why this drug has got approval for using for the treatment of OSA by US FDA. Semaglutide has got some evidence, but it does not have the approval from US FDA as of now as a drug for treatment of OSA. What about MASLD? Here you have a ESSENCE trial done with semaglutide, and it has clearly shown that in people who are using semaglutide, there is resolution of steatohepatitis with no worsening of liver fibrosis. The reduction in the liver fibrosis is also seen, and based on this data, again, semaglutide has got approval for treatment of MASLD also. What about people who are having injection phobia? Semaglutide, you have a oral option which is available, which is not there with tirzepatide. And the last point, which is very important, in masses, Tirzepatide is not a drug that can be given to masses. Most of the people will not be able to afford it. So for semaglutide, you have the synthetic ones which are available now, which are very cheap and can be given to masses also. So for both these groups where there is an injection phobia or there is a cost concern, semaglutide is the only drug that you have with you. So now coming back to the overall conclusion of the data, these are the different WHOs where semaglutide can be preferred. And there are other three where tirzepatide can be used. So this is based on all the evidence. My time is up, so I'll run fast. So these are all the different trials with semaglutide. I'll not go through all the trials, but these are all the trials showing all these benefits which are shown with semaglutide. And these are the screenshots of CDSCO website where they have approval for different drugs. So I searched for both tirzepatide and semaglutide. There are a number of different approvals which are available for semaglutide on the CDSCO website. A very interesting review article. Lastly, here they compared different anti-diabetic drugs on different aspects, all-cause death, CV death, non-fatal MI, and so on. And here you can see GLP-1, it is green for most of the different parameters. Tirzepatide is at the end. You will see green only at the one of the columns, which is for health and quality of life score. On others, it's gray. And what's the difference between green and gray? That I'll zoom here and show you. Green means amongst the most effective. Semaglutide is among the most effective on all the parameters, and gray is possibly not convincingly different from standard treatment. The data is still not that strong. So still tirzepatide can be used. It wins in people who are having obesity only, who are older than 18 years, who do not have ASCVD, don't have CKD, don't have MSLD, who are willing for injective therapy and who can afford it. So these are the people where you can use tirzepatide. And who are these people? These are the metabolically healthy obesity. And what is the prevalence of these people? This is a study from Dr. Mohans. This is the population which has got metabolically healthy obesity. Here around 1% or 1.5% of population where this drug can be used or offered. Although 50% of them would say that I don't want injections, remaining 50% would say that I can't afford it. And then probably the situation is like that where you have half of people can't afford it, half of them don't want it, and maybe you don't have any patients who can be prescribed tirzepatide. So coming back to the last question, the question that we started with, this is the answer. Which drug? It is semaglutide. Who for most of our patients, and why? Because there is enough of evidence and approvals from the regulatory authorities. So for a doctor like Abhishek, if you have to prescribe tirzepatide, you'll have to probably look for that suitable patient from your crowd. But for most of us, probably we can use easily semaglutide in most of our diabetic patients. Thank you.
Thank you. I was told it was a debate, no? Milke kaam karna tha. So again, I'll be speaking for tirzepatide. Thank you, Dr. Sunil Gupta, sir, for the invitation. And quickly, as we are short of time, yes, both drugs are actually incretin-based therapies, but let me be clear about one thing. I'm not saying that semaglutide is a bad drug, but again, it is a very good drug. What I'm saying is tirzepatide is better. And why? In my next slides, I'll prove it. And I believe you will agree. And my talk is based on 8 pillars, of course: mechanism, the trial data, weight loss, glycemic control, the cardiovascular outcomes, of course, and some real world evidences and tolerability. So let's say if 2 drugs are safe and effective in managing diabetes and obesity, which one would you choose? A drug which is having greater HbA1c reduction, greater weight loss, greater reduction in visceral fat, and greater achievement of treatment targets. The answer actually determines which drug should be used. So let's start with the science, because everything else flows from here. Yes, semaglutide is there. Semaglutide is a GLP-1 receptor, but it activates only one receptor. Tirzepatide is a dual GIP and GLP-1 receptor agonist, and it does everything semaglutide does. But actually it simultaneously activates the GIP receptor, and this is not a small addition. The GIP receptor is in adipose tissues, enhances insulin sensitivity, the most important thing. The GIP receptor in the brain amplifies satiety signals beyond what GLP-1 alone can achieve. And together they create synergistic fat oxidation. Mind it, synergistic fat oxidation through a dual incretin axis. So to prove it, the first thing is the landmark evidence, the SURMOUNT-5 trial, the head-to-head trial, which was done taking semaglutide and tirzepatide. And let me bring you the most important piece of evidence. In 2025, the New England Journal of Medicine published the results of SURMOUNT-5 trial. And what was the result? Tirzepatide had 20.2% body weight reduction as compared to semaglutide, which was only 13.7% body weight reduction. And that is 47% greater relative weight loss in achieved with tirzepatide as compared to semaglutide. So tirzepatide won all 5 secondary endpoints as well in the SURMOUNT-5 trial, and this is not a close race, of course. This is decisive. And if I talk about the numbers, then again, tirzepatide wins at every threshold. If you look into the average weight loss on tirzepatide, 22.8 kilograms achieved as compared to semaglutide, only 15 kilograms. So tirzepatide patient lost almost 7 kilos lost 7 more kilos as compared to semaglutide. But here is what I find the most compelling thing. Look at the proportion, most importantly. The patient who achieved more than 10% body weight loss, 81% were on patient achieved on tirzepatide as compared to 61% versus semaglutide. More than 15%, 67% on tirzepatide, 44% on semaglutide. More than 20, 45 versus 27, and more than 25% body weight loss, 31% versus 16.1, and that is nearly double. And waist circumference reduction, this is very important thing. Weight circumference reduction 18.4 centimeters on tirzepatide versus 13 centimeters on semaglutide was achieved, and this is 5 additional centimeters of visceral fat cleared from the vital around vital organs. If we look out quickly, the HbA1c reduction again. Tirzepatide has superior diabetes management for patients with type 2 diabetes. Glycemic control is a matter of life and death. And every percentage point of HbA1c reduction translates a fewer amputations, fewer kidney failures, and fewer cases of blindness. So which drug should be used? Choose it wisely. The clinical trials also, the evidence also have shown that tirzepatide, the mean HbA1c reduction was 2.01% as compared to semaglutide, that is only 1.86%. And tirzepatide also produced the greater weight loss as compared to semaglutide. Even the real world databases evidences, they have shown that the GLP-1 naive type 2 patient tirzepatide reduced HbA1c by almost 6.9 percentage points more as compared to semaglutide after adjusting for confounders. If you talk about heart outcomes, of course, as Dr. Rakesh has said, yes, I do agree semaglutide has a proven CVOT trials, but again, I would say tirzepatide can be compared, if I'm not saying it is superior, but they can be compared with semaglutide. And SELECT let's talk about SELECT trial. SELECT is a genuine important data, and I do not deny it, but here is a full picture. Again, in a real world study of patients with obstructive sleep apnea and type 2 diabetes, tirzepatide reduced MACE risk compared to semaglutide. Again, I would say have not shown the superiority, but they have been compared equally as against to semaglutide. And in 2025, Nature Medicine trial also emulated found tirzepatide provides at least comparable cardiovascular protection to GLP-1 analogs with established CV data. And let us not forget, weight is a #1 modifiable cardiovascular risk factors. And if tirzepatide removes 17 more pounds or say 8 kilos of weight on an average, it is protecting the heart more, and biology is inescapable. If we talk, let's quickly talk about obstructive sleep apnea again. I would say it favors tirzepatide. A category semaglutide cannot enter. Rakesh has already told this. Semaglutide does not have this approval, whereas in December 2024, the United States Food, Drug and Administration, that is USFDA, approved tirzepatide, marketed as Zepbound, for the treatment of moderate to severe obstructive sleep apnea in adults with obesity. And the SURMOUNT-OSA trial has showed that patients not using CPAP, tirzepatide reduced apnea-hypopnea index by 25.3 events per hour. And in patients using CPAP, the reduction was almost 29.3 events per hour. So approximately 43% of patients achieved full remission when tirzepatide was taken, as defined by the apnea-hypopnea index below 5. So the mechanism is almost clear. Tirzepatide's superior weight loss reduces pharyngeal fat and upper airway collapse. Greater weight loss equals to better OSA outcomes. If let's just talk quickly outside the trials. हमने trial बहुत पढ़ लिया. What happens in actual patients again? In some of the studies, I would discuss quickly the study 1 where Rodriguez et al. has shown that using the, he actually studied using the Truveta electronic health record database in a non-diabetic patients on tirzepatide, and what he showed as that the patient had 4.5% percentage points greater weight reduction at 6 months compared to semaglutide. Treen et al. Also has shown that in real ambulatory case settings, tirzepatide produced 7% weight loss versus 3.4% on semaglutide. Again, Chang et al. Also has shown that tirzepatide was associated with significantly lower all-cause mortality, cardiovascular events, acute kidney injury, and adverse kidney outcomes compared to GLP-1 alone, say semaglutide. So these are different databases, different research teams, different patient populations. If you talk about real-world data, and all pointing the same direction, and this is not a fluke, this is a pattern. If you talk about tolerability again, the drug is only as good as a patient's ability to take it. Efficacy data is irrelevant if patient quits due to the side effects. But here is a critical difference, I would say. Tirzepatide, if you look into tirzepatide, 2.7% of the patient discontinued due to GI adverse events, whereas if you talk about semaglutide, 5.6% of the patient discontinued due to GI adverse events. So patients are more than twice as likely to quit semaglutide due to intolerance as compared to the tirzepatide. So in the real world also, a patient who quits gets zero benefit, but a drug who is giving better tolerability means better adherence, and better adherence means better outcomes. So to conclude quickly, if we talk about mechanism, tirzepatide activates 2 metabolic receptors, semaglutide activates only 1. Trial data, yes, in the first ever head-to-head RCTs published in a New England journal, tirzepatide produces 47% greater relative weight loss. If we talk about diabetes, again, greater HbA1c reduction in every trial and every real-world databases. If we talk about cardiovascular outcomes, yes, superiority has not been proved, but again, the SURPASS CVT trial is ongoing, and yes, soon we'll be getting the data, the cardiovascular data. If we talk about tirzepatide, but again, comparable or superior MACE production is there, but yes, superiority has not been proven to a drastic effect. If we talk about sleep apnea, exclusive FDA approval has been there for tirzepatide, which has semaglutide. Unfortunately, has no such approval. Tolerability, patient gets quit semaglutide due to side effects as twice the rate as compared to tirzepatide. And yes, all the real world evidences, if we cumulatively see, every major EHR database confirms that the trial superiority in everyday clinical practice. So the score I have shown the benefits of tirzepatide as compared to the semaglutide. And when science leads, the answer is clear. Tirzepatide is not just another GLP-1, it is the next generation, and it has earned its position. Thank you.
Thank you, both of them. Basically, you made us all more confused, let me tell you. We didn't want it to be a debate, actually. We wanted you to score on tirzepatide, you on semaglutide. But unfortunately, what you have done is basically confused all of us. Probably both are good and both should be used in every scenario. So what I would say, you skipped on the oral semaglutide trials altogether. Osteoarthritis trial, you didn't, because FDA has given the approval, I think so. Second one is that we could have selected few scenarios where probably tirzepatide scores better and some on semaglutide scores better. That will be easier for the audience as well. Can you do that? Four from you, 4 for you.
We have discussed
Please.
already. Yes.
So I think this is the slide, sir. Dr. Patel, this slide answers your question.
Rakesh has already told her when, where to use, how to use tirzepatide. And
चलो ऐसे नहीं. ASCVD है, which molecule?
Semaglutide.
Risk factors है, which molecule?
Semaglutide.
Osteoarthritis है.
Any of the two.
Any of the two? Which is the FDA approval is there?
There is no approval for osteoarthritis. I don't think there is approval from FDA.
I think we can look into the literature further about it. OSA? Right. So, and with preserved ejection fraction?
Semaglutide.
So, what more is left, Abhishek? You can add to it. Better side effect tolerability?
Tirzepatide.
Right. So this economic front.
Semaglutide, definitely.
Why do you say so?
Semaglutide, anyways, the innovator is also cheaper than tirzepatide, and if you go for synthetic ones, then
so innovators are cheaper than tirzepatide. That's more important because presently we cannot compare the synthetic ones. Right. Thank you. Any other query from the audience? We will take it.
Thank you.
Huh? Okay.
Semaglutide has the ESSENCE trial, and based on that, it has got approval for usage in MSLD patients.
Sir, are we talking about semaglutide being superior just because it has more studies regarding the CVOT and the renal?
See, to be fair, I would say that studies are there with both of them. Semaglutide came earlier, the studies have gone completion, and that's why it got the approval. As Abhishek told earlier, the trials are ongoing for tirzepatide, and soon you will get approval for the other indications by tirzepatide also.
Yes, sir. Unless the GIP activation has different side effects, it's a matter of time tirzepatide gets all these approvals.
Yeah, that's what I said. Probably maybe in future you might get. Yeah.
So we don't have much of a time. Just I want to conclude with one. Select trial was stopped earlier. It showed some results. But the MMO trial has not yet shown any results. So probably we are not aware of it.
Yeah.
Thank you.
Thank you. Thank you.
Thank you, both of you.
Thank you, sir. I request our captains to kindly felicitate our pilots. For the next session, I invite Dr. Vijay Panikar, sir, Honorable Consultant, Department of Endocrinology, Diabetes and Metabolism, Lilavati Hospital, Mumbai. Dr. Tanuja Manohar, Professor and HOD, Department of Medicine, NKP Simpson Research Center and LMH, and Dr. Aziz Khan from Nagpur, Senior Cardiologist. For the session, I invite Dr. Raman Puri, sir, from Delhi.
Hello. Yeah. Dr. Raman Puri is MD DM Cardiology, founder, chairman of the Lipid Association of India, so he's the right person to talk on lipids. Senior interventional cardiologist, Cardiac Care Center, Apollo Hospital, New Delhi. Formerly head Department of Cardiology, Safdarjung Hospital, New Delhi, and member of the International Lipid Expert Panel, fellow of the National Lipid Association, USA, member of the IAS Regional Federation, Asia Pacific. Sir Raman bhai, it's all yours.
Thank you very much, and good afternoon, everyone. And sorry, I'm not well today. My voice is almost, to some extent, paralyzed, so bear with me. So I'm going to discuss about diabetic dyslipidemia. It's some sort of a topic. Though we talk of diabetes, there are a number of conferences of diabetes, but how to manage and when to manage dyslipidemia is a big issue. We published our consensus statement on diabetic dyslipidemia management in 2002, and you'll be surprised this was the most popular JCL article in social media. This is a statement from Journal of Clinical Lipidology. Now, if we look into the burden of diabetes, we all know there is increase in prevalence of not only diabetes, also in pre-diabetes, and unfortunately, 70% of patients of diabetes, they die of macrovascular complication, means myocardial infarctions. You have to understand few facts about diabetes, Indian diabetic patients. We developed diabetes 10 to 20 years earlier than the Western population. At the mean age is around 25 to 34. And the age of peak prevalence of diabetes is 10 years earlier in Indians or South Asians as compared to Chinese and Japanese. We have more severe diabetic retinopathy than white Europeans at a similar diabetic duration of diabetes. And most important, you have to understand that we develop myocardial infarction or macrovascular complication 4 to 7 years earlier than the European population with the similar duration of diabetes and comparable prevalence of hypertension and dyslipidemia. And modeling work suggests that we can roughly explain ASCVD or MI in 22% of patients due to diabetes as compared to 7% in European population. This is one of the studies from United States where South Asians have high prevalence of diabetes and metabolic syndrome with high prevalence of atherogenic dyslipidemia with BMI which is either normal or mildly raised, and we have a high prevalence of coronary artery disease. And this trait of insulin resistance in the form of a diabetes or metabolic syndrome with atherogenic dyslipidemia with normal BMI is basically what we call as a South Asian phenotype. And we have more visceral fat, we have higher waist circumference, and if you look into the visceral fat, we have an ectopic site where the fat is deposited, and this fat is not inert, it is metabolically active because it releases number of inflammatory markers which are responsible for many of the consequences. And also the progression of pre-diabetes to diabetes, this conversion rate is significantly higher in Indian population as compared to United States and Finland. Majority of patients of diabetes have evidence of diabetic dyslipidemia. That diabetic dyslipidemia means there is increase in triglyceride with LDL cholesterol either normal or mildly raised with low HDL cholesterol, and increased prevalence of small dense LDL particle. Now, let us concentrate on some of the slides which I'm going to discuss that will be very important for you to understand. At the time of diagnosis of diabetes, especially in a younger, all these patients there is increased prevalence of ASCVD risk factors. Means these factors will make patient prone to have cardiovascular event. 25% are smoker, 27% are hypertensive. And in this study, you can see that at the time in patients with pre-diabetes, means the patient has not presented with diabetes, about 47% of these patients have positive coronary artery calcium score, means the calcium score is more than 0, which is, and you remember one thing, presence of calcium in coronary artery is a manifestation or reflection of atherosclerosis. So this means 47% of pre-diabetic patients have evidence of a subclinical atherosclerosis, and it is proved by the fact that a study from Miami has been done where it has been seen that about 58% of patients who are pre-diabetic, they have some evidence of subclinical atherosclerosis. And as a result of this, you cannot, since patient is asymptomatic, his stress test is negative, you say that the patient doesn't have coronary artery disease. That should not be a notion in your mind. And if you look into this study of 10 years, in which it has been seen that those patients with impaired fasting glucose, they have 29% relative risk of CVD and 42% relative risk of coronary artery disease as compared to those patients with who have a normal fasting glucose. A study from Chennai by Dr. V. Mohan also shows that 15% of patients of pre-diabetes have underlying coronary artery disease. Now, what does it mean? That when you diagnose a patient with diabetes, at that time, there is a 50% chances of this patient having a subclinical atherosclerosis without any symptoms suggestive of ASCVD. And even if you go for this patient's treadmill test and echo, it will be practically normal. You will say the patient, go back, you don't have any heart disease, without understanding that there is a lesion, underlying lesions. And another important statement which you are not aware of, that 2/3 of myocardial infarction, 2/3 of myocardial infarction is because of subclinical atherosclerosis. Means patient is asymptomatic and TMT is negative. So this thing you have to understand, because it's not an obstruction which manifests as a ASCS. It is the plaque morphology which makes it prone to rupture. So that is what you have to. So what LAI has suggested, and you will now understand that as soon as you diagnose patients of diabetes, you initiate statin treatment with a presumption, which of course no more a presumption, that this patient has an underlying subclinical atherosclerosis, and this is how we differ. This is one of the main difference between LAI recommendations versus other international recommendations. Now let us discuss about some international guidelines. ADA, what ADA says, for primary prevention, LDL cholesterol is less than 70% if their prevent score is more than 10%, and if it is less than 100% when their prevent score is less than 10%, and if it is more than 10%, it is less than 70 milligram. For secondary prevention means those patients with ASCVD without diabetes, the target is less than 70 milligram, and if the patient of diabetes and ASCVD, then the target is 55 milligram. Now, main problem with ADA recommendation is this, the age group of 20 to 39. According to them, that if there is no ASCVD risk factor, they have not specified whether you should give statin or not. That is the major point, very important point for us to understand. This I'll discuss at a later stage. And now let us come to the American Association of Clinical Endocrinology. They are very simple, that if the patient has diabetes with ASCVD, target is less than 55. Diabetes with major target organ damage, but no ASCVD is less than 70. And diabetes without other risk factor or no organ damage, it is less than 100 milligram. European score 2 diabetes, which was published in 2023, according to them, if a patient has diabetes with no target organ damage, and if the score is between 10 to 20, the target is less than 70, and if it is, and if patient has a diabetes with a score of less than 10%, no target organ damage, it is less than 100 milligram. And if the patient has underlying ASCVD, the target is 55 milligram. Now, question is what are the limitations of these international guidelines for us? One of the major limitation is age for initiating treatment, as ADA 2020 suggests. Now, the coronary artery disease in India is a health emergency. 25% of patients who present with myocardial infarction, they are less than 40 years of age. So if we follow ADA definition, and as I said, 22% of MI has a strong relation to underlying diabetes. So if we follow that, then we will miss this 25% of patients with MI, and probably we will not do justice to Indian population. And overall, we have a rising trend. Now, recently, the trend in USA has also started increasing, and one of the culprit for that is metabolic syndrome and diabetes. Now, second is diabetes and coronary artery disease. Everybody has said, all these guidelines says the target should be less than 55. But question is that if the patient has CAD plus diabetes plus CKD, who is a smoker, plus peripheral artery disease, will you have the same target? Answer, you will all agree to me that answer to this question is no. Let me justify it. Now, this is a study from IMPROVE-IT trial. Those patients who had only coronary artery disease, residual risk was 30%. It went up to 40% where there was diabetes, and it went up to 56% when there was associated peripheral artery disease. What does it mean? Can you have the same target for those patients with the residual risk of 30% and 56%? Answer is no. So that is one of the strong reasons that all cannot be put in one shoe, you know. So every egg, no, not all the egg can be put in one basket. And now this is a study from, Korea, where patients who presented with ACS, it has been, if you look into the 12 months outcome, those patients who had coronary artery disease only, the events were 0.5%. It went up to 15.6% when there was associated diabetes, and it jumped to 18.7% when there was associated hypertension. Will you have the same target for all? I think you are all intelligent to understand that you cannot have the same target of less than 50 milligram for all these three group of patients, And this is one of a very good meta-analysis of patients of diabetes plus ASCVD plus minus CKD. Here you can see that if the patient has CKD versus non-CKD, the hazard ratio for cardiovascular event varied from 1.6 to 3.2. So therefore, you have to have a different goals. Looking into all these aspects, LAI came out with a very simple algorithm. The algorithm suggests that you classify patients of diabetes into with ASCVD and without ASCVD. Now, those patients with diabetes without ASCVD, if there is no target organ damage or one or no ASCVD risk factor, is classified as a high risk group, and LDL cholesterol is less than 70 milligram. If there is evidence of target organ damage and 2 or more ASCVD risk factor, the target comes down to 50 milligram. And if the diabetes has an associated ASCVD and without target organ damage or one or no major ASCVD risk factor, he falls into category A of extreme risk group, and the target is less than 50, but the optional is less than 30 milligram. And if the diabetes with ASCVD plus target organ damage or polyvascular disease or 2 or more ASCVD risk factor, he falls into category B, where the LDL cholesterol target is less than 30 milligram. Now, coming to the justification for LDL cholesterol of less than 30 milligram, what is the scientific evidence that it is going to benefit our patients? The most important trial is FOURIER trial, in which the median LDL cholesterol achieved with PCSK9 inhibitor was 30 milligram. And it was seen that as compared to basal LDL cholesterol of 93 milligram, reducing it to 30 milligram, there was about 15% reduction in primary endpoint. And it is not only 30 milligram, it was seen in this trial that 2% of these patients achieved LDL cholesterol less than 10 milligram, and there was 31% reduction in event as compared to the LDL cholesterol of 100 milligram. Now, these are some of the three most important post-hoc analysis, which shows that lowering LDL cholesterol to less than 30 milligram, like in FOURIER trial, it was 21 milligram. In IMPROVE-IT trial, it was less than 30 milligram. In ODYSSEY trial, it was about 21 milligram. So they had significant reduction in cardiovascular event. 1 year after our LEI recommendation, National Lipid Association of United States also came out with a new statement for their South Asians living in United States. They also created a extreme risk group category, and they also included patients of CAD plus diabetes plus other ASCVD factor as category, extreme risk group category, and they recommended LDL cholesterol target of less than 30 milligram. This was exactly 1 year after our recommendation. But remember one thing, that in FOURIER trial, 14% of patients, despite achieved LDL cholesterol of 30 milligram, continued to have an events. So the question comes that we have to look beyond LDL cholesterol, and what we have to look at is the triglyceride of non-HDL cholesterol and lipoprotein small a. But one thing is very important. Before you start reducing LDL cholesterol, you make sure that you have treated all modifiable risk factors. That is extremely important on all secondary factors which can lead to any derangement in the lipid profile. Looking into the triglyceride, question comes whether treating triglyceride is going to reduce cardiovascular event. Meta-analysis of 5 landmark trial, I think you must have heard many times, doesn't show any benefit, but only it has been seen that if the triglyceride is more than 204 and HDL is less than 34, there is a significant 34% reduction in cardiovascular event. And reduced trial, though it was initially it was a triglyceride driven trial, but subsequently it was found not to be, shows 25% reduction in primary event with just 19% reduction in triglyceride. And so therefore, our LEI recommendation is very strong in that you should keep triglyceride below 100 milligram, preferably 150 milligram, preferably less than 100 milligram, and always treat, and the control of diabetes has to be maintained because uncontrolled diabetes may be responsible for increased level of triglyceride. Non-HDL cholesterol, as you know that non-HDL cholesterol means all the atherogenic cholesterol in the circulation, it should be within 30 milligram, in the range of 30 milligram of LDL cholesterol value. And ApoB is a manifestation or reflection of circulating atherogenic particle. And patients with diabetes, metabolic syndrome, and many other conditions, you make sure that it comes to the target. Objective of LEI is very clear, that you have to bring down LDL cholesterol, ApoB, and non-HDL cholesterol to the target. That is most important for us. This is an algorithm which shows how you should treat these patients of diabetic dyslipidemia and make sure that you bring down you achieve the target of LDL cholesterol, non-HDL cholesterol, and ApoB within 12 weeks time. And type 1, of course, should be treated in the same way in which you treat type 2 diabetes, provided it carries the same risk of ASCVD. The take-home message is very clear. Initiate statin on the day diabetes is diagnosed. Decide diabetic patient ASCVD risk category. Achieve LDL cholesterol, non-HDL cholesterol, and ApoB target at earliest, preferably within 12 weeks as recommended by LAI. Screen Indians for diabetes, pre-diabetes, and for other ASCVD risk factor, including lipid profile. Include lipoprotein A and ApoB level if possible at age 18 to 20 or earlier if indicated. Good glycemic control in addition to lipid-lowering drug is important to prevent microvascular complication and also to achieve lipoprotein target. Lifestyle intervention is very important. Shortly, we are going to launch LAI ASCVD risk calculator. It will tell you that what should be the LDL, non-HDL cholesterol, and ApoB target of the patient which you are treating. And this is the LAI anthem which we are going to release shortly. This is something which is unique. I think just wait for about week to 10 days time. Thank you very much for your kind attention.
Thank you, sir. Very nicely you have elaborated, and you have also told the Indian contribution of these different categories of South Indian phenotype. That is, I think, Indian contribution to the Lipid Association, World Lipid Association. So thank you, very nicely elaborated.
Thank you, sir. Okay.
Thank you so much, sir. Now I request the captains to please felicitate the speaker and Dr. Sunil Gupta, sir, to join them. For now, moving ahead to the next session, flight number 59 on non-HDL cholesterol. Will it replace LDL cholesterol? I call upon Dr. P.K. Deshpande, sir, senior physician from KG Deshpande Memorial Center, Nagpur, and Dr. Aarti Dharaskar, ma'am, Director, Indrayani Hospital, Ramdaspet, Nagpur, and Dr. Purvi Chawla, ma'am, to speak on the topic.
Good evening, everyone. Thank you so much for this Hatke topic. I should say a big thanks to Dr. Sunil Gupta, sir. I actually read quite a bit to understand what I had to speak on. And really, this is a very important aspect that most diabetologists or most physicians, most clinicians tend to miss. So let's see what is in store and why such a simple calculation can, and just eyeballing at the report itself, because we are doing the report, we are looking at everything else, but we're just missing this tiny bit which can actually have a massive impact. So let's understand what non-HDL cholesterol has in store for us. Yes, LDL has always remained our dominant treatment goal for dyslipidemia, and most guidelines across the world endorse that. And yet, there is a good 20-23% of patients in clinical trials, especially, that face recurring cardiovascular events even after reaching the LDL targets. So relying on LDL seems to be, we are missing something important, and this entire atherogenic risk that we seem to be tackling is not really tackled efficiently. And this blind spot that we have, well, LDL is just one part of the puzzle, and the entire big picture, we are missing that. So a better marker in proposition is the non-HDL cholesterol, which is capturing all atherogenic and artery clogging particles in a single and a very clinically efficient manner. And of course, a superior marker, biomarker, means earlier detection, smarter treatment, and better outcomes for all patients at risk. Now, just to explain this, well, all the lipoproteins differ based on their composition, their size, and also the associated apolipoproteins along with them. This is not a masterclass in lipids, so I'm not going to go into the details. But just to say that these apolipoproteins basically govern the metabolic fate of the lipoproteins they are associated with. And in addition to LDL and HDL, the other major lipoproteins in the blood are these, the TRL or the triglyceride-rich lipoproteins. Now, these TRLs represent the liver-generated bulk of cholesterol. That is the VLDL, the IDL, which is the intermediate density lipoprotein, and the chylomicrons, which are gut-based. So, and then the entire bulk is that, I mean, the idea is that chylomicrons are derived from the gut, and they remain, they're only present in the postprandial period as such, and they are rapidly metabolized to chylomicron remnants. So we always look at the remnants as part of the non-HDL cholesterol. Along with the chylomicron remnants are also the VLDL metabolites, which are the VLDL remnants. Right? So all together, these chylomicron remnants, and it's all shown here in the diagram, the TRLs and the remnant chylomicrons, together they give us the TRL remnants. And the lipoproteins are associated with one or more specific apolipoproteins characteristic of each lipoprotein, like I just said. And hepatic derived LDL, VLDL, IDL, and the VLDL remnants, which are the metabolites, each of them carry ApoB100. Again, this is shown in the diagram right here. While gut-derived chylomicron and chylomicron remnants carry the ApoB48, a truncated version of ApoB100. Lipoprotein little a, again, that's another class, but that is also associated, and it's tagged right here with the non-HDL cholesterol. So VLDL and other LDL-derived lipoproteins carry the cholesterol from the liver to the periphery and are major players in atherosclerosis. This is the point I'm trying to make and give you just a bird's overview of what these different particles are like. And whereas the HDL is the reverse, it carries the cholesterol from the periphery to the liver, right, for further metabolism. So thus, these are the major atherogenic particles. Now the non-HDL particles, like I told you, the chylomicrons, the VLDLs, the IDLs, the lipoprotein little a and the LDL, all these together are involved in atherogenic initiation as well as progression, and the entire cascade is shown here. But just accept from me at this point that yes, they are all closely involved in the atherogenic process, and it's not just the LDL alone. Just to further belabor on that point, non-HDL particles all are atherogenic, not just LDL, and they actively deposit the cholesterol in the artery walls over time. This silent buildup narrows the arteries, obviously, and then the further events occur, and there is restricted flow as well. So the comprehensive atherogenic picture, well, non-HDL-C is an all-encompassing measure by including all the cholesterol-carrying lipoproteins contributing to the plaque buildup in arteries, and is a more complete assessment of the cardiovascular risk rather than LDL alone. I showed you what adds up to non-HDL cholesterol. So first, it's the LDL cholesterol, which we know, which is established. Now the triglyceride-rich lipoproteins, these are particles like the VLDL and the chylomicron remnants. These also directly contribute to atherosclerosis, particularly in insulin-resistant states, and this is where we come in. We deal with metabolic dysfunction as well as diabetes, both states of insulin resistance. Then we also have the TRL remnants, which are smaller, denser remnants of the TRLs that are highly atherogenic and can penetrate the artery wall, and they can initiate that inflammation as well as the plaque growth and further cause cardiovascular events. Lipoprotein little a, it's a genetically determined particle with both LDL-like and prothrombotic properties independently linked to increased cardiovascular risk. So this establishes that it's not LDL alone, but it's the entire gamut which is non-HDL cholesterol, and this diagram shows it really clearly that it consists of the VLDL, IDL, LDL itself, lipoprotein little a, and chylomicrons temporarily, but chylomicron remnants as such, and the formula total cholesterol minus HDL will just simply give us the non-HDL cholesterol fraction. It is as simple as that, and this entire gamut gives us a more comprehensive picture of the cardiovascular risk. The ADA has definitely shifted its focus, and they are saying that historically we have been LDL centric, but now we are endorsing non-HDL-C and ApoB for better risk assessment in diabetes. And this is a significant shift, but there is a lot of evidence to support that. So we've seen that, well, 40 milligram per DL reduction in LDL with the statins, and you have a 22% reduction in the events, right? However, there is still a residual risk, and this is what we are trying to ascertain, and this is what we are trying to address. So despite achieving recommended LDL levels, many patients still experience MACE or major adverse cardiovascular events, and we have a whole lot of studies to corroborate that. For example, a meta-analysis of 14 randomized controlled trials which lowered LDL found that the 5-year risk of MACE even after reaching the targets of LDL was 14% versus 18% in the statin versus placebo-treated arms respectively. Another massive study of more than 62,000 patients on statin therapy along with controlled LDL but elevated non-HDL reported a 32% higher risk of cardiovascular events. Again, there were different subsets also. Those on statins still had a higher risk of all-cause mortality as well as myocardial infarction. So this clearly shows that there is a residual risk, and this is what we are trying to assess by just simply subtracting the HDL from the total cholesterol values that we have. Now, there is strong evidence for other contributors to non-HDLC being independent cardiovascular risk drivers. Remember that the LDL, which is part of it, it is already established. Now, these are the other particles which make up non-HDLC, which are also, there is enough evidence to show that they are also cardiovascular risk markers, and I've enlisted all of them here. Well, it is a residual risk factor in cardiovascular disease. Now we are establishing that without a doubt. And guidelines as early as 2018 also endorsed that non-HDLC and ApoB100 were highlighted as additional risk factors for atherosclerotic cardiovascular disease and a major determinant of therapy decisions. In fact, they were promoting PCSK9 therapy in these kind of patients. Although ApoB100 appeared better, there is still a lot of debate whether we should be doing it, and I'll show you why in the Indian setting it is really not practical to do that. Now, the European consensus guidelines also showed that non-HDLC, in fact, as a secondary treatment target because of the lack of significant health economic benefits from interventions aimed at reducing ApoB100 at very low LDL levels. So, eventually, the European guidelines have said that use HDLC, non-HDLC as an important input into the systematic coronary risk estimation tool or the SCORE2 algorithm for assessing the disease risk itself. And other bodies like the Residual Risk Reduction Initiative, which is a globally active multidisciplinary non-profit organization, they have also emphasized on the same, that use HDLC while making treatment decisions, and this justifies the use of niacin, fibrate, omega-3 fatty acids, ezetimibe, and so on and so forth. Now, estimation, well, it's a very simple calculation. The formula is right here. No additional tests required except the total or the lipid profile that we are generally performing for our patients anyway. And then the threshold should be 30 less, 30 added to the LDL target that we have. And I'll show you that also in a couple of minutes. Given the food pattern consumption, well, the Indian client or Indian patient is always in a postprandial state, right? Almost lasts for 16 hours or so. And this makes a pure evaluation of dyslipidemia or atherosclerosis very, very difficult. So non-HDLC values are actually very consistent, and they are stable during fasting, and they do not require as much fasting as such, and that's why they are a better prognostic marker. But of course, there are underestimations and inaccuracies as well, and hence we need larger studies to come up with what exactly is a good target to follow for the same. So here we see that yes, LDLC does not capture the residual risk in diabetes, but non-HDLC does. It is endorsed by the ADA as well, standardized across Indian labs, yes, and there is zero additional cost to the patient because you're anyway doing the lipid profile. Now, ApoB used to be the gold standard, but in India, it's a far more expensive, not standardized test, and I will not give it that much importance when we already have a very simple calculation, which is a persistent and a predictive biomarker of the cardiovascular events that can occur later, especially in the younger population. Again, I have a whole lot of evidence compiled here for your perusal, just to show us that it has a greater impact in people under 45 years of age. And in the older patients over 60, it is still statistically significant, but the value attenuates. So early prediction and long-term protection is something that we can achieve with non-HDL cholesterol estimation. And again, even with statins as the first line of therapy, we've seen that there is still a residual risk, and statin add-on therapies targeting these other particles in the non-HDL cholesterol do reduce the residual cardiovascular risk. Again, we have a lot of evidence to suggest that, and there are very famous studies and very large studies to show us the same. Now again, trials, just give me 2 minutes more. Fourier trial for the which was with the PCSK9 inhibition found that there was mitigation of this cardiovascular risk. Trials with fibrates have also shown that. And then fibrates added to the simvastatin in the SAFARI study showed that there was incremental reduction in the non-HDL cholesterol and ApoB irrespective of the baseline triglycerides. The prominent study with selective PPR alpha modulation also found that no cardiovascular protection was seen only by targeting the triglyceride levels as long as the non-HDL-C levels were negligible in their change. So basically all trials are telling us that target that non-HDL-C effectively with all these other agents that we have in our armamentarium, and you will be able to address the residual risk. So this LDL is leaving a gap or a dangerous blind spot, and which is what we are capturing with the entire assessment of this residual risk with non-HDL-C. And this is a full atherogenic index. Many other indices are also there, but none have been validated in clinical trials as such. Now, the special populations require some attention because those who are on statin risk, we may forget that they do have this residual risk. So it's important to note their triglyceride levels as well and understand the non-HDL cholesterol levels. In obesity and diabetes, which we deal with day in and day out, is again there is an increased burden of atherogenic lipoproteins, and we need to address this. Metabolic disorders again are associated with complex dyslipidemia, and we need to understand this. So lots of studies have confirmed and major global associations have endorsed non-HDL-C. And this is a practical tip that if our target is 70 for LDL, then just add 30 to it, and 100 should be the non-HDL-C target for us. But there is some debate about what is high risk, moderate risk, and low risk with respect to non-HDL-C. But this is a good target to have. So whether it is a very clear signal when the LDL as well as non-HDL agree, or they don't agree, there is a hidden high risk, and we need to keep that in mind. So just relying on a single cardiovascular marker is not enough, and we need to have a more global perspective. So traditionally LDL, we are moving away from that towards an evolving biomarker, which is non-HDL cholesterol as a co-primary treatment goal. So don't get me wrong, I'm not saying it is replacing LDL, I'm just saying it is to be looked at along with LDL-C, and this is the new standard shift that we are observing globally. Again, globally, it's not easy to just adopt those Western guidelines to the Indian scenario because the LDL the lipid level or the dyslipidemia proportions are different across the regions based on the dietary habits, lifestyles, and healthcare systems worldwide. And this disparity needs to be considered when we come up with our own guidelines. So yes, from secondary endpoint to a primary endpoint, it's come to that focus, and we are looking and all guidelines, whether the American guidelines, the European guidelines, or even the Indian guidelines, are clearly telling us to look at the non-HDL cholesterol as an important biomarker. So yes, it's not an overnight replacement, and this is the last slide, but it is a more complete, accurate, and an actionable biomarker that we are looking at. And now it is in the fore. The future of lipid management is far broader than what just one cholesterol number. And as prevention becomes more personalized, clinicians will need markers that reflect the full burden of atherogenic particles, especially in those living with diabetes, metabolic syndrome, elevated triglycerides, or mixed dyslipidemia, just like our Indian population. So thank you very much for a patient hearing, and I'll be happy to discuss this further.
Thank you, Dr. Purvi, for excellent, flawless lecture on such a topic. I think the take home will be that not only LDL to be looked in the patients who are at a high risk for CVD, but also to take care of non-HDL-C for that matter, especially in Indian population where triglycerides are seen on very much on the higher side. So we have to look as whole non-HDL as well as LDL for to consider it into a risk factor for these patients for CVD. Thank you so much.
Summarized it perfectly. Thank you.
Thank you.
Thank you, ma'am. I request all our speakers to kindly come on this stage. And if you have any query, you can ask. Session is open for discussion. Dr. Raman Puri, sir. Dr. Purvi Chawla, ma'am.
मेरे को भी ऐसा फीलिंग आता है so in pregnancy, so I feel you are lucky to be there sharing dais with boss. Sir, there are some questions with Dr. Aziz Khan, and anyone who has any question on lipid, you can please start with
first.
Yeah.
I should congratulate Dr. Sunil for bringing such a giant personality to Nagpur, Dr. Manpuri. In fact, I want to tell something about more that he has been honored as father of lipidology by American Association of Indian Origin Cardiologists. He is the only member of National Lipid Association from India, and he has set all guidelines. Now, if you see any Western literature, they have put light guidelines, and our coronary arteries are different. Our everything he has mentioned, and then every reports also say that it is by Lipid Association of India. I am lucky to be working with him for last more than 10 years, and I wish I will continue to work with him. So there are some queries. Madam is also there. So if I'm a cardiologist, we get patients with diabetes, lipidemia. Even after getting LDL 70, still most of the patients, they come back with ACS or
Mike.
What did you ask?
patient of diabetes with even LDL cholesterol. A lot of patients get events. This is something more than LDL, which is important, and then we should look for that.
I think that if you look into our 2016 guidelines, I'm talking 10 years before, we were the first association to recommend LDL cholesterol as a primary target, non-HDL cholesterol as a co-primary target, which ADA 2026 has now incorporated. 10 years after what Ali said, now they have incorporated in their 2026 document. And ApoB as a secondary target. So, and our objective is very clear that when the treatment of dyslipidemia will not be complete unless you achieve LDL cholesterol, non-HDL cholesterol, and ApoB to the target. Now coming to non-HDL cholesterol, one thing, another important, there are important points which I would like to discuss, though it was not part of my statement, that triglyceride per se never cause atherosclerosis. Triglyceride per se will never cause atherosclerosis, but it is the cholesterol content of the triglyceride-rich lipoprotein, which we call as a remnant cholesterol, is responsible for atherosclerosis. But triglyceride contributes to atherosclerosis because it's a pro-inflammatory, it causes endothelial dysfunction, and that helps in migration of LDL particle into the subintimal space, number one. Number two, when there is now, like Dr. Chawla has spoken, that when there is a remnant particle goes into the subintimal space, it is possibly that since we as a nation have high triglyceride, why we have a malignant atherosclerosis is that these remnant particle, once they enter into the subintimal space, they have two components, triglyceride and LDL. Triglyceride cause intense inflammation that results into the aggressive progression of coronary artery disease. So that is one you have to understand very well. And ApoB eventually, not now, after 10 years, probably we will be alive or not, you will see that it is going to be a primary target. And because every particle, each atherogenic particle carries only one ApoB, so it gives you a reflection of atherogenic particle. Now coming to the ACS, now coming to the background of ACS. In patients with acute coronary syndrome, I don't know how many of you are here are cardiologists, but many of you patients, many of you must be seeing the ACS, acute coronary syndrome patient admitted. Once patient with acute coronary syndrome is admitted, you take lipid profile at the time of admission. When you take other samples like KFT and all that, you take lipid profile also with possibly lipoprotein small a with that. And you stratify the patient ASCVD risk category, in which risk category patient falls into. So when you are able to stratify that patient, you know what is the target. By the evening, you will be able to get the report that this is LDL cholesterol. And then you will know how much LDL cholesterol you have to reduce. Now, as soon as patient with acute coronary syndrome comes, you give two drugs, rosuvastatin 40 milligram plus ezetimibe 10 milligram. This has to be given, irrespective of what is the LDL cholesterol value. Now, in the evening, when you get a report and you think that you require more than 65% reduction, because ezetimibe plus rosuvastatin or atorvastatin high dose will reduce LDL cholesterol by 65%. If you require additional, you can add bempedoic acid on day 1. And if you think it is more than 20% required, you can advise PCSK9 on day 1. You don't have to wait as based upon Western guidelines that wait for 4 weeks or 8 weeks or 12 weeks. No. Why you want to waste time? When you have to bring down LDL cholesterol to the target, you bring it down within the shortest possible time. And you all know that majority of mortality in ACS is in first 15 days to 1 month's time. So you have to be very aggressive. So this is what LAI has recommended in 2022 in patients with acute coronary syndrome.
But our paper has been accepted by American Association of.
Absolutely, absolutely.
People combo therapy in SCS.
Yes, yes. Now, after our recommendation in 2022 of ezetimibe plus this high-intensity statin, European guidelines came. They also endorsed what we normally said, but with manipulation of words. Then we did one more study. I think it will be something that you will all be surprised that it is an LAREX study in which we gave high-intensity statin plus ezetimibe plus bempedoic acid, all 3 drugs, as soon as patient came in the emergency. And we found that we were able to achieve LDL cholesterol less than 50 milligram in just first week in 50% of the patients.
Yeah. Madam has well spoken of non-HDL cholesterol, madam. What are our line recommendations for non-HDL cholesterol? Sir?
No, as I said that we have already recommended in 2016 that it is co-primary target as important as LDL cholesterol. You want to say something?
No, no. I think this has been a huge lesson. We are not typically used to looking at non-HDL cholesterol, even though the guidelines clearly say so. I think we need to revise guidelines and sort of guide people more on how to go about it, because it's a very simple test, very practical, and can save.
Rather, non-HDL cholesterol is a poor man's ApoB. You can say it's a poor man ApoB. Yeah.
So my first question is for Dr. Ramanpuri, sir. Sir, do PCSK9 inhibitor like evolocumab has a defined role in diabetic dyslipidemia in current 2026 guideline?
Okay, should we give PCSK9 to this patient? Answer is it should only be given if you are not able to achieve LDL cholesterol target with the high-intensity statin. I'll not say high-intensity statin, maximum tolerated statin, because some patient may not tolerate high-intensity statin, plus ezetimibe plus bempedoic acid. If you are not able to achieve target with these, then of course you should consider PCSK9. And if, for example, there is associated elevated lipoprotein small a, because PCSK9 reduces LPA by 25%, so that will be added advantage of giving PCSK9 in these patients. Remember, all diabetic patients, you should bring down LDL, non-HDL and ApoB to the target in 12 weeks time, in 3 months time.
Sir, my last question is, should we do fasting on the lipid profile or anything to do?
Oh, it should be non-fasting, because 18 hours out of 24 hours, we are in a non-fasting state. And what it makes difference is that it increases triglyceride burn on average about 20 to 25 milligram. And there is a minor changes in LDL, HDL and other parameters. So I think that non-fasting is always better. And it has been seen that those patients, those population with LDL cholesterol in a normal range or a triglyceride in a normal range in fasting state, they have abnormal range, postprandial triglyceride. There is a test also in which you give fat loading test when you give it, and you find that there is an abnormally high triglyceride. And those patients who have postprandial hypertriglyceridemia, they have higher chances of having coronary events as compared to those who have a normal physiological increase in triglyceride.
Sir, also.
Even the this chylomicrons are on the higher side after postprandial. So to calculate those chylomicrons into the our target, it's better post meal or non-fasting
In
state.
2 hours time, I don't think chylomicron remnant will be there in the circulation. It is
Okay.
removed very fast. You will have VLDL remnant, of course, at that time.
So the only thing I just wanted to share is a very important study which we have done, and just to share it with you. We have done this fat load test, and we have given high fat diet to the individuals with diabetes and non-diabetics. And what we have seen, we have done 0, 1, 2, 3, 6, 7, up to 7 hours we have done the test. How is the rise of the LDL cholesterol, total cholesterol, triglycerides? And what we found is cholesterol, total cholesterol, HDL cholesterol, LDL cholesterol doesn't change significantly as far as statistical analysis is concerned from 0 hours to even 7 hours. But the triglyceride goes up to around at 4 hours is the peak. Like glycemia, you have 70 minutes blood glucose, but it goes 4 hours is peak, and it comes down at around 7 hours. The only important message is in diabetics, the lowering down of triglyceride is slower, and it remains at 2 hours level, versus the diabetic it comes down to the baseline. So what we have presumed, and maybe you can have an expert advice on this, comment that the resident time of triglyceride in diabetics is higher after taking a high fat meal versus non-diabetic.
See,
Is
it
there
has
any
to,
significance to
yeah,
this? as
yeah.
well?
It is because if you look into insulin resistance, there is inhibition of ApoC3. This is one of the mechanism why there is increase in triglyceride, because one factor which increases triglyceride is increase in free fatty acid because of insulin resistance. And second most important factor is that there is inhibition of ApoC3. And this inhibition of, not inhibition of, there is increase in ApoC3. And this ApoC3 is responsible for inhibition of lipoprotein lipase. So because of insulin resistance and higher ApoC3 level, you will find a persistently higher triglyceride lasting for a much longer time in patients of diabetes as compared to non-diabetes. So physical exercise is extremely important to make a person more insulin sensitive. And of course, you give insulin sensitizer like pioglitazone and metformin. And one of the mechanism by which pioglitazone reduces triglyceride. It's one of the most important drug, not only for diabetes, but for coronary artery disease, because there is only one study of pioglitazone which have shown that it reduces myocardial infarction and reduces trauma volume also. So I think that it is the insulin resistance leading to increase in ApoC3 is responsible for much of this.
Be an additional contributing factor of higher evidence, means high amount of cardiovascular disease in diabetes because of the higher resident time of this.
That's what I'm saying. So the basic mechanism is, increased level of ApoC3.
Thank you very much. Thank you.
Dr. Purvi Chawla.
We'll have to stop it beta here. To stop it, Purvi will be available with you because we're already late by almost 1 hour. Yeah, please.
Thank you.
Thank you.
Thank you so much.
Thank you, sir. Thank you, ma'am. For the flight number 61, I request our captains to kindly felicitate our speakers. For the next session, I invite Dr. Advait Mahale, General Medicine Physician, Chintamani Hospital, Amravati, and Dr. Pramod Shirbhate. I request Dr. S.B. Gupta, sir, to kindly chair the session. I also invite Dr. Jairaj Korpe, sir, consultant nephrologist, hypertension and transplant physician.
Sometimes when captain is not there, I think co-captain, though I don't think there is any such a definition. Pilots and co-pilots are there, but you are here. Come, please. We have a very prominent pilot or speaker, Dr. Sarita Bajaj. She is MD/DM in endocrinology from AIIMS Delhi. She is a consultant endocrinologist, and she is a former director, professor of head of the Department of Medicine from MLN Medical College, Prayagraj, the old Allahabad, and president Indian Thyroid Society, president RSSDI. I think so many laurels are there. And she started Professor Sarita Bajaj Oration in RSSDI UP chapter. She has received the Lifetime Achievement Award. And I think she has delivered so many orations, and would request Dr. Sarita Bajaj to talk on offspring of pregnant women with diabetes.
Thank you, respected chairpersons. Thank you, Sunil, Kavita, Shlok, Swar, and Binny for the invitation. I would like to echo what Jyoti Dev said. I think this is our favorite family, isn't it? And I think we really love them, and we would like to emulate such a family. So it's a pleasure to be here. A part of the stage was set for my talk by Dr. Manilka in the morning. And this is the roadmap that I will be following. So this is a very, very well established, right? But again, there's never any words that can fail or expressing it again and again. That hyperglycemia during pregnancy is a double-edged sword which affects not only the mother, but the offspring as well, creating a vicious cycle which can affect multiple generations. And this is not known now. If at all, we are half a century late, because the Peterson hypothesis was first proposed 50 years ago, that neonatal growth, specifically neonatal adiposity, is not limited to overt diabetes, but it extends across the full range of maternal glycemia. The mother's glycemic status and weight, which is exactly what Dr. Manilka said in the morning, before, during conception and pregnancy, influence the long-term health of the offspring, and the future health of the offspring can be programmed through the role of epigenetic changes which are induced by a hyperglycemic environment in utero. So this is the transgenerational transmission with epigenetic changes. And we're not just talking of nutrition. You have to consider smoking, alcohol, radiation, a sedentary lifestyle, and stress is also included. And these are the metabolic complications for the mother, for the fetus, for the infant, and for the adult as well. The degree of glycemic level and the timing of exposure also matter for the long-term offspring health, and not just metabolic problems. Neurobehavioral and neuropsychiatric abnormalities are also described. Now, for the last couple of years, we are talking of early GDM or eGDM, that is less than 20 weeks. So always the focus was between 24 to 28 weeks. But even this period is also crucial. So early GDM, it can be genuine, or these patients become regressors. Late GDM potential, or at the end of it, they may be entirely normoglycemic as well. Now, what is the importance here? Postpartum diabetes is seen in up to 1/4 of early GDMs and about 12% in late GDM. In early GDM, all these complications are also described. And we have different phenotypes, severe, moderate, or mild, based on the clinical, the antenatal OGTT phenotype, the subsequent blood glucose monitoring, and the pregnancy complications, which are obviously there with severe EGDM. So just to close off that little aspect here, this presents a crucial opportunity to, so if we have not been able to prime them before pregnancy, this is a very, very crucial window. It has multiple phenotypes and it requires a distinct approach. We're still not sure how to manage it, and precision and personalized medicine is extremely important. Right, moving on to the other complications, right? Dyslipidemia. Maternal, we were having a wonderful discussion just before my talk on dyslipidemia. And again, this is governed during pregnancy. Maternal GDM increases the risk of not only dyslipidemia in the early 3 to 9 years of life, but it is a strong predictor of CVD risk in adulthood. If we follow 4 decades, the cardiovascular risk during maternal diabetes pregnancy, it spans at least over 4 decades. Dr. Manilka was speaking about the next pandemic, or maybe epidemic. This is NAFLD with MASLD to be more precise now. Even that is decided during gestation of the fetus. Look at the weight gain and adiposity at 1 year of age. Maternal insulin sensitivity during pregnancy also predicts this in the first 12 months. And this is independent of glucose tolerance status in utero. If we follow these children from birth to 6 years, again, this is a very, very important study, which highlighted that maternal glucose intolerance, even without confirmed GDM, is linked to higher BMI and overweight risk in early childhood. And clinical monitoring should extend to glucose tolerance test or OGTT mothers and their children for early preventive interventions. The EPOCH study, another very landmark study, which showed that in utero exposure to GDM may program altered eating behavior in potentially increasing obesity risk through higher energy intake, and obviously altered eating behavior would lead to a greater risk of obesity later in life. The Pune maternal nutrition study, again, a very, very excellent study, which is now spans almost a quarter of a century. They have looked into the association between the maternal B12 status in pregnancy and the child's neurocognitive status at 9 years of age. The other aspect that they highlighted was that compromised linear growth, adiposity, inflammation, and less physical activity predisposed to hyperglycemia in young rural Indian women. What about the gut microbiota? Even gut microbiota are now being attributed to a lot of NCDs. So from GDM mothers, the infants from the first week of life persisting into infancy, they show altered gut microbiota. Though there's no difference in the overall diversity, it is linked to reduced microbial richness, inflammation, and future metabolic dysfunction. So need for early monitoring and potential microbiota targeted interventions may also mitigate long-term metabolic risk. We cannot talk about NCDs and not talk about vitamin D. You can see how important vitamin D is. All the maternal and fetal outcomes I've highlighted here, and supplementation reduces not only the maternal and neonatal complications, improves fetal growth, bone development, and it lowers the incidence of respiratory and immune-related disorders. Even reproductive health risk is there. Prenatal GDM exposure may impair gonadal development and hormonal milieu, raising the risk of subfertility in adulthood. So what does ADA 2026, the preconception counseling? It should begin at puberty for all individuals with diabetes and childbearing potential, family planning, effective contraception until glycemia is optimized. The A1C targets, even Jyoti said, we can go down to 6, provided we can avoid hypoglycemia. So the risk is always there, and preconception screening and care are essential to identify and manage hyperglycemia early. So obviously the outcomes are better, the health is better with early intervention. CGM, again, I won't go into details. Dr. Jyoti Dev discussed this excellently in the morning. Yes, better glycemic control, lower maternal weight gain, and reduced infant birth weight. In other words, lesser risk of macrosomia. Now, since we are talking of the offspring, breastfeeding has again a very, very important role to play. So there are a lot of advantages apart from the species that I have highlighted here. As opposed to formula feeding, it will support infant nutrition, growth, development, reduces risk of obesity and the metabolic complications that I have highlighted. And there are excellent articles like the Swift Offspring study showed that breastfeeding is associated with a lower risk of becoming overweight among offspring of diabetes mother in retrospective studies, but other studies did not find such a protective effect. Case control studies have reported that longer breastfeeding duration may lower the risk of developing type 2 diabetes. What about the impact of breastfeeding on risk of glucose intolerance in early postpartum? So breastfeeding, exclusive and mixed milk feeding, again are associated with less glucose intolerance, better metabolic profile. When exclusive is not possible, then mixed milk feeding can also be encouraged, and the women should be educated regarding this prenatally. Again, another very important study that there is a role, short duration of exclusive breastfeeding in protecting GDM women against type 2 diabetes. However, there are unique challenges facing women with GDM in breastfeeding, which cannot be accounted for by the confounding factors of obesity, parity, and maternal age. What happens to the impact of maternal glycemia on breast milk composition? So whether the glucose levels at or prior to breastfeeding, they should not influence the decision to breastfeed. Though, of course, future research should aim to expand the understanding of different bioactive components of breast milk. Now, what about type 1 diabetes? Again, the jury is not out there regarding, and there in this slide I've tried to summarize the main findings and the gaps for future research. So if the mother's blood glucose is elevated an hour or about 1.5 to 2 hours before breastfeeding, then the breast milk glucose and fructose are increased, but there is no excessive weight gain at 6 months. There is increased breast milk leptin compared to a donor without diabetes. The gaps in the future research are the length and adiposity of the child, other breast milk bioactive components, and decrease disease risks at adulthood. So these are the key clinical implications. I have spoken about the epigenetic alterations, gut microbiota disruption, and the neurobehavioral impact as well. GDM poses significant not only short but long-term risks to both the mother and the offspring. Early screening and proactive management is warranted. timely intervention, preventable, manageable, maternal health optimization, again, before, during pregnancy is crucial, and lifelong offspring health optimization is essential. Thank you. Thank you very much.
Very lucid, crisp, and excellent talk, respected madam.
Thank you.
Ma'am, I had a query. Is there any role of pre or probiotics to manage hyperglycemia during pregnancy?
Specific role of pre and probiotics? No.
No. Not known.
No.
Right. Thank you.
I think any questions from the audience? Because Madam has finished her talk before time, so we can definitely ask one or two questions.
I thought somebody
if there-
would save time.
I think that's great. Very few flights will come before time, so you are one of them.
Thank you. Thank you.
Okay, then. Thank you very much, ma'am.
Thank you so much, ma'am. Now I request our chairpersons to felicitate our speaker. Moving on to next flight, flight number 60. I call upon Dr. Akash Yohare, sir, Director, Lifeline Madhumi Diabetes Hospital, Raipur, and Dr. Sunita Jyoti Dev, ma'am, from Trivandrum. Dr. Banshi Sabu, sir, to deliver a talk on how can we improve the lifespan of type 1 in India.
Good evening. Dr. Banshi Sabu doesn't require any introduction. We all know about him. And since we are running late, I invite Dr. Banshi Sabu for the enlightening talk on type 1 diabetes in India, how to improve the lifespan.
Thank you.
Over to you, Doctor.
Thank you, Sunil. Thank you, Kavita, and thank you for giving this wonderful opportunity. As we were just discussing before some time, nowadays, a doctor is sending his CV and mostly it is asked that, doctor does not need any introduction. And that's the reason I've never been introduced to any society. Thank you. What I am going to talk in next 15 minutes, the improving life expectancy of type 1 diabetes, particularly in India. It's really difficult, but I will try what I understood in last couple of decades. Why this matter? Type 1 diabetes is still shortening the lives of the people with type 1 diabetes. It remains associated with premature mortality, and this is fact. I mean, you will not find in your many of the social gatherings someone who is having type 1 diabetes and telling that I am having type 1 diabetes since last 50 years. Actually speaking, in 2002, on World Diabetes Day, I have put an advertisement in a newspaper that if someone is having type 1 diabetes since last more than 50 years, having and taking care of himself or herself, we would like to felicitate from Indian Medical Association as a person from a Diacare, but we could not get one person. At that time, the city of Ahmedabad was having a population of around 4 million. So for 40 years or 50 years, if someone is still surviving in our country, that was the situation in 2002. There is a lot of gap between India and high-income countries. But we know that in high-income countries, there is a difference. And that difference I have seen personally when I was there in a steno clinic. It was to my surprise, there was a geriatric type 1 clinic. So I mean, when I was there in 2000, I was surprised to see that someone can have a type 1 diabetes clinic. That's also a geriatric type 1 clinic. And then I was there in Colorado and multiple other places where they are dedicated only for type 1 diabetes. And we have seen the people who are surviving even for 70, 80 or even more than that. But whenever we talk about type 1 diabetes, we can't forget this child who was the first one to receive insulin in 1923, and we can't forget these two great scientists who got Nobel Prize for discovering insulin along with MacLeod and Kolb too. The global type 1 diabetes landscape actually changed from 2021 onward, because that time IDF, International Diabetic Federation, in its atlas, they had put the data that actually India is having highest number of type 1 diabetes below the age of 19, and that data has changed. We were just thinking that we are having only type 2 diabetes problem, but that's not true. And rather, every year we get 24,000 people who are added in the list. But if you see the top 10 countries, it's not that Asian countries don't have the type 1 diabetes. We have China, you can see Saudi Arabia, you can see the Kuwait, you can see many other countries who are in top 10 countries who have type 1 diabetes. May not be have higher incidence of type 1 diabetes, but because a large size of country with lot of population, we have type 1 diabetes. At present, we have all over world around 9.5 million people who are living with type 1 diabetes globally, but 1.8 million people are having below the age of 20. Now, this is very important, that adult type 1 is also equally and more important. Type 1 does not mean it's a pediatric diabetes. I strongly tell you, it's not meaning that only pediatric endocrinologists and they start thinking that diabetes or a type 1 diabetes mean it is only pediatric endocrinologists. They know diabetes. It's adult disease. And recently, constantly we were talking to the SPAD. Actually, you know that SPAD was originally divided from IDF, because in IDF they were not talking more about adult diabetes or more about type 2 diabetes. So SPAD was formed, and now we have written a combined paper with IDF and SPAD, and in that we have written very clear cut that more than 50% who are developing type 1 diabetes in your country are actually in adult age. So in India, if 24,000 people who are below the age of 19 who are developing type 1 diabetes in my country, India, almost similar number are diagnosed with type 1 diabetes in adult age. We have more issues with type 1 diabetes with children, but definitely more issues are with adults, because they are actually misdiagnosed. They have more, a sort of a feeling that they don't want to go and tell anyone that I have a type 1 diabetes. We all run the foundation and we just try to involve or invite the people and children only, but we have a lot of adult type 1 diabetes too. This is the global landscape 2025. If you see the latest IDF data, you will find that in India we have around 300,000 plus children below the age of 19 who are having type 1 diabetes. Now, what is the life expectancy? Sunil had asked very clear-cut question that how to increase the life expectancy of a person with type 1 diabetes. And that's a very important question which he asked. But this is what the type 1 index data. A child who is diagnosed at the age of 10, he can have his normal life only up to the age of 28. This is what the average good quality of life in India is, around 18 years if someone is developing type 1 diabetes below the age of 10. It means average, it means some of them will develop complication maybe after 15 or 12, and some of them may be developing in the complication after 25 years of their type 1 diabetes, and this is the situation. And 60 years in best performing countries. And this data, when I have taken, it is in 2021. At that time, AID was not introduced in the world. Automated insulin delivery system was not there. And even in the Western world, who were using insulin pump, which was 670, not the 780 or 680, or some of them were only on insulin pump or only on continuous glucose monitoring, their average life who were developing diabetes below the age of 10 will have life of up to 60 or 70 of 60 years of the age after that, and they will not have still normal life. But probably after AID, I can say they will have as normal as someone having diabetes in their early age group. And it is much, much lower in a resource limited setting. So I mean, countries like Sudan, someone who is given just once in a day a premix insulin or just a once in a day basal insulin, probably they may also survive for another 10-12 years, because first 5 years of a type 1 diabetes may not develop microvascular complication, and another 5 to 10 years they may develop complication. Managing type 1 diabetes is really difficult. I mean, one side they are keep on getting hypoglycemia if you just want a more tighter glycemic control, and other side we are always having a higher risk of developing complication. Why people with type 1 diabetes die early? And that's a very important question. I mean, that's what we want to understand, that how we can increase the expectancy of life. Delayed diagnosis, still this is situation. In primary care level, they may not diagnose even. They may have with diabetes ketoacidosis. I always tell that if someone knows diabetes and is still under your care, if you are having someone who is having type 1 diabetes and having diabetic ketoacidosis and could not treat and someone dies, it's like a literally crime. I mean, you don't know diabetic ketoacidosis. The managing diabetes ketoacidosis since last 40 years has not been much changed. It's still IV fluid, it's still low dose insulin infusion continuously, it's still continuously not to give bicarbonate, not to give bolus dose. All things remain same in last 40 years. So nothing has been changed. So don't make sure, make sure that if someone develops diabetes, ketoacidosis and goes to diabetologist, he should not die. He should not have developing brain edema. They die because of severe hypo sometime, kidney disease, CV and lack of insulin excess. And if someone type 1 diabetes who says that he is dying because of cardiovascular disease, I will be rather happy, because to have a cardiovascular disease, he has to survive for another 30 years to have cardiovascular disease, and that's also very, very important for that. Delayed diagnosis is a challenge. We have also challenge number 2, which is a challenge more for many other developing countries. I will not put this challenge for my country because we have insulin affordable, it is available and it is accessible to most part of the countries, even including rural part of our country too. But still, it may be a challenge, but there are countries who are not manufactured for insulin. And you think of like Lebanon. I was just, our vice president of IDF, she is coming from Lebanon. She was saying that insulin in Lebanon is costing, that same glargine which is costing in India $4 is $40. It is $40 in Lebanon. So think of the price which is there in India, $4, and it is costing $40 in countries like Lebanon where the war is going on. So there are the countries where supply interruption because of either natural calamities or because of war-like situation, and then children will keep on dying because they don't get the access for that. The challenge for glucose monitoring also. Nobody wants to monitor their sugar more intensively. If you are not monitoring, you will not take the action. So it's not just once or twice. It requires 5 times, 6 times, 8 times the sugar, and at the same time, they have to take the bolus also. And that's what the requirement is. So many patients are infrequently checking their sugar. And that's an important reason for them to develop complication too. And most complication arise because of some hospitalization, either sick day or hypoglycemia or diabetes ketoacidosis. I have written again very clearly, it is mismanagement. There is a psychosocial burden, and that's very, very important thing to understand. It's really difficult. I know that Dr. Rishi Shukla had worked in last 30 years for the psychosocial burden. He was talking about the marriage issue for these type 1. Dr. Ramchandani, G.D. Ramchandani is working on those psychosocial issues which are very important, inviting all those hundreds of the kids and giving them a social support, giving them a psychological support, giving them a insulin is not a great thing. Giving them a psychosocial support is very, very important, because many of them have a depression. Their family requires a lot of supports, and these children are sometime in a transition phase, because up to the age of 18 and 21, we are supported by Life for Child, we are supported by CDIC and many of the national organizations, and now government also started giving to the children below the age of 18 or 19 free insulin, but probably when they become adult, they may not get. So there are a lot of issues for that. We all know DCCT, and I think this is proved beyond doubt. We all know that tighter the glycemic control, better is the outcome for that. We are debating since last 40 years for type 2 diabetes management, how to do it, whether to give sulfonylurea or whether to give now GLP-1. It has got the CV safety data or it does not have. But for type 1, we never had any doubt. They all have to be given insulin, try to achieve tighter glycemic control and no hypoglycemia. In DCCT, we know that as you try to control this, HbA1c less than 7, the risk of hypoglycemia is so high. So it becomes a very important limiting factor for a tighter glycemic control with person with type 1 diabetes. So beyond A1C, we have to think. We just can't chase only A1C. HbA1c alone, and if you just try to achieve less than 7, you are developing more hypoglycemia. So this is what the time in range. And time in range for a type 1 diabetes also, on a continuous glucose monitoring, if someone is there, more than 70% time in range someone should be there. It means 70 to 180 milligram of the sugar in throughout the day of 24 hours, 70% of the time they should be in this range, and that is for all other type 2 diabetes also. But if type 1 diabetes, and preferably they all should be on continuous glucose monitoring, and they should be achieving time in range of more than 70. But does utility of CGM will reduce the risk of hypoglycemia? Yes. From those 62 per 100 years was there in DCCT trial. After 25 years, the similar type of patients put on continuous glucose monitoring, and you can see the risk of hypoglycemia is significantly reduced from 83 to 2008. It was 62 and somewhere around 20%. So CGM will definitely reduce the risk of hypoglycemia. But will it able to achieve HbA1c of less than 7? No. Because some of the countries started giving continuous glucose monitoring to all their children, all those who are below the age of 19. It had become a standard of care. Now they may not be dependent only on random blood glucose monitoring from self-monitoring of blood glucose, and they all were given, and these are the countries who are using it, but still they are not achieving time in range more than 70% in less than 30% of the patient. And that's how the insulin pump is introduced. Insulin pump is not new. It is in 1960. The first insulin infusion pump was introduced. So it means you can understand it was before 65 years, first insulin pump was there. Even in DCCT trial, they had used insulin pump too. Insulin pump at that point of time was for convenience. Just give insulin pump through pen instead of they were giving insulin pump. But what's the purpose of giving insulin? We have to pump insulin in such a way that it gives basal and it gives bolus as physiological as it is being produced in our body. So pumps are designed for one thing, it can be given for multiple basal rate, and that's the beauty of the pump, insulin pump. But now newer pump which are used for type 2 diabetes, they will not have multiple basal rates, but this is what multiple times you can change the basal rates of that, and you can use the pump also for multiple time bolus also. So the pump is designed in such a way that you can use for multiple basal rates as well as multiple times you can use the bolus. But still it is not automated insulin delivery. The all insulin pump which were older one, they were used to give the multiple basal rates or giving them multiple bolus. They were also put with along with sensor augmented pump. Then there was the overnight closed loop system came. Then hybrid closed loop system came. And now we are lucky that we have in India and in Southeast Asia, probably only country in India, we have advanced hybrid closed loop system. And that is what we are having 780G. Why it should be used? Because if you are using any variety of monitoring or any type of insulin therapy, still you will not able to achieve time in range. I mean, you may have your patients who are either on older insulin pump or with the continuous glucose monitoring, which we may consider they are on best therapy. There are people who are on multiple daily insulin injection, most of the patient along with BGM or CGM. But unless you put them on an advanced hybrid closed loop system or hybrid closed loop system, this is not available in our country. Advanced hybrid closed loop system had shown them they are achieving time in range more than 70% of the time without hypoglycemia. And this is what the utility of CSI. We have the data which was published in 2016, and this was published with the hybrid closed loop system, not with advanced, and to show that actually they are developing 0% hypoglycemia. No hypoglycemia was there in these patients. Do we have the data that continuous subcutaneous insulin infusion pump will have significant reduction in A1C without increasing the risk of hypoglycemia? We have ADAPT study and we have multiple such papers. I am not going in detail, just to tell about some papers are there scientifically, because in any meetings we have to show that yes, it has got a data to show that it can decrease significantly risk of hypoglycemia, still achieving tighter glycemic control, achieving HbA1c less and achieving more than time in range, which is more than 70% of the time. The best part is these automated insulin delivery system, they have auto correction, and this auto correction is the total dose of the patient who was taking insulin on AID or they were taking on their basal bolus therapy, it was same. But what it has been done here, there is some auto basal which was fixed as per the AI, and with the user initiated bolus which we had explained the patient, but in between you can see the 20% of the extra insulin which was we were giving otherwise, through that it was given in auto corrected dose and patient was not developing any hypoglycemia. We were having our own data from India, some 219 patients initial insulin pump patients we just collected data from all across the country, and just to show internationally that we are also having equivalent time in range those patients who are put on a advanced insulin delivery system. These were the Indian children below the age of 15, which was published in a ATTD. Let me show a case who was on a 20 units of glargine and aspart of 686. Now here you will be surprised this patient is having HbA1c of 11.8. Then everybody will say that what you are doing with a person with 11.8 A1c with a patient who are on glargine and aspart. What we used to do, I am sure everybody will say that with 11.8 we have to increase the dose of basal, we have to increase the dose of bolus. See the continuous glucose monitoring. You will be surprised the same patient to whom we are put on 20 units of glargine. One other day, he is developing mid of the night, sugar goes up to 70. Patient is not ready to increase even 1 unit of glargine because in between last 14 days, he had gone in hypoglycemia. And these are the patients who are other day are developing the sugar level up to 400. So these are the situation which they keep on having. Manoj had given this case, I think, in one of the his presentation, or I don't know, but this is what the situation in many of our clinical situation. Sometimes patient HbA1c is around 10 or 10.5, and if you do the continuous glucose monitoring, you just can't increase the dose of blindly these glargine or the regular acting insulin because they are actually developing a lot of hypo and hyperglycemia. And once you put these patients on AID, you can see that they're continuously superb, the time in range, and most of the time the sugar is remaining between and no hypoglycemia. That's most important thing. There is no hypoglycemia. And on that, we have written a paper. It's a call to action. And this call to action written from a developing countries, not having a lot of patients on insulin pump. Still, we have written call to action and where we got all those endorsement who were part of international guidelines for CGM, part of time in range. They were endorsing all the association including SPAD and ESPE and ADA and ATTD and everyone. And that what we wanted that all people with type 1 diabetes and other insulin deficient diabetes must be given a choice to use AID system. And this is a very important word which we had used, must be given a choice. I mean, it's really difficult. One thing we are thinking for our patient, they are very poor, they can't afford even CGM, they can't afford for insulin. Should we give them a choice? I mean, that's really a difficult situation for many of us, but still I feel that at least they should be given a choice. If not, must should be given, if you don't want to use the word must. And tell them that something like AID which is available. And I had used in my patient almost everyone, and some of my patients, they look very poor. You feel that you will have to give some insulin also from some foundation, but ultimately they got the insulin pump also. If you just explain that this is what the insulin pump is going to change the life of a child or a person with type 1 diabetes throughout his lifetime. 1,500 patients initially, some top 10 prescriber. 2 of them are right here in front of me, Manoj and Jyoti is here, and many more from India who were part of the first top 1,500 insulin pump when it was put in India. Now we have more than around 5,000 AID system in India, and the older pump are still there, which are another 5,000. But still it is very less. You know, I told you in India we have around 1 million type 1 diabetes patient. Now what more we can do? Early detection. This is very easy. This is one project which we have done with IDF and Diabetes India in 2013. And that time just we have written to all schools and just detect. Early detection, this can be done by RSSDI. Early detection just in a school education program. Those who are losing weight fast, the school teacher can detect them. Early detection can be a good choice because unless if they develop decay and delayed diagnosis may lead to death also. The kidney protection and CV risk protection like any other type 1 diabetes or any type 2 diabetes patient also that we have to do it. For all type 1 diabetes more than 5, we are forgetting the vaccination strategy. Make sure they are given. Again, the cost is a challenge. Digital health and automated AI, artificial intelligence can help for future tools or distantly you can take care of these patients. What India should do? Universal insulin security. And probably I can see that in another 2 years or 3 years, India will have this universal insulin security for all children. Maybe most of the state government now becoming proactive, and maybe in 1 or 2 years you will find a lot of this. The goal is zero death due to insulin unavailability. So there should not be, at least after 3-4 years, one child should not go to a senior person and ask that, because of insulin unavailability, I could not get it and they are dying. School diabetes program, one of the biggest program of International Diabetic Federation, running since last 15 years. Kids, it's knowing diabetes in school. It is not only for type 1 diabetes, it's also early type 2 diabetes. It is for pediatric obesity, it is for nutrition, every aspect. Sanofi is supporting it. I again request all young doctors across the country to take the part of in kids program. You can download complete curriculum of kids program and you can go to your school and you can write to us also for support too. National Type 1 Diabetes Registry, we are thinking since long. Now probably RSSDI is thinking of it very seriously for making type 1 diabetes registry. Workforce development, we require more diabetic educators, more pediatric diabetologists. I will say not pediatric or not adult. I mean someone who have more interest in type 1 diabetes. It's not for pediatric diabetologist or someone who is adult endocrinologist and he thinks that only he knows. Rather, I had gone to some of the, premier institute of our country where they are taking care of type 1 diabetes. And we were there in one of the premium institute with some of the senior person, and I told very openly, because these senior consultant who passed MD from somewhere, today they are doing their senior residency and they are still writing the premix insulin in the same institute doing DM endocrinology. And when they will pass out, they will come out outside, they will still keep on prescribing the same prescription because they used to write in the same institute. And when in the same institute, if they get some one adrenal mass, they will have for 3 days a grand round, but not having anything new which they are going to use. I mean, neither a new technology, nor they are going to teach that how a type 1 diabetes should be treated in these premium institute. And that's the reason that whatever we are seeing, even the senior endocrinologists which we are seeing, their prescriptions are not up to the mark to have. And that's the reason we are not having many adult type 1 diabetes who have type 1 since last 30-40 years and is still surviving. So one of the way by which we can say that their life can be improved, they can survive more, I think the basic education, not at the level of MBBS, I think at MD and definitely at DM level is to be improved. Definitely at the level of DM, because then they have to write down themselves that they are endocrinologists. People may come to them that saying that you are endocrinologist, you must be the best person to write a prescription for them. So they should be taught maximum, and that's the only way by which we can improve the quality of life and we can increase their life. Also, if India scales, it is universal insulin access, national registry, CGM to reimburse, structure education, technology, all to be done. Earlier diagnosis, no child with type 1 diabetes in India should lose years of life because of where they were born. I mean, this is really shameful for India, which is the fastest developing countries. We are 4th largest economy. We have Germany, Japan and UK is behind us. We are 3rd or 4th largest economy, and still type 1 children in India are dying, and that's really shameful for us. But we as a doctor, we can't do some of the things. Nothing. We have to say that patient that 4 injections in a day, probably we can't decrease the number of injection for that child unless you put them on AID. Our role is again as a professional, as to give them a continuous education throughout the lifetime. But the person with type 1 diabetes is a player. He is the player. You are only to guide them. And the blood glucose monitoring and multiple factors. It's not just diet, exercise, hormonal changes. There are some 49 factors which can increase and decrease the sugar. I had shown you CGM of type 1 diabetes. Middle of the night, one day 70, other day 300. What he is doing, any lifestyle change in middle of the night at 12 o'clock? No change was there. Still the sugar is fluctuating so high. So that is what we are going to have. Unless you put them on something like AID, they are not going to have a time in range more than 70%. What we need to have more equity basis rather than equality for everyone to give, but they need more education. They need, maybe a poor person may need more education and more technology rather than a poor person because he can't afford, we can't give. That should not be there. So to bridge the gap, we have to these disparities to be also to be reduced in the people with type 1 diabetes. And I thank again, once again, Sunil for giving this opportunity, putting type 1 diabetes in a, like already he has given Rishi Shukla had given a oration for this type 1 diabetes. So type 1 diabetes for our diabetes meeting had become very, very important part of it. Since last 15 years, we are working very hard that each and every diabetes meeting is incomplete without we talk for type 1 diabetes. And I thank all those organizations who are working for type 1 diabetes and helping India, and particularly to me like CDIC, SPAD, RSSDI, type 1 diabetes insulin project which we have started, Life for Child, Diabetes India, or other organizations who are helping us. We are thankful to them and thanking all those children and their caregiver for this. They helped me to grow in field of type 1 diabetes. Thank you very much for this.
Thank you, Dr. Bansi Sabu, for that insightful and thought-provoking presentation. And when it comes to type 1 diabetes, you speak not only with experience and knowledge, but also with the genuine interest. And you are talking from bottom of your heart with
Thank you.
Passion and compassion.
Thank you, sir.
It is really appreciable that you are into so many projects for taking care of children with type 1 diabetes in India. And any discussion? Is there a discussion for this lecture?
Yes, sir.
It has been one of the complete shock, and I wish it would have been given earlier in the day. Every aspect you have touched, but nowadays we do meetings in the ministry after Prime Minister has taken charge. We have only actionables. I was thinking how many actionables, counting the blessings, I counted the actionables. There are about 20 actionables which must be done. I just tell two because people are, for the international talks will start. You rightly said that the diagnosis of type 1 diabetes never be missed. That Premier Institute, where an unconscious patient was not diagnosed. We'll never miss a diabetes in a student thing. Second thing you said, the insulin is a birthright, but how to make it? I think we must have every state must have a champion like you who will inspire and try to take, or like Sujay. I mean, we'll take it forward in that way. Third thing, which is very important, is that absolutely important is the fact that the child, three things which kills the child. One is hyperglycemia, decay. Now it is said the care in a Premier Institute is judged by the decay care. If a decay patient dies today, Bansi, the Premier Institute will be finished. That's the ministry's call. I'll repeat again, any Premier Institute is judged by the decay care they give. If a good residency care is there, no decay patient should die.
Should not die, not by any chance.
Second thing, they die of hypoglycemia. And you beautifully shown by CGM, which is a birthright, how hypoglycemia can be saved. And you also talked about heart, which is the fourth cause of death. That can be taken care of. But Bansi, there's other in our country, the type 1 diabetes die also of infection. I think that also has to be taken.
We have written that vaccination and all those things should be taken care of.
So I think it's a complete talk, many actionables. I hope Sunil will print it and will take it forward. Thank you very much. Give a big, I think a standing ovation for Bansi for the beautiful talk he has given. It's a complete talk, absolutely complete.
Thank you, sir.
Bansi sir, can't we make a national toll-free number for registry? Rather, patient should come direct contact to us whether we are searching for the patient. That will give us exact feedback. Anybody can register, and there should be one app in the phone which can be flourished everywhere.
So RSSDI is working very hard with Koita Center already. Dr. Manoj and Dr. Rakesh, and they all are working very hard. And we are also the part of that advisory group, that National Type 1 Diabetes Registry. Now different state government also started working. As I told you that Gujarat government now dedicated type 1 clinic. Kolkata already, all district is already covered in West Bengal. Rajasthan had already started with few centers. And I'm sure in another 5 years, it will be across country. I mean, The first state which was started in Kerala long back, Jyoti Dev had worked and they started giving even free insulin pump also. And then in between it was stopped. Now current chief minister and current health minister is very close friend of Dr. Jyoti Dev, and I am sure that it will be the first state not only to take care of all type 1 children, giving them basic, but even for advanced care, that may be the first state. And even first one state starts giving them advanced care. First, I am very sure that in another 3, 4 year, 5 year, at least comprehensive care will be covered across country, because now National Health Minister and it had come RBSK, you must have heard, the Rashtriya Bal Vikas, also the second phase they have introduced also. So across country, all state health government is going to take, but some of the state government may take proactive action for even giving them insulin pump. So in that state government, they are going to have the full Pakka registry. The problem will come for adult type 1. I still have the problem with type 1 in children is still taken care better way, because everyone have, a sympathy, everyone wants to treat. Adult type 1, they can't go anywhere, they can't get the free insulin, they have to work hard and they die. They develop more complication than type 1. So as a RSSDI, we should not just concentrate only on pediatric diabetes project, we should work on a type 1 project, which includes anyone, whether it's an adult or type 1. In my clinic, anyone type 1, any poor patient, we should help him. It's not that why only the children, why can't we do help to adult also? Yes, sir.
You stole the heart.
Oh, sir, thank you.
And second thing, I think I was motivated that we all must embrace technology very intensively. Otherwise, we'll not be able to achieve to what you said. And last thing is a complaint to you. मेरी इंस्टीट्यूट की बेइज्जती करा दी तुमने.
ऐसा नहीं, मैंने बोला नहीं, नाम नहीं लिया. मैंने नाम नहीं लिया, लेकिन मैंने आपके साथ ही बोला था. We were both together and in that same institute. And my point is, Sunil had asked me very important question that how to increase the life expectancy of type 1 in India. And one of the way is educating those who are responsible for taking care. So if they are not educated properly, because their prescription is replicated, you know that.
Now that in good work, we passed it out to Sanjay and they have a separate team.
We have told already, Sanjay, on that day openly I told.
I was there.
Because Sanjay articulated, we changed over from
So we are running out of time.
I understand that, this is...
now changed over to the basal bolus.
Thank you, sir.
So, I mean, you know that CDIC has totally changed.
For the interest of time,
Yes, thank you so much.
I must tell you, Sunil, your talk, you gave it to Bansi Bhai, has the actionables which will change the destiny of the country and trajectory of type 1 diabetes.
Thank you so much, Dr. Bansi Sabu.
Sir, I just want to tell, it will change under the leadership of Sunil when he will be taking care of the president also. Because till that, we are going to have type 1 registry. T20 registry is already under RSSDI process. So Anuj had started, Rakesh has started, but it will be launched under Sunil when he will be taking over the president.
He's the president now. He's the presiding officer.
No, president elect.
Thank you very much for the session.
So,
we are running short of time.
I promise this group of intellectuals here, in my best of my capacity, we'll be going ahead. Not only to sir, there are many people and few of them can record if you want. Me and Rakesh, come here. We both promise, along with our all EC members, to every one of you, that we'll do our best with best capacity. Thank you. आ जाओ प्रताप भाई, आप भी आ जाओ. आप चालू करो जब तक दूसरों को बुलाना. तो आपको एक president elect, secretary or treasurer, इससे ज्यादा तो कुछ नहीं चाहिए ना.
This year type 1 diabetes SPAD meeting is in Brazil, but definitely your this commitment which you are doing, you should do at IDF at national meeting in month of April too.
Yes,
that
yes.
India had changed for that.
We'll
Thank you.
do that, sir. Thank you.
Moving ahead to our next session, I invite Dr. Manoj Chawla sir and Dr. Jyoti Dev sir to chair the session, and Dr. Jayesh Timani sir from Nagpur.
Okay, so we move ahead with the next session, a very interesting topic on smart clinic, not hard clinic, tech that saves time and grows practice. And let me invite Dr. Bharat Sabu,
on stage to take the next talk. Bharat has many laurels to his name, amongst them the Amazon best-selling author, director for Prayas Diabetes Center at Indore, and co-founder of Doc Yantra Private Limited. Bharat has been doing some amazing work in the field of AI technology, outreach programs, and recently delivered a wonderful oral presentation and had papers at ADA at New Orleans. So with great pleasure, let's welcome Dr. Bharat Sabu.
Thank you, Manoj sir. Thank you. First of all, thank you, Sunil sir and Kavita ma'am for inviting me here. And thank you, Kavita ma'am, for giving me this talk here. Actually, she heard this talk somewhere else and she asked me to talk on this topic only in Hello Diabetes Academia. It is really tough to talk after Bansi sir because Bansi bhai takes away all the juice which is there in the hall, and it is really very difficult for me to talk now. But I will try to do justice to what has been given to me. The job which has been assigned to me is to talk about smart clinic, not the hard clinic, and to talk about tech that saves time and grows practice. So I will just use 5 use cases and 5 principles as a take home. Now, at the end of this talk, we will like to see everyone become an intelligent diabetologist. Now, the biggest question is AI is here, and question is how, because patient, they already put whatever you give to them into ChatGPT and ask whether this doctor is right or wrong. Again, pharma and insurance, they use AI for drug discovery and your prescription analysis. Other specialties are adapting to AI much faster because we think we are only adopting, they are adopting to it much faster than endocrinology and diabetes. Now there are 2 choices. Either we should ignore AI or we should use AI blindly. So these are the 2 choices in front of us. But the best choice is the third one, to use AI intelligently. How? We will see. Because AI is not the revolution, intelligent clinical integration is. We should not be solely relying on AI, but to integrate it intelligently into our day-to-day practice. There is a data tsunami, 288 readings per day is for blood sugar values. And this matrix is non-comprehensible by human brain with so much of thing around in your day-to-day OPD. Again, diabetes care has evolved. We know from SMBG to AI co-pilots now which are there with our CGM devices. So this has taken a drastic change and a change which is evident. Now there is a continuous paradigm because the practice which was previously episodic, patient used to come to us in 2 months, 3 months, sometimes in 6 months. So that was an episodic care. Now the patient demands a continuous care, 24/7 visibility, which enables proactive predictive care. And it requires a fundamental shift from data checking to pattern solving. So we need to change also. Now again, we have a paradox with us. We have too little time. We don't have time out of our busy schedule to look into all the nuances of day-to-day clinic, data, pointers, other things. And there is too much noise also because distinguishing from actionable clinical signals from irrelevant physiological things becomes very, very difficult. Now, to define the lexicon, we all know what artificial intelligence is. It is a broad concept of machines. They mimic human cognitive behavior like learning and problem solving. It runs on machine learning, we all know. And there are large language models, which are the talk of town these days, on which it runs. This is as brief as it can be. Now, it should be assistant. AI should reduce clinical noise, but it should not increase the digital chaos. This is my pointer. So the system computes the probabilities, but the diabetologists remain the moral and clinical North Star. You should be the authoritative person in the whole ecosystem. 4 levels of clinical AI are there. First is descriptive. It can tell you what has happened. Second is predictive. It can tell you what may happen or what can happen. Third is prescriptive, what to consider. It can act as a prescriber also. And fourth is adaptive, where safe automation is there and autonomous action is there. So these are 4 levels of AI. Let us dig down further. Now the descriptive AI, it creates automated summaries. So it saves clinician 2 to 3 minutes per patient per digesting retrospective data before the clinical encounter begins. So you feed in the data to AI, it does a summary and it does it beautifully well. Again, predictive, it moves care from reactive to proactive, where hypoglycemia forecasting is done, dawn phenomena is checked, risk engines are employed and deployed, and then we see the risk which is coming in future to the patient, and that is how predictive AI works. Now coming forward to prescriptive, Prescriptive is for titration support. We have seen many apps which are doing titration support for insulin dosing. Portal responses, which are LLM drafting personalized empathic replies, just like the chatbot which is there. When we go to ICICI, Lombard or any other website, it is first AI which responds. The human comes later. So this is of that sort. And then there are behavioral nudges which are there, suggesting specific lifestyle interventions based on personalized glycemic responses. Again, it reduces the clinical inertia and administrative burden from the caregiver by providing actionable draft. So the draft is important. It is not giving the prescription, it is giving you a draft which after your review becomes a prescription. Now again, adaptive, which does micro adjustment, which are executed continuously without human intervention. So you are not in the loop. This is the fourth level. And this is the most dreadful level. We need to be very cautious about it. So the closed loop system, they are validated. It is fine to go. Nothing from our end is required and it works wonderfully well. The hard guardrails are system boundaries which are defined purely by evidence-based clinical wisdom. And that is what makes these closed loop systems a marvel. Again, the continuous learning curve is there. It runs by algorithms. It again updates itself for patient. And that is why the closed loop system works wonderfully well after some point of time in our patients. Those who have experienced the 780G know it because it works wonderfully well after a month or two and you are nowhere required. Now, where the doctors go wrong, because there is so much AI around, the hidden pitfalls of integrating AI into clinical practice, we will first take this. We become automation complacent. What is this? We blindly trust the algorithmic output. And many times I have seen doctor doing this. Leads to reduced vigilance and failure to notice the clinical errors. The clinical errors AI make are often ignored. So we skip the manual review of the raw AGP trace. Suppose we upload the AGP. Whatever it has given, we consider it right. No, you need to be vigilant. You should be the center. You should be the North Star. Again, insight overload. While AI generates 50 highly accurate, fascinating, but clinically non-actionable insights per patient, the clinician simply stops reading that because it gives so much of data, you stop reading it. So the solution is AI should be programmed only to surface top 3 actionable interventions. So top 3 actionable interventions you will be focusing more upon. Then entropy of intuition. This is a term called as calculator effect. Remember, we used to do maths on our own. So our mathematical ability is much better than our kids. Yeah. So this is actually the calculator effect. So the training program must force manual interpretation. Otherwise, a resident who is putting all the ECG into a AI LLM will never learn how to read a ECG. This is the computer effect. Now, the rubber stamp. This is again a term where clinicians rapidly approve the AI generated notes without looking at it. They just put the rubber stamp, tuck, 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 tuck. They don't review it. And this is the biggest pitfall, I tell you. Because all the medical legal liability lies with you as a clinician, not with the AI. No one is going to sue the AI. Now, what are the danger zones? Hallucination is one danger zone. Bias is second. And overconfidence is third, because the AI mistaking a harmless correlation for a dangerous clinical causation. A wrong AI answers delivered with absolute linguistic confidence, because LLM are very good linguistically, is the most dangerous artifact in modern medicine. So be wary of that. Never trust a LLM unless you are sure of yourself. Now 5 use cases. It will save 5 to 10 hours per week. It will improve documentation. It will enhance patient education, stay current on evidence, and all while keeping my clinical judgment as the final authority, not the AI. Now, again, the problem is after 30-40 patients per day, discharge summaries, insurance pre-authorization letter, they take 20 minutes each. So the time sink is 2 to 3 hours per day. What to do? Voice note, feed to AI, AI draft, review, and sign. This is very simple. It can be done verbally also. This is very easy. What it will do, it will save your time. But the caveat is AI draft, I decide, not letting AI to complete it. I will review it, I will finalize it, and then I will sign it. Now the guardrails are, we should check for factual accuracy, medication and doses, clinical nuances, and medico-legal completeness. So this is very important. Staying current with evidence. This is a problem with heavy OPD. So Monday morning, 15 minutes evidence review. You need to write this prompt, paste 5 to 10 PubMed abstract from the past 2 weeks and ask AI, what changed in practice first? Second, practice changing or confirmatory. Third, what is the NNT or the effect size? And fourth, because we are living in India, any Indian population applicability concern. If it is concerning, don't use it. So AI delivers all these things. It saves 2 hours of literature review and you are becoming more intelligent. So this is a simple example of time restricted eating query, and AI can sometimes fabricate DOI, so be very cautious while checking the references again and again. Patient education. It takes 15 minutes per patient ideally. I think no one does it. 2 hours education is needed for all the things. 70% is verbal counseling. At the end of the day, your jaw is paining like anything and you don't talk to your kids because you have talked enough in your OPD. So personalized education in 2 minutes, just give a prompt. I always do this, create a handout for this age patient. I just write what he wants to do, just copy paste from my history sheet, and AI generate customized handout, which I printed, and culturally appropriate language is there and appropriate technical level is there. So before AI, generic printouts were there, half irrelevant. Patient forget 70% of what I have said in after reaching out of OPD, and frequently anxious phone calls to remember what I said. After AI, personalized education, fewer calls, and better adherence. So AI scales the education, and I remain the medical authority. But it should be used only for education. Always include escalation, and I should review before sending. So I should be there. This is a perfect example of what I am saying. This is Mitra, which was awarded by ADA last year. We also presented the type 1 trial data this year also. And this actually solves most of the problem of patient education. Now DD assistant. Many times we are in a fix. What can be there? And a 28-year-old woman, DK, BMI 32, family history of type 2 diabetes, but GAD positive, C-peptide low, then AI can come to a help, not to rescue. Because it can tell you what can be there, what are the differentials, what additional tests are required, and what should be the treatment. And this is the way it should be. But the thing is, you need to use it to expand your thinking. You need to make your own diagnosis to generate comprehensive differential, suggest relevant test, and provide evidence-based workup approach. Do not accept the AI diagnosis without trusting your brain. Now again, research and academic writing, the fifth case. Clinicians are expected to publish, and that is why they are known for. So the traditional approach is PubMed research, reading abstract, 2 to 3 hour, organizing theme, outlining, drafting. Do the PubMed research manually, then AI synthesize 20 abstracts, write manuscript using AI scaffold, time saved is 4 to 5 hours. Do not let AI write the full manuscript. Do not trust AI citations. Use AI for literature organization and do citation yourself. Then it will help you. Just use it as an organizer. Now the 5 principles. First, augment, never replace. Let it augment your intelligence. Let it not replace your intelligence. You should trust but verify with your own guts. Define clear boundaries while prompting. Maintain expertise and prioritize patient safety. Just quickly. So first is augment, never replace. You should not replace yourself. The final medical decision is always mine. Second is, I won't stake my medical license on it. I will verify it. You need to trust but verify. Third, guardrail should be there. Education should be guardrailed. It should not give the treatment. Fourth, maintain expertise. Do not let AI atrophy your clinical skills, and prioritize patient safety always, because if something goes wrong, you are responsible, not AI. So from tomorrow, pick one of these use cases and start using in your day-to-day OPD. These are the free tools to start from today, and these are really free and very wonderful tools. So liability, if AI makes a mistake, you are liable. Patient privacy, you need to de-identify the patient data before putting into any LLM. And what if AI goes wrong? That is why the principle 2 is there. Verify citation, double check. AI is the starting point, never an end point. Will AI replace diabetologist? No. Diabetologists who use AI will replace those who don't. So these are the 5 principles at a glance. The bottom line is use it intelligently, ignore all the wrong things what it is doing, but use it to augment your intelligence. The best diabetologist 10 years from now won't be AI. It will be a diabetologist who intelligently uses AI. Thank you.
Thank you, Bharat. I'm aware that we are running extremely short of time, but there's any one single question or compelling comment, we invite that before I hand it back to the rapporteurs of the session. If not, Bharat will be around for anybody who wants to know more about AI and how to become more intelligent and survive as a diabetologist in this scenario.
Thank you.
Thank you. Thank you, Bharat, for taking us through that.
Thank you so much, sir. Now I request the chairpersons to felicitate the speaker. And I request Dr. Sunil Gupta, sir, to join.
Ravi Wagmare, sir. Yeah, please join. Dr. Ellen Bajaj, sir. Yeah, Dr. Ellen Bajaj, Dr. Puranik, and Dr. A.K. Das, sir. Sir, please chair the sessions.
My dear friends, it is a great honor and pleasure to introduce Professor Dr. Sundar Mudaliar in 2 words. Sundar is the son of the soil. He's from Chennai, trained in Stanley, in which I remember him very well, Sundar. But today, India born but international expert. His word is the last word in the field of the SGLT2 inhibitors and many other areas, the ketosis, absolutely fabulous. And he has been trained also in England and ultimately United States. He's currently a clinical professor of medicine at the University of California, San Diego, and a board certified endocrinologist. He is active in seeing patients and teaching, and research focus is on the clinical aspects of diabetes and treatment. Many ongoing landmark studies, including the NIH Diabetes Prevention Program, the outcome study from the prevention program, the NIH DCCT EDIC study, and the NIH GRAD GRADE study, and published more than 200 original papers in peer-reviewed journals. Dear friends, today Sundar is going to speak to us on a very important topic, that is the navigating GLP-1 therapy, pancreatitis, and navigating the incretin jungle from GLP-1 to GIP to glucagon, from single to incretin and tricretin, and beyond. So navigating the incretin jungle from GLP-1 to GLP plus GIP plus GLP, GIP plus glucagon and beyond. Sundar, all is yours.
Okay. Good evening, everybody, and thank you so much, Professor Das. We have known each other for more than 25 years, or even close to 40 years, if you remember.
Yes,
In
yes.
1983, you came to Stanley from Jutma. Can you all hear me, please, and see my
Yeah.
slides?
Yeah. Can the voice be a little better? Can you see the voice is slightly better?
Yeah.
Yeah.
Is the voice good now?
Yes, better now.
Okay, thank you. All right, so you very nicely described it, and I will try to navigate this jungle. There are so many molecules there. What they do, why they do it, we really don't know, and honestly, even I don't know today. So what I'm going to do is, all right. So in it first, I will describe the classic incretins, which everybody knows. GLP-1, GIP, we've known them for more than 40 years, and they have lots of effects, A1C, body weight, cardiorenal, muscle, sleep apnea. Then the jungle has expanded literally, and we have what I call the GLP-1 plus, because you need the GLP-1 at the heart of it. You have other dual agonists, tirzepatide is GLP, GIP, but we have a GLP-1 plus GIP antagonist. It doesn't make sense, but both the combinations work. We have GLP plus glucagon. We have the triple agonist, GLP, GIP, and that's retatrutide. Other gut-brain peptides, amylin, leptin, neuropeptide Y, and last but not the least, GLP-1 plus agents to minimize lean body mass loss. Let me remind you, GLP-1 is a very ancient hormone. How old? Well, it is expressed in teleost fish. Tilapia is a teleost fish. It goes back to the Jurassic period when dinosaurs were around. And this is an example of it. And this is Svetlana Modzov. She was at Harvard then. She's published some of the original papers on the GLP-1. And she talked about this, how it's present. The thing is, GLP-1 in mammals lowers blood glucose, but in fish it causes hyperglycemia. It's the exact opposite effect which evolved over a million years. And this fish, believe it or not, can get diabetes. And this paper has been published. The teleost fish, it's got a pancreas-like islet. And if you take it out, it gets diabetes. And you can give it hormonal treatment over there. So my interest in this goes back a long time, more than 15 years. With my mentor, Bob Henry, Diabetologia does a then and now series. And we wrote from scientific discovery to therapeutics. The then was what happened in 1986 when the first GIP paper in humans was described. We knew all about it, and the incretin effect was only glucose, glycemic. We didn't know about the weight. Then at that time, in 2012, 25 years later, we said there are a lot of other effects, including satiety, body weight regulation. So look at what happened in 25 years and look at what happened in the last 15 years since then. Today, GLP-1s established, and this I've adapted this from Dan Drucker. He's really an authority on this. We have the approved for type 1, type 2 diabetes, 0.8 to 2% approximately the different agents. Obesity in patients with diabetes up to 15% you can get. Without diabetes, only obesity, 22%. And this is the established ones. Cardiorenal protection, we all know. The FDA has approved liraglutide, Dula, semaglutide, ACE, glucose lowering, and MACE. Tirzepatide, as of today, does not have the indications for reducing cardiovascular disease in the US at least. Then, for people without diabetes, we have Wegovy at the higher dose, again, approved for the MACE cardiovascular disease reduction. And Zepbound, which is the obesity one, same doses. Monjaro is the diabetes one, but it does not have any MACE approval. Oral formulations as of today, only in type 2 diabetes. We have Rybelsus, different doses. Again, it's got type 2 diabetes and cardiovascular. Modest reductions, A1C, weight. And now, since May 2026, Novo has decided it's going to be called Ozempic. They didn't want too many names over there. And that is different dose, and because they have improved the molecule. And of course, orforglipron Foundayo is approved for diabetes. A1C loading is pretty robust, 1.8%, and weight is about 11% over there. We all know about the other effects on the kidney. Semaglutide actually is approved for reducing CKD progression. Tirzepatide doesn't have it yet. You're waiting for the Treasure CKD study. Heart failure, we know. Semaglutide and the STEP have best studies positive, but not yet approved for that. Tirzepatide, the Summit Heart have not yet approved for it. We know the FDA has approved tirzepatide for sleep apnea. And of course, semaglutide has been approved for MASLD or MASH. Other investigational, tirzepatide is still being studied. They're waiting for the results from the Synergy NASH study. Parkinson's disease, semaglutide is being studied. Alzheimer's, so far the results are not promising. These two studies, the EVOKE and the EVOKE Plus, were negative actually, but the other studies are going on. Peripheral arterial disease, liraglutide, semaglutide, not approved yet, but positive. They're all the vessels, whether it's in the heart, in the brain, and anywhere else. Semaglutide in alcohol use disorder, and an initial publication in JAMA showed that those consuming alcohol in a laboratory session following 8 weeks of treatment, they drank less. The bigger studies are all going on, and we are participating in one of those big studies with semaglutide. Now the question is, why is it that if you take GIP and add it to GLP, you get more glucose lowering, more weight loss? Well, as you all know, tirzepatide actually was a bioengineered drug almost. The base of the molecule is GIP, and then they put GLP on top of it. It is imbalanced and biased. What does that mean? It's imbalanced in that it has more affinity for GIP receptor, less affinity for GLP. It is biased because once the molecule binds to the receptor, it can go through two pathways, the cyclic AMP pathway and the beta-arrestin. Cyclic AMP is what gives us insulin secretion, and this is what the molecule is biased. Beta-arrestin takes it out and terminates its activity. This results in prolonged GLP-1 for insulin secretion over there. In addition, GIP modulates lipid storage and lipolysis in white adipose tissue, and it also regulates postprandial glucagon secretion via direct alpha cell effects over there. Also tends to reduce the nausea through a central effect. But the GIP paradox, as I told you, is we have tirzepatide, GLP-GIP agonist, but we have this maritide, GLP-1 plus GIP antagonist, and it causes pretty good weight loss and glycemia. So this is a study which was presented at last year's ADA, presented in Lantus. These are people with a weight of about 230 pounds. The weight comes down by 17%. A1C in these patients with diabetes, 2.2. Weight loss in those, of course, this is another study, 20%, which is coming down towards by bariatric surgery levels. Of course, we have to remember there are GI side effects following the first dose, because remember, this is once a month, every 4 weeks. And then if you started low, you had better GI tolerability. How do we reconcile the paradox? I have asked a lot of people, Michael Knox, how can both of it do it? You agonize it, you antagonize it. As of now, what we think, it's probably desensitization, that's why I put a question mark. It's also maybe internalization, means it goes and continues stimulating. Bottom line, nobody knows. What about glucagon? Glucagon, I might remind you, was discovered before my assay was before insulin. We knew about glucagon before insulin. The assay was in the later on. Is glucagon a friend or a foe? We know people get hypoglycemia. It's approved to raise the blood sugar. And if you block it, you can decrease blood sugar type 1 and type 2. And Roger Unger, who's from Dallas, unfortunately he passed away at the age of 94. People thought he would get the Nobel Prize because he said, block glucagon, you will cure type 1 diabetes. But unfortunately, it did not happen. In humans, the studies are not that great. In mice, you can cure it. And you have liver problems, blood pressure, and LFTs, abnormalities. So people thought, okay, let's agonize don't block it, do it. And we have many dual GLP, GIP And as Professor Das said, we've got these triple agonists coming in. So which are the ones? None of them are approved. So these are the dual agonists. And you can find out when it says dutide means it is two of those glutides over there. So vodutide, efinopegdutide, mazdutide. It's approved in China actually, mazdutide, pemvidutide, corticotidutide. Well, what about adding glucagon? And then we get the power of three. I don't know if you remember Alice in Wonderland. Lewis Carroll wrote it, but he also wrote this other thing, The Power of Three. So this was just presented at the ADA this year, and it is a phase 3 study called the Transit T2D1 with the retatrutide. And look at this. 3 doses of retatrutide, 4, 9, 12 versus placebo. People, baseline weight is 7.9. Some people are reaching 5.9, below 6. This is not even in the diabetes range over there. It's pretty impressive, and these are the dose titration which they did. What about body weight in patients with diabetes? Mean weight 96 kilos. About 15-16%, which is pretty remarkable over there. They also presented data of what they call the Triumph 1 study. I don't know why they called it Triumph. Before the victory, they're declaring victory. Anyway, phase 3 study with retatrutide, and this is their slide over there. 80 weeks, that's 20 months, the 12 milligram dose, 28%. That is very well in bariatric surgery. People lost 70 pounds in the thing. And they had an extension up to 104 weeks. 30% weight reduction. And 1 in 4 people lost more than 35% of their body weight. Reduced knee pain, reduced sleep apnea. 95% of people with pre-diabetes going back. But remember, side effects are always there. Mostly GI, there's hypotension. Strangely, UTIs were more common in female patients, and hypotension also was reported, and heart rate also goes up initially when we have to be there. About 5% of people dropped out because of the side effects. But what about its effects on fatty liver disease, on MASL? Well, this was another study. Arun Sanyal was the PI on that study. They published it in Nature in 2024. At 24 weeks, 6 months, normal liver function defined as less than 5%, almost 80% of the people on the 8 milligram 86, they reverted back to normal fat versus 0% with placebo. There's another one which is undergoing trials, FOC pegtrutide. When you see true means it's a triple agonist. And it's being studied for MASH. It's got an orphan drug designation from the FDA EMA for pulmonary fibrosis, primary biliary cholangitis, sclerosis. I just don't understand what these drugs are doing. It's almost too good to be true. And of course, the question is, why are they so robust in their effects to lower blood glucose, weight, and all that? That's because in addition to GLP, GIP, glucagon is a catabolic. Insulin is anabolic. Glucagon is it increases energy expenditure, thermogenesis, acts a lot on the liver through FGF21, and it increases lipid oxidation and decreases de novo lipogenesis in the liver. So then look at the other peptides, amylin. It comes from the beta cell. Till today, at least I don't know, many people have asked, we don't know why the beta cell is making 2 hormones. It's making insulin, we know about that. Why is amylin coming there? Leptin from adipose tissue, and amylin, it restores sensitivity to leptin, which is a very strong satiety signal. And if you target amylin, you may get less nausea and vomiting, less muscle loss, and potentially longer lasting weight loss. This is all potential, but it's there. Many analogs are there. I've named them eloralintide, cagrilintide, CagriSema, petrelintide, and all of them. But this is very interesting. It is suggested that they might reduce less muscle over there. And skeletal muscle loss, as we know, is often overlooked, but we are paying more attention to it now. It can improve metabolic health because muscle is where insulin's main action is. You can get sarcopenic obesity, and most weight loss procedures, whether it's bariatric surgery or others, you will lose about 30%, 20 to 40%, including muscle as lean body mass, which has got adverse effects. Of course, now we don't have much data, but we're looking more at MRI, we're more looking rather than just DEXA or bioimpedance. And that's why we tell patients to increase protein consumption and perform muscle strengthening exercises. What about drugs to improve muscle mass? Well, there are drugs are there. We have many. They block myostatin activin. These are the drugs. I won't name them. Bimagrumab, I might remind you, is named after, in fact, at the slide in the AD they show Bhima, our character from the Mahabharata, from the Indian epic. They've halted Bimagrumab alone, but it is continuing along with semaglutide. Then if you do an androgen receptor modulator, and that is also in the thing. But the question is, why don't we prevent obesity in the first place? That's because it's a very complex mechanisms which control it. Remember, the default in the body is gain weight. It is not to lose weight. The default is gain weight. And centrally, of course, we all know the hypothalamus integrates everything. It does that through the arcuate nucleus, through these four nuclei, AGRP and NPY. And they're like the gas pedal. You stimulate them, you eat more, you expend less energy. POMC and CART is there, and they're the brake. You stimulate them, you don't eat as much, you increase energy. Then there's this other parallel system, we don't talk about it. The nucleus of the solitary tract, the dorsal motor nucleus area postrema, collectively called the dorsal vagal complex. It does everything, not only gut motility, digestion, energy, heart function, lung function, all of it is there. That's central. What about the periphery? Well, leptin is a well-known satiety factor. Insulin also has got very complex effects, but long-term it regulates body weight over there. Then all the gut, GLP, GIP, amylin, all of them, they act at the hypothalamus over there. Then cholecystokinin, short-term regulate, meal to meal it regulates in addition to it increases bile secretion. Then nutrient receptors, stretch receptors going via the vagus to the dorsal vagal complex. There's only one hormone which opposes all of them, ghrelin. That increases energy intake, but it is opposed by all of it, and it shows how powerful the system is that the body, its default is to gain weight. That determines what you eat, your vein size, and everything. This is the homeostatic system, and the thing opposing it is the hedonic system. Hey, there's a gulab jamun there. I don't know what you had for dinner. I saw over there. You finish your dinner, you're full, and come on, go have the gulab jamun or the rasmalai. Well, dopamine is the main thing, and that is the mesolimbic system. It's a reward system. And David Kessler, who was a former FDA commissioner, and he was actually in charge of COVID in the Biden administration, he gained 35 pounds during COVID, and he himself took Ozempic, and he wrote a beautiful book, Diet, Drugs, and Dopamine. But what he didn't say is there's a third system which can override the other two systems, the prefrontal cortex. Some people will say, yeah, I see that. I'm not going to eat it. The cognitive system can override all of this. But he said one very important thing. I'm coming to the end. I've got a couple slides more left. He said, we don't have an end game. For blood pressure, we have an end game. Your blood pressure 120, 80 or 130, 70. For glucose, we say, yeah, A1C 7 or 6, or we can do that. But for weight loss, what do we want? 5%, 10%, 12%? We still don't have an end game in sight for a lot of the things. Cost, of course, is a big thing. So where did the jungle start? This is what I said. We started with the monoagonist. We went to the dual. All of these are proved. Then we came to this antagonist. Then we went to the, GLP, GIP. Then we came to the triple agonist. Then we came to the quadruple agonist with IGF-1. It's an oral pill, but not much data recently since last ADA. Then amylin. All these molecules are there. DACRA, amylin calcitonin receptor. Amylin acts through the calcitonin receptor. Then agents to reduce muscle loss. And GLP-1 plus GIP, called dapeptide, NPY, FGF, FGF agonist. Where is leptin? We did the studies almost 35 years ago with leptin for weight loss. It didn't go much. And this is Jeff Fly wrote, does the Emperor of Energy Balance have no clothes? Well, leptin is coming back. There is a drug called Mibaverdimab along with tirzepatide, and it is being studied. And at EASD last year, quintuple, what is it? Tirzepatide, so it's GLP, GIP, and lanifibranor, a pan-PPA agonist. It's undergoing studies, alpha, delta, and gamma over there. All started with the Gila monster over there, in 2015. This was developed at 2005, right in San Diego. The company was over there. The Economist said last year, they're probably the most important breakthrough drugs ever, like a Swiss knife. It addresses everything, alcohol, Parkinson's. Of course, some of them are not approved over there. But we still have issues related to cost, access, tolerability. WHO said use it, but where's the cost of it? I know it's available in India now at a lower cost, side effects, non-responders, they are there. Durability, all of this remains. Do I have another 2 minutes or I can finish over here? I don't want to prolong the session. I'll take you very quickly. The future is multi-agonist. This is Dan Drucker. We have GLP, GIP, glucagon, amylin, activin 2 receptor, myostatin, that's the bimagrumab and all. Apelin receptor, again, muscle function. Neuropeptide Y, centrally, GLP-2, they're all being studied. And this is again from Dan Drucker. We have to target the brain, all these receptors, glucagon, GLP, amylin, neuropeptide. The pancreas is over there. We have GLP, GIP, and glucagon. The bone, GLP-2, GIP, sarcopenia. This is targeting the activin and apelin receptors. Adipose tissue, these receptors. Metabolic, we have glucagon, GLP. Although GLP-1 is present in the liver, it's not much at all. It's in the endothelial cells. It's glucagon which is doing most of the stuff. In the kidney, of course, we have glucagon, GLP, atherosclerosis, GLP, GIP, and of course, cardiovascular protection. We have all these drugs. Let me finish with Sir C.V. Raman. He said, ask the right questions and nature will open the door to her secrets. I think we're asking the right question. And I might remind you, in 1930, almost 100 years ago, he was the first non-white Asian and Indian to receive the Nobel Prize for his effect. Thank you so much. Yeah.
Professor Sundar, it has been one of the best talks, sweet, short, and highly impactful. There'll be few questions. Would you like to take the questions from the audience? One or two questions? One or two things can I ask you? I just wanted
Professor Shah to begin.
Sundar, we wanted to ask you that we thought that with retatrutide, we have reached the climax of weight loss medication, triple combination. You have also now shown about a quadruple combination. Where is it going to end? How many drugs can we combine together?
It depends on the chemist. And as I told you, the FDA commissioner said we have no end game in sight. We have no idea where we are going. And I don't know if Professor Shah has some.
And Sundar, is this myostatin being incorporated as anti-sarcopenic? Is it already done? The clinical trials are going on?
Yeah, yes.
So it is showing there is not much of sarcopenia.
Yeah.
My last question.
You have to wait for the full results to come out. The problem is that if you start tinkering with nature, nature does something else which we have to wait. And I might remind you, there's a New England Journal article from 20 years ago. There are human mutations of the myostatin receptor. And you can go and just put the myostatin receptor mutation, New England Journal of Medicine. There was a 3-year-old German boy who looked like he was Arnold Schwarzenegger. He was like an Iron Man. 3-year-old boy. Because myostatin, he was born with a natural mutation.
The final question from my side. Recently we had obesity medicine conference in India. Obesity medicine. We had few came down from there. There's a society called Obesity Medicine. They came out and they talked about it. And they also talked about the older drugs, phentermine plus one more, and they are also available in the USA market. In our country, we don't have that. What's your comment on those two combination, where it is used, and what is the benefit beyond GIP, GLP, and glucagon, etc.?
Yeah, I mean, I can only give you my opinion on them. They are not used much. You have the bupropion,
Yeah,
naltrexone
bupropion combination.
and even orlistat is approved as over-the-counter. Orlistat is a fat blocker. Maximum you will get 5%, 7%, lot of side effects over there. In my opinion, I think we have moved beyond. It's like we are in the horse carriage and now we are coming to the cars. We are going to electric cars and all that. That's my opinion.
Perfect. Thank you. We'll have the questions first from the chairpersons, please. Any audience, any one or two questions from the audience? Sundar is our own. We can ask him anything without any inhibition. I just want to know, Sundar, how much weight loss in Indians, you don't put the question back to me, how much weight loss in Indians is appropriate? There is a saying going on, do you like to look like Karan Johar by reducing X percentage, or you want to stop? Where do we stop? And number two, if the drugs have to be continued indefinitely, what is your answer for the Indian doctors, Indian patients, and Indian families who will be using these drugs?
Yeah, every doctor has to make the decision, depends on the patient. I have stopped these drugs for many of my patients. One patient came in, he had a BMI of 30 or something, and his BMI came down to 22. And he said, he stopped it on his own. He said, I'm not taking these drugs again. He said, I can't even walk. I can't get up. This is in the earlier days when we didn't know. The second thing is, I didn't say, well, the side effects are there. There's dysphesias, dysgeusias. One, the patient and the wife came. The wife said, stop the drug. I said, why? This guy is so grumpy. He shouts at me, this thing.
Irritable.
She says, I don't want to pump the drug. Stop the drug. So we have to do it for each patient. We have at first do no harm to the patient. It's an individual decision. We can find out. Muscle loss is still there and we have to be thinking. I think we should respect Professor Shah's time. I'm sorry I took a little bit.
No, I think brilliant answer. No, tell me just one last question. This new combination of amylin with Cagri and all that, CagriSema and all that, are they going to be comparable to GIP, GLP, to incretin, or they're going to be different? What is the amount of weight loss? Because we have not known about the CagriSema and other amylin combinations. What is the weight loss?
It will not be probably in the retatrutide because a retatrutide, the glucagon, right, blows everything away. But the side effect profile may be better. Like I said, it improves leptin sensitivity, which is still the emperor of energy balance in the body. It may cause less muscle loss, and because its effects on the dorsal, it doesn't act on the area postrema over there. And I don't know, and there are no comparative studies at all. So we cannot say, but it will not, in my opinion, not be in the ballpark of the 30, maybe 15, 18%, but we'll have to wait and see.
Good.
We have that, Sunil here, sir. Good morning to you and thank you very much.
Sunil is here. Sunil Gupta is here. Sundar, Sunil is here.
I don't know whether you are able to see me or I'll have to.
I can. I saw you. Yes, I saw you.
Yes. Now I'm here.
And I must tell you, Sunil has organized one of the best conference this year. He's the incoming president for the RSSDI. And he has organized one of the best conference. We are all appreciating for last 2 days. One more day has to go tomorrow. So a big round of applause for him, Sundar. He has organized one of the best conference.
So Dr. Sundar Mudliar is our international advisor of the.
Yeah, I know.
So I go on talking to him on this aspect quite often. I feel that's one of the wonderful oration I have ever heard on this incretin-based therapy, especially the forthcoming and future of this, because we have gone up to retatrutide, and then there are hardly anything we are aware of. But I feel it's one of the exciting area working. CagriSema, yes, redefined. They have redefined program like you have other programs for others. So they have redefined program. Redefined 2 data has been actually presented in one of the meeting, if I'm not wrong, last ADA. or ESD. Some meeting I have attended, so, but they have presented. But then if you even we have to go a long way to go. As per a side effect profile of amylin and the GLP-1 combination, CagriSema or SEMA and cagrilintide, is side effect profile is almost similar, possibly. Muscle loss, I don't think is
Less.
much of the difference, but now have redefined 3, which is CV outcome trial, and we have just finished 1 year, maybe 3 or 4 years later, we'll have CV outcome trial from redefined 3 support like. So thank you very much once again.
Sunil, before you close, I think Sundar, I have a quote for you. The quote is that, it has been said by the one Indian seer who said that if you want to go abroad, you must go. But see that you are enriching your country with knowledge throughout. And Sundar, we like to give a standing ovation for coming every year to every meeting that we invite. And no, Sundar, it is a great occasion, I mean, the way you speak, the way you motivate, the way you transfer the knowledge. This has been a complete lecture in 25, 27 minutes. You have opened up newer vistas before us. And we are showing our love, our appreciation for you. Over to Sunil for the final word. But Sundar, really, we appreciate very much.
So nice of you. Thank you very much, sir. And next year, at least, we hope that you should be here physically in 2027. It's the first week of June. Again, we have 15 days gap between ADA and this. So it says the first week of June, we have Hello Diabetes Academia 2027 next year. So please block your dates, sir. And if you have, if you can just organize to have you physically, that next year will be really great for all of us. Thank you very much once again for being here. Thank you. Chairperson, sir, you have to conduct the second session now. Dr. Pankaj Shah is already there. He has already joined.
Dear friends, we have another son of the soil very close to us, Professor Dr. Pankaj Shah from the Mayo Clinic. He is MD, DM in endocrinology. He's a consultant endocrinologist at Mayo Clinic. And, we meet him very often. He has contributed immensely in the faculty of Mayo College Department of Endocrinology. He is the chair of the Hospital Diabetes Oversight Group at the prestigious Mayo Clinic, Rochester. Pankaj is very close to us and has year after year come here in person or over the virtual platform, has enlightened us. And today he is going to speak to us on a very important topic. And that is one of the complications of GLP-1. I mean, one of the complications we have heard, I have not seen, is the pancreatitis and the pancreatic mass. Now, Pankaj is going to speak to us on the GLP-1 agonists, pancreatitis and pancreatic mass. A very interesting and revolutionary topic. Pankaj, all is yours.
Thank you very much. Can you hear me okay?
Yes, we can.
Am I audible loud enough or?
A little more louder, better. It is okay. It's okay, Pankaj. It's okay. Pankaj is okay. Voice is okay.
Pankaj, you're on mute. Okay.
This is okay?
Yes.
Okay, thank you. Thank you for the opportunity to address the audience there. This is my topic. So the main messages are this. We will talk about routine test of pancreatic enzymes while using these agents. We'll talk about abdominal pain while using these agents. We'll talk about prior pancreatitis as a contraindication or not. We'll talk about high risk of pancreatic cancer as a contraindication or not. So these are the various GLP-1 and GIP, GLP-1 dual and trip dual agonists that are available in different parts of the world, including several, of course, only in India, some Indian trade names. These are approved, as we've discussed, for diabetes control, for reducing end-stage kidney disease, reducing major adverse cardiovascular events, treating MASH, reducing weight, and of course for obstructive sleep apnea. I will not repeat this. And for that reason, the market share, for example, in India has been growing from almost none in 2020. It has gone to 7% of diabetes market and 80% of obesity market. There is about 1,600 crore rupees being spent on this market share apparently in 2026. So what is the story of incretins and pancreatic cancer? Let's start with the origins of concern. In April 2005, exenatide, the first GLP-1 agonists, were approved by US FDA. In 2005 through 2006, about a year and a half, there were about 50 cases of pancreatitis reported to the FDA adverse event reporting system. Out of that, 18 were thought to be from other causes, but 30 were, no other cause was found. And of that, only 11 had tomography, CT scan, or ultrasonography. So in its wisdom, FDA in 2007 issued a warning of possible link between exenatide and acute pancreatitis. So these early signals have often driven the guideline caution and clinical practice changes that still persist. Then came the meta-analysis of this data from 2004 to 2009, published in 2011, showing that reporting of pancreatitis was about 10 times higher odds with exenatide compared to thiazolidinedione, meglitidenide, or sulfonylurea. Even with sitagliptin, it was 6.5, 7 times more of reporting pancreatitis compared to reporting of pancreatitis from other drugs. And then the SYNC study came out, the case control study of one of the insurance companies, showing that there was 2.2 higher odds of having been on exenatide or sitagliptin, having been on exenatide or sitagliptin in those who were presented to hospital with acute pancreatitis compared to those who did not have acute pancreatitis and presented to emergency room for other reasons. Since then, there have been other studies that have shown association between acute pancreatitis and GLP-1 agonists, as can be shown here, these 3 studies in addition to the SYNC study. And then there have been several retrospective analyses don't show any link association between these agents and pancreatitis, the hazard ratio crossing 1, as you can see, all these are not statistically significant link. And then there have been a couple of studies which showed that actually there is a lower risk of acute pancreatitis in those agents being used. Now, this is of course retrospective studies, these are association studies. So association studies are all over the place, higher odds, no odds, or lower odds of pancreatitis while these drugs are being used. Well, let's talk about acute pancreatitis first of all. How do we diagnose acute pancreatitis? Acute pancreatitis is diagnosed by 2 of the 3 things. Number 1, abdominal pain consistent with the disease. Number 2, elevated enzymes 3 times upper limit of normal. And number 3, characteristic imaging studies. So that is the current guidelines, 2 of the 3. Let us look at it some more. Let's talk about abdominal pain. The abdominal pain of acute pancreatitis is epigastric or left upper quadrant. It's constant, radiates to back, chest, flanks, severe usually, associated with nausea, vomiting, and inability to tolerate oral intake. Well, the problem is that GLP-1 receptor agonists or GIP, GLP-1 dual agonists, etc., they are associated with abdominal pain. The pain can be from drug, from biliary complication, from gastroparesis, from gastritis, constipation, intussusception, acute pancreatitis. There are many reasons for pain. So if we look at the specific characteristics of pain, drug can itself cause pain. As many as half of these patients may have pain. They're usually transient. Biliary complications associated with these obese patients or people with diabetes using GLP-1 agonists is upper abdominal pain. It can lead to pancreatitis by itself, but it can have pain without pancreatitis and nausea, vomiting, maybe fever. Gastroparesis may have abdominal pain, cramping. There may be reduced eating there. Gastritis associated with using these drugs can have epigastric burning pain, nausea, vomiting, decreased appetite. Constipation can have abdominal pain. Intussusception can have upper abdominal pain, nausea, vomiting, and of course, acute pancreatitis has typical pain. But then acute pancreatitis has atypical pain. It may be painless. There may be other manifestations that are not typically considered as part of acute pancreatitis. For that reason, it is not clear what pain means, right? So about 60% of people who are using these agents will have pain sometime or the other while using these drugs. About 25% of people will have significant nausea or vomiting while using these agents. So far it would appear that abdominal pain, nausea, vomiting are common when using these agents, and it is not always due to acute pancreatitis. There are other causes. Well, let's talk about pancreatic enzymes. Now, this data has nothing to do with GLP-1. This is just looking at acute pancreatitis. If you just look at acute pancreatitis, false positivity rate of 3 times upper limit of enzyme levels of amylase and lipase is about 25 to 30%. Such a high false positivity rate. So at that backdrop, I am discussing a case here, a 65-year-old man who's initiated on semaglutide to manage diabetes. He had coronary disease, so there was a good reason to use it, loses weight, has good glucose control, but now has amylase and lipase that are high. So semaglutide has been stopped. What is the best advice for this patient? Number one, elevated pancreatic enzyme levels can occur with GLP-1 receptor agonists without pancreatitis, reflecting adaptive pancreatic growth rather than inflammation. Number two is lipase elevation is diagnostic of acute pancreatitis. Number three is lipase elevation is itself not diagnosed with acute pancreatitis, but reliably predicts it, or same thing with amylase. I will explain to you why, but my answer is this, that elevated pancreatic enzymes can occur with GLP-1 receptor agonist without its relationship to pancreatitis. So this is some data on liraglutide therapy. When on liraglutide therapy, the lipase concentration goes up pretty much soon after starting liraglutide and stays high throughout treatment and then comes back towards normal after stopping liraglutide. So looking at the liraglutide diabetes trial, elevated lipase can be seen by 30%. 5% may have 3 times upper limit of lipase if it is routinely measured. Actually, similar numbers, slightly less, but similar number for amylase as well. This is for placebo. This is not even drug. So those who are receiving drug has slightly higher elevation of lipase and amylase as we had seen in the graph. So overall, the positive predictive value of routinely measured enzyme 3 times upper limit of normal is 0.7%. That means if 1,000 people had elevated lipase 3 times upper limit of normal, only 7 out of them actually have pancreatitis. So essentially, pancreatic enzymes can be elevated even 3 times upper limit of normal on these drugs and are not predictive of current pancreatitis or future pancreatitis and have no role in routine management. Well, the third topic is abdominal imaging. Well, unfortunately, we don't have enough data on abdominal imaging in the so-called pancreatitis associated with GLP-1 agonists, so I'll skip that. So far I hope I've convinced you that if we diagnose by pain and pancreatic enzymes 3 times upper, there is very high false positivity. And I at least would not diagnose somebody pancreatitis based on 3 times upper limit of normal enzyme levels unless confirmed that pain is typical of acute pancreatitis or their imaging findings are consistent with acute pancreatitis. This is a very interesting data on acute pancreatitis presenting to emergency rooms in those who are on GLP-1 receptor agonists compared to those who are not on GLP-1 receptor agonists. These are acute pancreatitis in general, 20,000 here and 20,000 here, they are propensity matched, etc. from TriNet-X data, showing that those who develop so-called pancreatitis with GLP-1 receptor agonists have about half the risk of dying, 1/3 the risk of complications or needing parenteral nutrition, about half the risk of acute kidney injury or shock, and 1/4 the risk of need for mechanical ventilation. So then I can conclude that if pancreatic pain plus enzyme is used, there is high positivity rate, and it's a milder disease or a mixture of people who don't have disease and have disease, and that's why all average is much milder. So then what we have to do is to look at the meta-analysis of randomized controlled trials looking at acute pancreatitis with these agents, and this is the data. As you can see, the odds ratio 1.11 crossing 1, GLP-1 receptor agonist only without the DPP-4 inhibitors 1.05, 0.89, 0.96, 0.95, 0.96. This also is crossing 1. This also is. So all these odds ratio are crossing 1. That means that meta-analysis of randomized controlled trials failed to show any association of acute pancreatitis with these agents. What about using these agents? We use these agents in a population that is at a higher risk of pancreatitis to begin with. These are the risk factor for acute pancreatitis on the middle column and for diabetes on the right column. Hypertriglyceridemia, high triglycerides, gallstone disease, excessive alcohol use, smoking and obesity, all of them are risk factors for pancreatitis. Similarly, hypertriglyceridemia, gallstone, alcohol, tobacco, and obesity are risk factors for diabetes. They have common risk factor between the two, and we're using these drugs for diabetes. Obesity by itself causes both of these. So obesity also, we use these drugs for obesity. And then, of course, diabetes is a risk factor of pancreatitis, and pancreatitis is a risk factor for diabetes onset. So there are common risk factors, especially of concern is gallstone, because people develop gallstone on weight loss. Randomized controlled trials repeatedly show that people using GLP-1 agonists at a higher risk of developing gallbladder or biliary disease, be it stone disease or polycystitis, etc. And that this is seen more in weight loss trials compared to type 2 diabetes trials. And as we discussed, gallbladder, gallstone disease itself can cause pancreatitis also. So then our summary is that there is a common risk factor between the indications of these agents and pancreatitis. And gallbladder disease can be caused by GLP-1 receptor agonists, especially those who have a lot of weight loss, and that can lead on to pancreatitis, of course. What about the GLP-1 receptor these agents for people who are at relatively higher risk of acute pancreatitis? So there is not a lot of data, a lot of later studies ruled out pancreatitis, acute or chronic or past pancreatitis, or at least recent pancreatitis when they recruited these trials, patients for these trials. So we did not have previous pancreatitis patients, except the liraglutide study which had it. So we don't quite know what is the risk in pancreatitis in those people who are at high risk. In that backdrop, let me show you one study. This is from Israel. It shows that those who have had pancreatitis or elevated lipase have 25% higher hazard of developing pancreatitis if started on GLP-1 receptor agonists. And this is despite correcting for other factors as they are. So this study, very recent study, would imply that maybe there is some risk associated with those who have had pancreatitis and lipase. In that backdrop, let me discuss a case that we saw in Lipid Clinic who had 20 episodes of acute pancreatitis, triglycerides more than 5,000, etc. I'll cut short and say, what is the best advice for this patient? These agents cause pancreatitis. He had pancreatitis and we should not use. These agents likely do not cause pancreatitis, but she had pancreatitis and should not consider therapy. SGLT2 inhibitor is better, or DPP4 inhibitor is better, or we should consider therapy for her. And let me argue that my answer is the last one. And let me show you what happened. These are various triglyceride concentrations that I got for this patient from the chart. Patient was on plasmapheresis to lower triglyceride concentrations and was gemfibrozil fenofibrate to reduce the risk of pancreatitis. And these are the specific events of pancreatitis this patient had over a period of time. After this episode of, with this pancreatitis, of course, serum lipase concentrations were very, very high. This small line that you can see, light orange line, a thin line, that is the upper limit of normal. So what did we do with this patient? Well, before that, the patient's BMI is high, patient is obese, and of course, this patient's weight is more or less stable over the 7-8 years that I'm showing the data. What did we do with this patient? We started this patient on liraglutide after an episode of pancreatitis, and we then switched the patient to tirzepatide after that. And this is what happened. Patient's weight came down, BMI came down, and triglycerides came down, and at least since September 2023, hasn't had another episode of pancreatitis when she was having repeatedly. We'll see what happens, but there is no episode of pancreatitis here. So my summary from this is that I would recommend these in people with prior pancreatitis if the primary cause, the proximate cause of previous pancreatitis has been eliminated, or by using these drugs, the primate cause, the proximate cause will be eliminated. The second half of the talk is brief, fortunately. I'm going to talk about pancreatic masses. And the concern is the association of incretin with pancreatic cancer. Long story short, this is a patient who has a pancreatic cyst, and whether it should be used or not, and we'll discuss that. Okay, so let me give you the origins of concern. April, Byetta or exenatide is approved. October 2007, there is some association of acute pancreatitis, and pancreatitis is the risk factor for pancreatic adenocarcinoma. So that the Erlacher study that we saw reviewed the risk association of these agents with pancreatic cancer compared to the controls, and they showed that there were about 2 to 3 higher odds of pancreatic cancer with exenatide or sitagliptin compared to the report associated with thiazolidine, meglitide, or sulfonylurea. Then came the big study, the Butler study, in which they studied a small number of people, histopathology of organ donors. So people have died, and then looking at their pancreas, those who were diabetes on incretin therapy, those who were in diabetes on other therapy, and the control subjects. This is the data that showed that pancreatic mass is almost twice as much in those who were receiving incretin therapies. Beta cell mass was very, very high. Alpha cell mass was very, very high. Now, this has been repeated in many other studies, and this has been shown in many studies. They also showed that there was increased exocrine cell proliferation, increased pancreatic intraepithelial neoplasia, increased alpha cell hyperplasia, and microgluconomas seen in histopathology. Then came this retrospective analysis of cancers in the LEADER trial, the liraglutide trials. These are the various cancers as can be seen here. I want to highlight on pancreatic cancer. Those who received liraglutide, 13 had pancreatic cancer out of 4,600, and those who received placebo, only 5 had out of 4,600. This was not statistically significant. It is crossing 1. But you know, it is definitely concerning, no question about it. So if you look at the lesions in pancreas, they are very common. If you did CT scan of the pancreas, about 10-15% of people have masses. Elderly, about 50-60% people have some lumps in pancreas. There are many lumps in pancreas. They can be cystic. There may be intraductal pancreatic mucinous neoplasm or cystadenoma, side branch IPM, and there are many things, and there can be solid masses as well, including malignancies or neuroendocrine tumor and focal pancreatitis, etc. So summary is that pancreatic lesions are not uncommon. Most are benign, but there may be malignant lesions, or they may have malignant potential. Many of the IPMNs have malignant potential. Now, same thing as pancreatitis, these agents are used in people who are at a high risk of developing adenocarcinoma to begin with, and these are the risk factors of pancreatic cancer and for diabetes. And for pancreatic cancer, acute and chronic pancreatitis, cigarette smoking and alcohol, obesity and metabolic syndrome are all risk factors of pancreatitis, pancreatic cancer, as well as for diabetes. Also, diabetes is a risk factor for pancreatic cancer, and pancreatic cancer is a risk factor for newly developed diabetes. So they relate to each other. So to summarize then, the common risk factors between pancreatic cancer and adenocarcinoma and their risk factor for each other. So if you look at the association studies, There is at least one study showing an association between pancreatic cancer and using these agents, as can be seen here, about 1.5 to 2 times higher odds of developing pancreatic cancer. There are some studies showing no association between these two, and then there are many studies showing, if anything, decreased association of pancreatic cancer with using these agents. Now, these are all retrospective study, association studies. These are not meta-analysis of randomized controlled trials. So association studies show higher odds, no association, or lower odds all over the place. But if you look at the randomized controlled trial, the odds ratios are 0.84, 0.78, 0.68, 1.06, which is 0.67 to 1.67, 0.62, 0.41 to 0.95, etc. Essentially showing no risk of pancreatic adenocarcinoma with GLP-1 receptor agonist and GLP-1 dual agonist use. Now, mind you, many trials have excluded participants who had recent or active malignancy, and those pancreatic cancer was not specifically excluded. Remember, pancreatitis was excluded, and pancreatitis is a risk factor for pancreatic cancer. Of course, medullary thyroid cancer, etc., are excluded. I'm not going there. So what about those who had high risk of pancreatic cancer? This is the data in patients who had chronic pancreatitis. This is a huge database looking at that and showing that those who have had chronic pancreatitis, if these agents are used, are at a 33% risk of developing pancreatic cancer if they use GLP-1 agonist compared to not using GLP-1 agonist. About half the risk if they are diabetes and using GLP-1 agonist compared to not using GLP-1 agonist. So the risk is going down if this retrospective data has to be believed. And there is some more data from real world looking at the overall pancreatic cancer risk in general population, showing that the risk of developing pancreatic cancer is lower in those who are GLP-1 receptor agonists compared to those who were treated with insulin. Not only with insulin, with DPP-4, sulfonylurea, metformin, SGLT2 inhibitor, and thiazolidine, nowhere it is showing that GLP-1 receptor agonist has a higher risk of pancreatic cancer compared to the other comparator drug in diabetes. So it would appear that there may be a reduced risk or at least not an increased risk of pancreatic adenocarcinoma when using these agents. But I would hesitate recommending these agents for pancreatic cancer. Though there are indications that they may not be harmful. There are some abstract published in ASCO, the Cancer Association's study recently, that they may be actually protective, but we'll see when the papers come out. So essentially, those who are at a high risk of pancreatic cancer, I could use this shared decision making, discuss the cardiorenal benefit and other benefits, and the risk of pancreatic cancer, and we can take it from there. I am not discussing about the contraindications otherwise. We know. So to conclude then these agents, when using these agents, routine pancreatic enzyme monitoring is of no value and should be stopped. That abdominal pain should be adequately interrogated before diagnosing somebody having acute pancreatitis using these agents. And prior pancreatitis is not a contraindication to start these agents. Consider, especially in those where the cause of prior pancreatitis has been addressed, or the cause of pancreatitis like triglycerides will come down by using these agents because of weight loss. And of course, if somebody develops pancreatitis and it is confirmed, it is recommended that these drugs be stopped. Those who are at high risk of pancreatitis is not a contraindication, but I would definitely await more data before I recommend these agents in people who have had pancreatic cancer. Thank you so very much for your patience.
Dr. Pankaj, it has been very good to allay our fears and anxiety. You know, these drugs are more and more used in our country, and we do not have enough facility to do. I mean, of course, I do not think we do enzymes while starting these drugs. Maybe, as you said, history of MTC, history of pancreatitis, prior pancreatitis, history of pancreatic cancer, that we definitely obtain. So I think what you said is absolutely beneficial for us, that we should be careful in depriving the patient of the benefit of this wonder molecule. I have only one question to ask Pankaj. Pankaj, I'm Ashok here. Ashok from Jipmer. You know, Pondicherry is, yeah, Ashok Das. So what happens, Pankaj, is that, you know, we have high alcohol consumption in Pondicherry. You know, it is cheaper than the water. So we have high percentage of people who have alcoholic pancreatitis. And to confide in you, I have given to at least 10 of them and no problem so far. What's your advice on the people who consume alcohol, had 1 or 2 attacks of alcoholic pancreatitis? You showed alcoholic pancreatitis was also there in your list. Any special advice you like to give?
If they have had pancreatitis in the past and taking alcohol, they should not take alcohol. That doesn't mean they should not take GLP-1 agonists, but they should not take alcohol because that is life-threatening. Most people will stop it at last, maybe after 6th or 5th episode of pancreatitis. But if somebody has just alcohol and has had no pancreatitis, I think these agents are very good. Actually, people, it helps with addiction and de-addiction, as you know, more than I do, but it is helpful. So I don't hesitate using these agents in that situation.
Thank you. Any questions from the
Sir,
chairs? Yes.
Sir, one question. So with these discussions, so what are the basic investigation to be done prior to starting GLP-RA to obese patient or obese diabetic patient? So what are the basic investigation to be done?
Basic investigation to be done is examination that there is no pre-existing thyroid nodule. Otherwise, you will be blamed for medullary thyroid cancer if it did not exist. Other than that, there is no basic investigations. Frankly, in history, of course, you know, if the patient has had gastroparesis, that we just have to discuss as to if it used this. It may make things worse, but essentially there is no investigations that I do.
Basic amylase lipase investigation, basic amylase lipase, USG abdomen.
You should not check serum amylase lipase before starting or after starting. The problem in India is that packages of laboratories, lipase amylase is part of those packages. And I've had so many people in India who had lipase amylase measured routinely. Now they're measuring routinely on GLP-1 and they find it to be high and they stop GLP-1, which is, I'm not saying there are no other options, but if that is a good option for the patient, we should not deprive that patient of that.
Okay, thank you, sir.
Dr. Budaliar is here. Dr. Budaliar, please go ahead.
No. I enjoyed your talk, Pankaj. And a lot of it I have to go back and teach my fellows again. I really like that, the lipoprotein lipase thing which was there. But I just want to make one correction to what I said. I said glucagon was discovered before insulin. No, it was discovered 1 year after insulin. The assay was 1 year before. Just for correction, Professor Das here over there. But this is, I enjoyed your talk.
Dr. Pankaj, good morning here. Sunil here. Thank you very much once again being with us with this Hello Diabetes Academia. Both of you, Dr. Sundar Mudlia, Dr. Pankaj. Pankaj, we had wonderful insight into it because we all have apprehensions of starting GLP analog when it comes to past history of pancreatitis, someone coming to you with family history of pancreatitis, someone coming to you with severe hypertriglyceridemia, someone coming to you with cholelithiasis is another thing, someone coming to you with moderate to severe proliferative diabetic retinopathy. So these are some areas where we as a clinician becomes little, in a gray zone whether to start, not to start such medicines. And so this is, there are some good insight, but I feel retina has not been, of course, all of them, we know that we have to be careful, we have to screen them. But what you said, not to do anything, I feel sometimes the moment we feel some kind of suspicion, then we certainly at least get, I started getting sonography done for cholelithiasis and retina is being evaluated in practically everyone every year. So what's your comment on that? Whether we should not be doing that also? Of course, I know amylase lipase is not required, but then these are few risk factors which have been noted, though percentage too less. So,
Pankaj, that was not part of the topic that we discussed, but Sunil wants to know, for the neon point of view, would you like to do a retinal examination and look at the depth?
So NIOS, which has hardly any predisposing finding. When it happens, it happens. It's a rare thing. When it happens, it's a very, very rare. But what Sunil ji is saying is very important. If somebody has hemoglobin A1C of 12.6%, we start them on tirzepatide, it goes to 6%. They may have blindness if they had retinopathy to begin with. That is true for bariatric surgery, that is true for insulin treatment, that is true for dietary treatment. That can, any hemoglobin A1C coming down by 6% will have serious complications, can have serious complications from blindness. They can have acute neuropathy, treatment-induced neuropathy. So there are several conditions that we have to be very careful in doing that. And I'm sorry I answered the question wrong earlier. We do, if the patient is uncontrolled, we do want to control their retinopathy and stable before we put them on something that is highly effective without question. Now, whether gallbladder ultrasound should be done or not, I don't do it as a routine. Whatever there, sometimes we do things because we don't want to get blamed for the problem. So we do it, so that's a different thing. But I don't routinely do ultrasound or CT for the gallbladder before I start.
And alcohol, sir, has already discussed about alcohol. It's really a big problem even in, everywhere in India, I feel. And but there is also one good data, possibly Pankaj must have shared that also, that there's a, if you're starting GLP analog, the withdrawal, the alcohol withdrawal symptoms, they go down, and they actually have a better compliance versus others if you start that. So it's another benefit of the
Good,
drug.
good. I think Sundar will be very happy, Pankaj, because the new chief minister of Chennai, of Tamil Nadu, has closed all the alcohol shops. They have all come to my state now, Pondicherry. All the Tasmac shops, all are closed. And he, yesterday, 1 crore alcohol bottles of various types, from beer to costliest champagne, he just broke those bottles. It was on the TV, you must have seen. He breaking all these bottles and eliminating.
America has been there. we had banned alcohol. Alcoholism did not quite go down.
Exactly. But
So-
Pankaj, I think on behalf of all of us, I thank you profusely, because it's a very common fear in the back of our mind. And you know that, and now we will be giving it more boldly. Of course, we'll have checks and breaks, as you rightly pointed out. But it has been a great strength of knowing that these drugs are not absolutely unsafe. We need not be panic about it. And these are the guidelines. We must ask the questions, but we know today what to do, not to deprive the patient of the great benefit of the molecule. Thank you very much, Pankaj. Over to Sunil.
Yeah, thank you very much. I feel Dr. Pankaj Shah and Dr. Sundar Bhatia. Let's give a wonderful standing ovation to both of them. And if you know, this must be very early morning for Dr. Sundar Bhatia. It must be around 6:30 or 7, very early morning. And that's a so thank you, and even Dr. Pankaj Shah. Let me tell all my delegates and the faculty that both of them are consistent faculty since multiple years. And Sundar Mutlia sir is our international advisor, and he always is there with Hello Diabetes Academia. Sir, we had a wonderful program since yesterday morning. We have almost 1,600 people registered here. Since yesterday, we had already had a footfall of around 1,350 footfalls, and we have tomorrow early morning the International Yoga Day from 7 a.m. in the morning here, and followed by our meeting. And we have JD Con, Juvenile Diabetes Conclave. Dr. Sundar Butlia had already witnessed it once. Which there in another hall, and of course the doctors meeting on the another hall. So that's what we are doing, and we had this time the conference was inaugurated by Dr. Jitendra Singh, who himself is a diabetologist and is a union minister. So we had wonderful meeting with him yesterday. So with these few words, thank you very much once again, sir. Thank you.
Thank you.
Thank you, sir. I request Dr. Sunil Gupta, sir, to kindly felicitate our captains.